Right. So good morning, everyone. Yes. शुरू करते हैं. Very good. Great. Okay. Sure. So let us begin where we stopped yesterday. That now we have understood that how to study medicine. So to study medicine, we have started with the basic approach to physiology. We have understood the symptoms of cardiovascular disease. We understood the assessment methods. We classified the disease, and we are going to start with the individual diseases now. We are going to start with the individual diseases now, and our quest is to become a good cardiologist by end of the day. Okay, so except for doing an angiography, you should be able to do everything possible in our cardiology. So which are the topics that we want to study? For that, let us look at the classification. The topics that we have to study, let us look at the classification. So we want to study the topic of arrhythmia first thing in the morning. So we are going to start that. There is the arrhythmia that we want to study in the first session. After arrhythmias, we are going to take a break, and then we will go on to structural disease, in which we will study rheumatic fever, and then we will do cardiomyopathies, and then we will complete our day with heart failure. Okay, so these are the topics that we want to do, so we could just get it very, very clear. Right. Okay, so let us start with the topic of arrhythmias. The first topic for today morning, that is the topic of arrhythmias. आज क्लास कब तक है? 8 o'clock. Today we will do till 8 o'clock. Right, 9 to 8 है आपका शेड्यूल में, उतना ही करेंगे. Right. So we are going to start with our first topic today, that is arrhythmia. Yesterday when we discussed the topic of palpitation, we already know the definition. Arrhythmias are defined as disorders of rate and or rhythm. So arrhythmias are defined as disorders of rate and or rhythm. Disorders of rate and or rhythm. Right? So this is how we want to continue here. Yes, so arrhythmia definition: disorders of rate and or rhythm. The arrhythmias based on the heart rate. The arrhythmias based on the heart rate are classified into 3 types. Based on the heart rate are classified into 3 types. So arrhythmias based on the heart rate divided into the 3 types. One, we know that when the heart rate is less than 60 beats per minute, we are going to call this as bradyarrhythmia. We are going to call this as bradyarrhythmia. We are going to call this as bradyarrhythmia. Then we have got in the other extreme, we have got the topic when the heart rate is more than 100 beats per minute. We are going to call this as tachyarrhythmia. We are going to talk it as tachyarrhythmia. So we have started today the first topic for the morning. In the first session, we will be reviewing the topic of arrhythmias that you have covered with Dr. Arvind sir. We are just going to do a quick review. We will make simple, concise notes and just to continue this further. Okay, so you just have to follow this. You can take down my notes. You already know my notes of arrhythmia will not be more than 10 to 12 pages. So you can write that extra. So you don't have to ask whether to add or to subtract. You can copy again. So having two set of notes, and then you can decide how you want to integrate the two notes together. So broadly, arrhythmias are classified into 1 bradyarrhythmia, 2 tachyarrhythmia, and here there is the only arrhythmia. This is only for MCQ. The only arrhythmia which can come with a normal heart rate. The only arrhythmia which can come with a normal heart rate. Only arrhythmia which can come with a normal heart rate is the topic of sinus arrhythmia. It is the topic of sinus arrhythmia. So this is just for MCQ. It is physiological, as you can make out from the color. It is a green color. We are talking about sinus arrhythmia. What is sinus arrhythmia? Sinus arrhythmia is just the physiological variation. It is just the physiological variation in the heart rate. Physiological variation in the heart rate with the phases of respiration. With the phases of respiration. It is the physiological variation in the heart rate with the phases of respiration. We can say that. So if you remember yesterday, pulses paradoxes, we understood the physiology that in inspiration, what happens to left side blood flow? During inspiration, what happens to the left side flow? Left side flow becomes less. So during inspiration, the left side gets less blood flow. If the left side gets less blood flow, the stroke volume becomes less. If the stroke volume becomes less, how can we maintain cardiac output? By increase in the heart rate. Remember the physiology. Yesterday we discussed like constrictive pericarditis also. I hope you can understand. I hope you can understand the concept here. That during inspiration, you expect increase in the heart rate. You expect a increase in the heart rate. So arrhythmias are defined as disorders of rate and or rhythm based on the heart rate. There are three types. So stroke volume decreases, heart rate increases. Okay, that is the correlation that we want to see. So this type of arrhythmia is physiological, seen in young anxious adults. It can occur in young anxious adults. They are asymptomatic. It is just a incidental finding on the ECG. It is just a incidental finding on the ECG, and the treatment is reassurance alone. The treatment is reassurance alone. That is all that we want to know. This is the first slide. Based on the heart rate, we have classified the arrhythmias into 3. 1 bradyarrhythmia, 2 tachyarrhythmia, and number 3 is the sinus arrhythmia. Sinus arrhythmia is the only arrhythmia which can come with a normal heart rate, but it is not abnormal. It is a physiological variation of the heart rate with the phases of respiration. We all know that there is increase in heart rate with inspiration. So when a young anxious adult undergoes an ECG, they may hyperventilate and they can have changes in the heart rate. The patient does not have a symptom, but it can be an abnormality detected on the ECG. But since it is physiological, the reassurance alone is the treatment that is needed. Reassurance alone is the treatment that is required. Okay, right everybody, take this column out. So one column we have taken care of, that is the topic of sinus arrhythmia, important for the MCQ. What do you see on the ECG? There will be varying RR interval. The varying RR interval will be seen on the ECG. That will be the finding. The all other parameters are normal. Only abnormality is varying RR interval, okay, is be seen on the ECG. Come on. Now let us classify the other two columns and then discuss them one by one. Under the bradycardia heading, bradycardia, what are the topics? Sinus bradycardia is the most common bradyarrhythmia. Sinus bradycardia is the most common bradyarrhythmia. Followed by, we want to discuss the topic of heart block. So heart block can occur at different levels, but most common site is the AV nodal block. AV nodal block is the most common site, and that is synonymous with the topic of heart block. So under bradyarrhythmia, we are going to review the topic of AV nodal block. We want to study again. We want to review the topic of AV nodal block in this under the heading of bradyarrhythmia. Please remember, this is a review of important points about arrhythmia. You have already covered most of the points, and rather all or more of the points with Arvind sir. So just it is a simple recap to help you remember and integrate the topic. Under tachyarrhythmia, why varying RR? RR interval tells you heart rate. Heart rate is fluctuating. That's why you get varying RR interval. So again, I'm requesting all of you that I requested that you must read the ECG and come of yesterday, because otherwise you might find it difficult to understand. We are writing all this information based on the premise that you know ECG, at least the basics of ECG. Even though you might not have got time to read it, I am sure that Arvind sir has drilled it into your head and you will have the knowledge intact. So try to keep your logic intact. Okay, do not panic. Other side, supraventricular arrhythmias, rather tachyarrhythmias, are classified based on the site of origin. Based on the site of origin into three. Based on the site of origin classified into three. We have got sinus tachycardia, most common tachyarrhythmia. Sinus tachycardia is the most common tachyarrhythmia. Most common tachyarrhythmia, right? So there is going to be supraventricular arrhythmias. There can be supraventricular tachyarrhythmias, and there can be ventricular tachyarrhythmias. Supraventricular and ventricular tachyarrhythmias. These are the 2 points we have to study or revise under the topic of tachyarrhythmias. I want you to discuss. Okay. So please remember, it is not that you have to revise the notes every time. You will be having some residual knowledge from attending that class itself. At least that's why I'm telling you that when you are sitting here and attending the class, please give the time. Okay, please give attention to the class so that you don't have to spend too much time in revision. Most of us faculties ensure that we repeat the topic at least 2 times, 3 times, and we make sure that you reinforce the topics in your head. Okay, so today, first session, we are going to review some basic points about the arrhythmia. Under bradyarrhythmia, we are going to discuss the topic AV nodal block. Under tachyarrhythmia, we are going to review the topic of supraventricular and ventricular tachyarrhythmias. This is the topic we want to revise. So let us start with first AV nodal block. Let us start with the AV nodal block. As you said, we are going to make very concise, simple notes. Okay, we are going to talk about AV nodal block. It is synonymous with heart block. So AV nodal block we want to discuss. It is the most common site of heart block, and you can understand by simple logic that whenever there is a block in the conduction system, you are going to get a decrease in the heart rate. That is why it is classified under the topic of bradyarrhythmia, AV nodal block. So AV nodal block based on the severity of the defect, based on the severity of the conduction defect, is classified into three types. It is classified into three types. The three types are, we can have first degree, use the right colors with me, first degree AV block, use the colors. When we make the ECG illustration also, we can use the same colors. I hope you can start making little more colorful notes. You don't have to come under stressful thing, just have to go with the flow. So we have got the topic of first degree AV block. You can make a relatively small column for first degree AV block. Then we have got the topic of second degree AV block. Make a big column. Second degree AV block. Leave a big column. And we have got the topic of third degree AV block, which is also called as complete heart block. Third degree AV block, which is also called as complete heart block. Okay. So we are discussing the topic of AV nodal block because it is the most common site of the heart block. Based on the severity, it is divided into first degree, second degree and third degree AV block. Third degree is also called as complete heart block. Okay. So let us discuss this further. What is the first degree AV block? The first degree AV block is defined as prolonged PR interval. There is a prolonged PR interval with no missing of the beat. No missing of the beat. So the only abnormality that you get in first degree AV block is that the conduction across the AV node has become slow. That's all. But every impulse from the SA node is conducted to the ventricle. It is conducted to the ventricle. There is no missed beat. The only abnormality is prolonged PR interval with no missing of the beat. The second degree, there has to be missed beat. There has to be missed beat is present. Minimum one missed beat is present. It has to be present, that the conduction is not just slow, but at least one or more impulses from the SA node do not reach the ventricle. Do not reach the ventricle. That is why missed beat is present. Missed beat is present. Okay. In this missed beat, based on the PR interval, further based on the PR interval, they are further subdivided into two. They are further subdivided into two types. Based on the PR interval, they are divided into Mobitz type 1 and the Mobitz type 2. Mobitz type 1 and the Mobitz type 2. In Mobitz type 1, along with the missed beat, there is a varying PR interval. In Mobitz type 2, there is a constant PR interval. There is a constant PR under. Okay. So what we have got here, simply second degree AV block. There has to be presence of missed beat. Presence of missed beat. Based on the PR interval, it can be Mobitz type 1 or Mobitz type 2. Okay, under this third degree AV block or complete heart block is characterized complete, that means no impulse from the atria enters into ventricle. So that means there is a state of AV dissociation. There is a state of AV dissociation. Yesterday we have written canon A wave, canon A wave, AV dissociation will occur because all the impulses from the atria are prevented from entering the ventricle. So ventricle have their own pacemaker, but the rhythm is regular. Though even though there is constant, there is AV dissociation, there is a constant PP, that means atrial rate is constant, and there is a constant RR, ventricular rate is also constant. Ventricular rate is also constant. So first degree, second degree, third degree AV block. So first degree, the conduction has become slow, that's all. In second degree, one or more of the beats are not transmitted to the ventricle, and in third degree, all the beats are stopped from entering the ventricle. This is the definition of the AV nodal block types. Now, what are the causes? Follow our algorithm. What are the causes of first degree AV block? The most common cause of first degree AV block is drug induced. Most common cause of first degree AV block is drug induced. Please remember, all antiarrhythmic drugs are going to, whichever drug which slows the heart rate can cause first degree AV block. Just remember the dictum, all the drugs which reduce the heart rate, can cause first degree AV block, followed by electrolyte imbalance, hyperkalemia, hypokalemia, both can lead to the first degree AV block. Hypomagnesemia can lead to first degree AV block, and number 3, acute rheumatic fever. So if you recall from our own rheumatology class, one of the minor criteria for diagnosis of rheumatic fever was prolonged PR interval on the ECG. So first degree AV block is more commonly drug induced. It can be due to electrolyte imbalance or seen in acute rheumatic fever. Since all the beats are conducted, most commonly they remain asymptomatic. Most common presentation, it is an incidental finding on the ECG. For example, patient is taking beta blocker for their hypertension. You do a routine ECG and you may find first degree AV block. So patient does not have symptom, but it is an incidental finding on the ECG. Hypomagnesemia, right? On the other side, second degree AV block, most common cause is ischemic heart disease. Most common cause is the ischemic heart disease. It can also occur, ischemic heart disease, it can also occur with degenerative heart disease. It can occur with degenerative heart disease. It can occur with infiltrative cardiomyopathy. Infiltrative cardiomyopathy can also cause this symptom. Second degree AV block, because of the presence of the missed beat, can present most common presenting symptom is palpitation. Because of the missed beat. So yesterday you were asking me that how bradyarrhythmia can cause palpitation. Understand the answer today. That even in heart block, when there is a missed beat, the patient feels as if the heart has stopped and started. That is why that also is unpleasant awareness of one's own heartbeat. So that is also called as palpitation. That is also called as palpitation. Third degree AV block, most common cause is degenerative heart disease. Most common cause is degenerative heart disease. Others are all extremely rare. It can occur post procedure like surgery, radiofrequency ablation, post procedure. Rare cause, congenital SLE. Remember rheumatology. When the mother has anti-Rho antibody, remember rheumatology, anti-Rho antibody can cross the placenta and lead to the third degree AV block in the child. Can lead to third degree AV block in the child. Okay, so third degree AV block, in spite of it being most severe, what can we see? Atria and ventricle have a regular heart rate. That is why most common presentation remains asymptomatic. Most common presentation is asymptomatic. Most common presentation is asymptomatic, right? So what we are looking at, the presentation, most common clinical presentation is different with different blocks. But since all of them cause bradyarrhythmia, all of them can present as syncope on exertion. All of them can cause syncopal attack on exertion, because there is no compensatory increase in heart rate. Whenever a person does exertion, the heart rate increases. No compensatory increase in the heart rate is possible because of the heart block, and that is why all of them, if the patient does heavy exertion, can present as syncope on exertion. Can present as syncope on exertion. Okay, again I am telling you, you are all wasting your time in the chat box. For the next 10 minutes, I don't want a single of your stupid comment on the chat box, because you are not focusing on what is in front of you. You are asking what is not there, and I cannot believe it. So if you have a consensus that you don't want to study this arrhythmia again, we can skip this topic and save everybody's time. Okay, so I want complete cooperation. I want all of you to just focus on what is being told. I do not want your answers or your suggestions. Right now, learn what is there in front of you. Okay, extra points may be there, but that's not important right now. What is essential, learn that first. Okay, right, so continue further. So I'm giving you a clear table and you are just wasting your time. That's not fair. So we want to look at this. Clinical features is the most common presentation. So most common is different, but all of them can have syncope on exertion. All of them can have a syncopal attack on exertion. Syncope on exertion. The diagnostic test, gold standard of diagnosis. Arrhythmias, both the screening and the gold standard is the ECG. arrhythmia, the gold standard is the ECG. Yesterday we studied when we wrote about ECG is that ECG, whether we do the best screening test and the gold standard for all the arrhythmias is ECG. Gold standard and diagnostic test is called as ECG. That's what we are having here. So we have got it here that diagnosis is based on ECG. What is the treatment? We will write the treatment first and then we will draw the corresponding ECG. We will write the ECG and then we will focus on the ECG changes. First degree AV block is asymptomatic. So urgently nothing needs to be done. So all you have to do is identify and correct the underlying cause. The type 1 first degree AV block is asymptomatic, incidental finding. So all you have to do is correct the underlying cause. If it is drug induced, try and change the drug. If it is electrolyte imbalance, correct the electrolyte imbalance. That's what we want to do. And number two, only in cases, okay, only in cases which are symptomatic cases, only in symptomatic cases on essential drug therapy, only in symptomatic cases who are on essential drug therapy. Example, patient is taking amiodarone for ventricular tachycardia. Patient is taking amiodarone for ventricular tachycardia. So we will study ventricular tachycardia is a life-threatening arrhythmia. Life-threatening arrhythmia, right? So what we have got here, only in the symptomatic cases, only in the symptomatic cases on essential drug therapy. On essential drug therapy, we need to consider permanent pacemaker implantation. So this is the indication for PPI, that is your permanent pacemaker implantation. PPI, that is your permanent pacemaker implantation. Permanent pacemaker implantation. Okay, so that is indicated. So we are collecting alongside that what are the indications for permanent pacemaker implantation in a patient with AV block. Indications for permanent pacemaker implantation in a patient with AV block we are trying to study. Post procedure means when you do a surgery, cardiac surgery, the fibers can be cut. During valve replacement, fibers can be cut and that can lead to a heart block. Post procedure heart block can occur, right? So this is indication number 1. In second degree AV block, most of them are symptomatic. So you must consider temporary pacemaker. You must consider a temporary pacemaker. And along with that, you will try to correct the cause. You will try to correct the cause. Please remember, because the cause that you have written in second degree AV block, cause can be ischemic heart disease, degenerative. So ischemic heart disease like MI, you can do angioplasty and reverse. But sometimes we may not do the angioplasty immediately. So you will try to correct the cause. But only in cases, refractory cases. Only in refractory cases. Refractory cases or in persistent cases more than 48 hours of treatment. So even after correcting the underlying cause, even after correcting the underlying cause, if the patient has got the second degree AV block, even after correcting the underlying cause, if the problem is persistent after 48 hours, becomes indication for permanent pacemaker implantation. Becomes indication for permanent pacemaker implantation. That's what we want to learn. So in first degree AV block, symptoms are not there. So you correct the cause and that is it. But if you cannot stop the essential drug, then you consider permanent pacemaker. This is amiodarone for ventricular tachycardia. Amiodarone for ventricular tachycardia. In second degree AV block, since the patient is symptomatic, you want to consider temporary pacemaker and you will correct the cause if it is possible. If the patient in refractory cases, okay, now it is 48 hours, previously 72 hours I might have written, so please look, change it to 48 hours. We will persistent, then we consider permanent pacemaker implantation. Okay, please change it to 48 hours. You want to consider permanent pacemaker implantation. Okay, on the third side, third degree AV block, they may be asymptomatic, but irrespective of the symptoms, and the cause, all patients must, in all cases of third degree AV block, all cases of third degree heart block must undergo permanent pacemaker implantation. So we have got a sequential points here. So irrespective of the symptoms, all the cases of third degree AV block must undergo the permanent pacemaker implantation. है ना, टेम्पररी पेसमेकर मीन्स व्हाट, वो आपको वार्ड में सीखना पड़ेगा कुशल गुप्ता, है ना. यू पास अ वायर, टेम्पररी पेसिंग वायर इन थ्रू द इंटरनल जुगुलर एंड पेस द हार्ट फ्रॉम एक्सटर्नल बैटरी, है ना. सो दिस यू हैव टू रीड द प्रोसीजर. मीन्स व्हाट का मतलब गूगल करने का, है ना, अभी, बिकॉज मीन्स व्हाट मीन्स इट इज अ प्रोसीजर. इफ यू हैव नॉट रीच्ड देयर, नो प्रॉब्लम, you just have to understand that. Okay, so go step by step. So this is a simple point here. So what we have got here, I'll show you. So if we zoom out, I'll show you the entire picture so we get the clarity here. Okay, so just look at the whole topic together of AV block. This is the whole topic of AV block in front of you. So all that you need to know about AV block. Please remember, cardioversion is only done for tachyarrhythmia. Cardioversion is a treatment to stop the heart, reset the rhythm, not for bradyarrhythmia, not for bradyarrhythmia. Okay, so look at the simple points that you have to recall. First degree, second degree, third degree AV block. So you have to just look at the definition, causes, clinical feature, diagnosis, treatment and prognosis. That's how we want to study. Okay, that is how we want to study. So it is a simple approach. So under bradyarrhythmia, we have discussed the topic of AV nodal block. We have discussed the topic of AV nodal block. Okay. So what I want you to do, we want to draw the ECG now. Okay, we want to draw the ECG now of them. ECG points we will draw here. So what are the ECG changes that we have got to see in AV nodal block? Let me teach you here. ECG changes in AV nodal block. What are the ECG changes in the AV nodal block? So again, draw a column, simple points, just follow the chart. So AV nodal block, what will be the different ECG changes I want you to follow? For that you want to know first how to depict normal AV nodal conduction. How to depict normal AV node conduction. How to illustrate, you must know normal AV node conduction. How to understand, you must know. So AV nodal conduction. So how to draw this? We have got a P wave followed by the QRS complex. So P wave followed by the QRS complex. The T wave is not absent in the ECG, but I am not a ECG machine. That is why I am not drawing it. Okay, so don't ask that question that T wave nahi hai kya sir? T wave hota hai, but I cannot draw like an ECG machine. I am showing you the points to be noted. The points to be noted. Okay, so now look at this here. So what we have to do? We have to draw it here. You have to draw the ECG. You have to learn how the ECG occurs. You don't have to stick a picture. You will never understand anything. So what we have got? The P wave, R wave, the P wave, R wave, P wave, R wave. Okay. So what we have to look at? Normal AV nodal conduction. To say that AV node conduction is normal, what you have to see? Every P wave is conducted to the R wave. Every P wave is conducted to the R wave. So what we are seeing? That every P is conducted to the R, QRS complex. That means there is no missed beat. So what you can derive? There is no missed beat. You can say that. There is no missed beat. You can say that. Every P wave is followed by the QRS complex. Every P wave is followed by the QRS complex. That means we all know P wave represents atrial depolarization. QRS represents ventricular depolarization. So you can see that if P wave, that is atrial depolarization, is conducted to QRS, ventricular depolarization, that means impulse has traveled from atria to the ventricle, and between the atria and the ventricle there is only one pathway. Between atria and ventricle there are only one pathway, that is across the AV node, across the AV node, and that is why we say no missed beat, no missed beat. Okay, so that is one way, that is anatomical conduction. Physiology, you must see that the PR interval should be constant and normal. The PR interval should be constant and normal. The PR interval should be constant and normal. What is normal PR interval? Normal PR interval is how much? Normal PR interval 0.12 to 0.20 seconds. Normal PR interval should be there. So this is the normal PR interval. That means the conduction time is also normal. That means the conduction time across the AV node is normal. Conduction time across the AV node is also normal. It is also normal, we can say. Okay, so what are the points we have written down here? First, what you have to see in the ECG, I have shown you. When you get the ECG, what you will see in arrhythmia? You will see P wave is present, means sinus rhythm. P wave is present, means it is the P wave, means its sinus rhythm is present. Every P wave is followed by QRS. That means no missed beat. Conduction anatomy is normal. And the PR interval should be constant. as well as normal. It should be constant as well as normal. Very good. Correct PR answers, everybody. So that should be normal. If both these things are present, you can say AV nodal conduction is normal. You can say AV nodal conduction is normal. But let us come to abnormality. First degree AV block. Let us come to the treatment. That is the first degree AV block. First degree AV block. In first degree AV block, the only abnormality is prolonged PR interval. That means the X PR interval is more than 0.20 seconds. But there is no missed beat. So how will you draw this? You will draw like the same point, but just increase the duration of the PR interval. Increase the duration of the PR interval. So you can see, compared to the above ECG, the heart rate has become slow. Heart rate has become comparatively less. In the same rhythm strip, 1, 2, 3, 4, 5 beats were there. Now there are only 1, 2, 3, 4 beats are present. So you will not hear. But what you can see, every P wave is followed by QRS complex. Every P wave is followed by QRS complex. That means there is no missed beat. Every beat is conducted to the QRS. Every beat is conducted. There is no missed beat. The only abnormality is that the prolonged PR interval. The PR interval is prolonged and it is more than normal. That is the only abnormality. Then you can say it is first degree AV block. You can say the patient has got first degree AV block. Patient has got first degree AV block. Come to second degree. Everybody clear till here? Are we clear here? We go on to next. Second degree AV block. Second degree AV block. Second degree AV block. Okay. So arrhythmias we will continue till 12 o'clock, our first session. Those who do not want to attend the arrhythmia can take a break. Okay. So if you are already confident about arrhythmias, you can take a break, but do not disturb this class. Okay. We will focus on what is there. So second degree AV block. Second degree AV block, missed beat is present. Missed beat is present. Missed beat is present. Okay. So missed beat is present. So what are the two types? There is Mobitz type 1 and Mobitz type 2. There is Mobitz type 1 which is characterized by Wenckebach's phenomena. There is the Mobitz type 1 which is characterized by Wenckebach's phenomena. In the Wenckebach's phenomena, what is happening? There is progressive increase in the PR interval. Progressive increase in the PR interval is there with subsequent dropping of the beat. With subsequent dropping of the beat. That's why I told you there is a varying PR. The PR interval is not constant. Every beat has got a different PR interval. Everyone is a varying PR interval is present here. Varying PR interval is present here. Okay, so what we have got here, how to draw Mobitz type 1 Wenckebach's phenomena. Mobitz type 1 Wenckebach's phenomena. Let us see here. So we'll draw like this. P wave is there, small PR interval, QRS complex. P wave, little prolonged PR interval. P wave, more prolonged PR interval. P wave, then there is missed beat, and then the rhythm resets. So we will again get P wave, QRS complex, P wave, QRS complex, and then there is another break in the cycle. So we can see here, if we follow our algorithm, okay, P wave is present, means it is sinus rhythm. Every P wave, we will see, every P wave, is it getting conducted? This has come here, this has got conducted, but this P wave is not getting conducted. This P wave is not getting conducted, and that is why we are having missed beat. Missed beat is present. So other beats are getting conducted. One or more missed beat is present. That is why we call it second degree AV block. Missed beat is present. That is why we call it second degree AV block. After confirming it is second degree, then you see whether it is Mobitz type 1 or not. Then you see. So then you look at the PR interval. What is happening to PR interval? It is X here. It becomes 2X. It becomes 3X. And then there is a drop. The rhythm resets. It becomes X, 2X, 3X, and then there is a drop. Okay. So how we have to know here? So it is a progressive increase in the PR interval with subsequent dropping of the beat. That is called as Wenckebach's phenomenon. This is not 3:1. Anna, don't use such things, please. It is not 3:1. The 2:1, 3:1, these are called as with fixed blocks. Not here. Okay. This is second degree AV block, Mobitz type 1. Second degree AV block, Mobitz type 1, we have to say. Next followed by Mobitz type 2. Anna, then you will understand. Mobitz type 2 has got a constant PR interval. Mobitz type 2 has got a constant PR interval. कल मैंने बताया था ना आपको, where we studied in the abnormal rhythm. Try to recall. What are the causes of abnormal rhythm? Try to recall. Abnormal rhythm में लिखा irregularly regular pulse, fixed second degree, and irregularly irregular with variable second degree AV block. ये क्या होते हैं यहां पर समझेंगे. Are you done with Mobitz type 1? Are we done with Mobitz type 1? Yes. Mobitz type 1 is done. So we will take it forward. Okay. So we have to come here and see here what are the two types of Mobitz type 2. A is the fixed. We will show an example of 2:1 block. Example, we will show 2:1 block. So here what will happen? There is the P wave, there is PR interval, there is P wave, missed beat, P wave, PR interval, P wave, P wave, PR interval, P wave, P wave, PR interval. So this is called as 2:1 block. This is called as 2:1 block. This is a fixed. This is a fixed second degree AV block. Fixed second degree AV block. So this P wave is conducted, this P wave is conducted, this P wave is conducted, but alternate beats are missed. Alternate beats are missed here. Okay, so we cannot get the beat here. There are missed beat. But when you look at this, you can see that the PR interval is constant. Wherever present, the PR interval is constant. So this is called as fixed second degree AV block, Mobitz type 2, and there can also be variable second degree block where the conduction is erratic. After one beat, then after 2 beats, 3 beats, one is conducted. After 2 beats, one is conducted. After one is conducted. So here also you will see missed beat is present. Okay, missed beat is present. Others are conducting, but when you look at the PR interval, it is constant. Wherever present, PR interval is constant. PR interval is constant, but there is no regularity. One is conducted, three are missed. One is conducted, two are missed. Other one is conducted. So they are subtypes of Mobitz type 2 second degree AV block. Second degree AV block. I am again telling you, you have to start from the top. Do not direct make diagnosis. First you see whether missed beat is there. If missed beat is present, you label it as second degree. Then you look at the PR interval. If PR interval is constant, you call it Mobitz type 2. If it is Mobitz type 2, then you will see whether it is fixed or variable. If it is Mobitz type 1, there is no such name. You just call it as Wenckebach's phenomenon. You just call it as Wenckebach's phenomenon. Okay. Finally, we have come to third degree heart block. Third degree heart block or the complete heart block. It is characterized by AV dissociation. It is characterized by AV dissociation is present. But what we said, constant PP. Draw it with me, please. Draw it with me. Be little fast. Come on. So make P wave at regular intervals. First draw P wave at regular intervals, and you will also understand concept of Cannon A wave today. Come on, draw PP interval. There is also constant RR interval. Constant RR interval. But remember, ventricular rate is slower. Ventricular rate is slower than the atrial rate because of the automaticity. Than the atrial rate, it will be slower because of the automaticity. So the QRS complex will come like this. So one QRS complex यहाँ draw कर लिया, one QRS complex यहाँ draw कर लीजिए, one QRS complex will come here. So what you can see, there is no relation. What you can see in the ECG, there is no relation between the P wave and the QRS complex. Between the P wave and the QRS complex. AV dissociation इसको बोलते हैं, AV dissociation. So you can see that here there is the small, okay, there is a QRS is coming after the P wave. Here it is coming before the P wave. Here it is coming before the P wave. That is the problem that we see. This is called as AV dissociation. Okay, everybody note it down. So I am going to answer your questions because I know there are few things that you feel are tricky, but you will learn them along the way when you get the whole picture together. Okay, everybody, is it clear to you? Is it clear? This is the complete topic of AV nodal block with indications for pacemaker. This is the complete topic of AV nodal block with important causes, important indications for pacemaker. Okay, let me show it to you. Okay, here I'll put it together for you. This is our all the ECGs of the complete heart block, all the ECGs of the AV nodal block. Yes, simple, you can see, right? So this is just the simple points you have to remember. This is the simple points that you have to remember. So AV nodal block. है ना. So we have to go from time to time, sir, है ना. So what we have done first is hour of today. In first hour, है ना, QRS is normal, need not be wide. It can be wide, but it is not necessary. Okay, it may be incomplete also. That's not our problem. SLE is not a reversible cause of complete heart block. Please remember, complete heart block is irreversible most of the time. It is irreversible most of the time. So third degree heart block is the complete heart block. On a complete heart block, this is what we have. So just remember these simple parameters here. Normal to abnormal, you want to know. Constant RR means constant ventricular rate is constant. Look at this. This constant RR I am marking. RR means here, this RR to this RR is constant, X and X. So ventricular rate is constant. Ventricular rate is constant. Very good question. Now somebody has asked the right question, that sometimes second degree and third degree can look similar. First degree and second degree can look similar. But to differentiate, you must remember, third degree heart block has no increase in the heart rate after atropine trial. First, second degree and third degree can look similar. To differentiate, you have to give a therapeutic trial with atropine injection. Good question. Atropine injection. After giving atropine injection, third degree heart rate will not increase because atropine increases SA node output, but impulse cannot reach ventricle, does not affect ventricular pacemaker. That's a very good question. Okay, that is a good question. So where is canon A wave? Garba King, Hana Samdo, Baat Samdo. That what you are going to see here, that when the P and the QRS can fuse together sometime. P and the QRS fuse together means what? Atria are also contracting, ventricle are also contracting. When both chambers contract together, that is the time you will get a canon A wave on the JVP. Canon A wave on the JVP, right? So this is the points, right? Okay, so we have completed bradyarrhythmia and sinus arrhythmia. Clear everybody? Let's go on to tachyarrhythmia topic. Let us go on to tachyarrhythmia topic. So tachyarrhythmia, let me show you. First, where we have started today? We have started with our classification of arrhythmia. We have completed the topic AV nodal block, that is bradyarrhythmia complete, sinus arrhythmia complete. Okay. So what we have to look at now? We have to learn about the tachyarrhythmias. Now we have to learn about the tachyarrhythmias. We want to look at, right? So come on, everybody, ready? Tachyarrhythmia is little different from brady. Brady is easy to understand because in bradyarrhythmia, conduction defect is there, leading to reduction in the heart rate. But tachyarrhythmia, why it should become more itself is to understand that why it has become more. Okay, so we want to learn about that. So tell me everybody that how much is your interest? Should we just revise the topic to topic of the tachyarrhythmia, or do you want to understand some physiology, anti-arrhythmic drug? Do you want to understand? Do you want to understand anti-arrhythmic drug physiology, or should we just do notes of arrhythmias? The tip 1, 2, 3, 4 arrhythmias. How should we go about? Come on, put your opinion. Just first 10 opinions will count, right? Then we will take it from there. Chaliye. So should we start with the physiology, mechanism and all that? Mechanism and all that should we know, right? Atropine trial again, है ना? Atropine trial कैसा है? Complete heart block. Listen carefully. Atropine trial. Remember carefully that when you give atropine, it will increase the heart rate. Atropine increase the heart rate. When it increases the heart rate, it should get conducted to the ventricle. But in complete heart block, the heart rate from SA node cannot get conducted to ventricle. So the ventricular rate will not increase even after giving atropine. But in second degree AV block, the heart rate will increase because some impulses will be conducted. Chalo. So let us start here. So I will give you now complete integration of arrhythmias. Okay, complete integration of arrhythmias we will do. Come on, pay attention. So first we have to start with the physiology of cardiac conduction. We have to start with the physiology of the cardiac conduction. We have to go back to first MBBS. To learn physiology of cardiac conduction. Everybody pay attention. This is extremely important. Arrhythmias are a topic which remain confusing. Okay. So today we are going to start with the detail. And antiarrhythmic drugs. Another important problem. We will go all that we will complete today. Right? So let us go fast. So we have got 2 hours to do that. Let us start with 2 hours to do that. Come on. So physiology of cardiac conduction. The heart has got 2 types of cells. They are present in the heart. Okay. So there are 2 types of cells in the heart. So physiology. How does the electrical conduction work? That's the problem. How does electrical conduction work? That's the point. So number A, we have got the impulse producing cells. They are called as the pacemaker cell. Everybody, total attention. I want you to understand. So pacemaker cell. What is pacemaker cell do? Pacemaker cell contains the special slow sodium channels which have the ability to produce impulse. Okay. So it is not going to require stimulation. It can produce the impulse. And this is called as your funny currents, special slow sodium channels which have got the ability to produce an impulse. Question. Where are the pacemaker cells present? Please remember, pacemaker cells are present throughout the heart. They are present in the SA node, they are present in the AV node, they are present in all the areas of the heart. They are scattered in all areas of the heart. So pacemaker cells are present everywhere in the heart, but the SA node automaticity is highest. Automaticity of SA node is highest. Hence it works as the dominant pacemaker. Please remember, works as the dominant pacemaker. That means that every part of the heart has the ability to produce impulse. अभी हमने बात किया ना, if SA node does not work, AV node will start. If AV node does not work, ventricular ectopic will take over. So there will always be there. Okay, there will always be pacemaker activity can be there. But SA node automaticity is highest. सब लोग उसी पे है कि कैनन ए वेव है ना. Right. So we are coming back to this. So what we learn in physiology, there are the slow sodium channels which have got the ability to produce an impulse. So what it is called? They produce the funny currents. They produce the funny currents. They are called as. This production automaticity is regulated by the autonomic tone. It is regulated by the autonomic tone. It is regulated by the autonomic tone. You have to look for. Produce the funny currents, that is called as, and we have to be regulated by autonomic tone. So depending, we all know sympathetic activity increases heart rate. Parasympathetic activity is going to reduce the heart rate. Okay, reduce the heart rate. That's what we want to know. So pacemaker cells are present everywhere. Ability to produce an impulse is there, which produces the funny current. So draw with me electrophysiology. I want you to draw with me electrophysiology of the pacemaker cell. Electrophysiology of the pacemaker cell. Okay. So resting membrane potential of the pacemaker cell is minus 60 millivolt. This is the cell membrane. This is the cell membrane. For the ionic shift to occur, cell membrane for the ionic shift to occur. Please focus here. This is core physiology. We must try to understand. This is always important here. So resting membrane potential of the pacemaker cell. It's an important MCQ. It's an important MCQ to differentiate between pacemaker cell and the conduction cell. It is important. So the resting membrane potential of the pacemaker cell is minus 60 millivolt. Everybody with me, minus 60 millivolt is the resting membrane potential. All of you focus here. So resting membrane potential, what the pacemaker has got? Slow sodium channel. We have got the slow sodium channel which are automatically activated with the ability to produce an impulse. Produce an impulse. No, pacemaking potential is with every cell. That's why we get arrhythmia. No, ventricular ectopic become pacemaker. That's why we get ventricular tachycardia. So there is little confusion. No problem. These are concepts which you must understand here. Now, slow sodium channel increases the resting membrane potential slowly to minus 40 millivolts. Minus 40 millivolts. Once it happens, what opens? Voltage gated calcium channel. Voltage gated fast calcium channels will open up and rapidly depolarize the cell. Rapidly depolarize the cell. It will depolarize the cell to plus 10 millivolt. To plus 10 millivolt. It will depolarize the cell. Depolarize the cell. The outward efflux of potassium restores the cell to resting membrane potential. Restores the cell to resting membrane potential. Please remember, clinically relevant physiology. I want you to understand. So what happens here? The pacemaker cell produce their own impulse. The resting membrane potential is minus 60. The slow sodium positive charge is coming inside the cell. The resting membrane potential comes to minus 40. At minus 40, fast calcium opens and it rapidly depolarizes the cell to plus 10 millivolt. Efflux of potassium restores the cell to resting membrane potential. So this is how the impulse is generated in the pacemaker cell. This is how impulse is produced by the pacemaker cell. Impulse is produced in the pacemaker cell. Everybody clear? First page we are writing, first MBBS, physiology we are writing here. So this is pacemaker cell physiology, pacemaker cell physiology. Go to second page. In the second page, we want to write about conduction cell physiology. We want to write about the conduction cell physiology. So pacemaker cells are there and conducting cells are there. There are pacemaker cells and those which are just conducting cells. Conducting cell do not have the ability to produce an impulse. They don't have ability to produce impulse. They only conduct the impulse from the pacemaker cell. What are the peculiar points? They have lower resting membrane potential due to persistently open potassium channel. Lower resting membrane potential due to persistently open potassium channel. This is difference in the physiology. Persistently open potassium channels, they have lower resting membrane potential due to persistently open potassium channels. Okay, due to open potassium channels. Number 2, these are the cells, they have plateau potential. We will understand what is that meaning. This is for MCQ. They have plateau potential. I will tell you how to remember. Plateau potential will be seen in the conducting cell physiology. Come on here. Now let us go further. So we have to draw conducting cell. Make a big picture. एकदम चिक्कू जैसा मत करो, कंजूस मत बनो, डोंट बी माइसरली. ड्रॉ अ बिग डायग्राम. Draw big diagram because we want to show anti-arrhythmic action also. Okay, so we want to draw again. Write this on a new page. Yes, make big pictures because we want to show pathology also. ये तो आधा है picture, है ना? So we are starting with review of physiology. Review of physiology. Make it big and clear. Okay, so we are drawing conducting cell physiology. Okay, एक बार चलो पेसमेकर लिख दो आप लोग, नहीं तो इधर मेरे को स्ट्रेस देते रहोगे, है ना? पेसमेकर फिजियोलॉजी. रेडी एवरीबॉडी? पेसमेकर सेल, आर वी ओवर? ठीक है, चलो पेसमेकर फिजियोलॉजी डन. आगे चलते हैं टू कंडक्टिंग सेल फिजियोलॉजी. कंडक्टिंग सेल फिजियोलॉजी दे आर, इसमें भी ड्रॉ करिए. कम ऑन, लिटिल फास्ट, मेरे साथ रहिए. मैच माय स्पीड नाउ. वी हैव गॉट यूज्ड टू मी नाउ. You have to match the speed. Come with me, we will learn this together. This is the membrane, cell membrane. This is the cell membrane. Okay, ready? Now what I have written, first line को पढ़ो. The first line को पढ़ो. Persistently open potassium channel. Draw it with me. Persistently open potassium channel के वजह से resting membrane potential is minus 90 millivolt. Resting membrane potential is minus 90 millivolt. Come on. Minus 90 millivolt. So draw with me. Right. So persistently open potassium channel is there. That is why positive charge goes outside the cell. The resting membrane potential is lower than the pacemaker cell. Lower than the pacemaker cell. Now what comes? Impulse from the pacemaker cell. What has come here? Impulse from the pacemaker cell. This green color, it is the impulse from the pacemaker cell. This is the impulse from the pacemaker cell reaches the conducting cell. Pacemaker cell is automatic. Pacemaker cell is automatic. मतलब अपने आप शुरू होता है. Activation happens automatic, which is regulated by autonomic tone. But conducting cell have to be activated. Conducting cell have to be activated by impulse from the pacemaker cell. अब ये cell impulse क्या करता है? Impulse from the pacemaker cell activates the opposite rapid sodium channel. Rapid sodium channel, rapidly depolarizing the cell to plus 40 millivolts. Rapid sodium channel, okay, rapid sodium channel, okay, rapid sodium channel, okay, rapid sodium channel leads to plus 40 millivolts. After that, rapid sodium shuts also immediately. So resting membrane, potassium is going outside, starts coming down. Potassium is always open, so the charge starts coming down. When the charge reaches plus 20 millivolt, who is opening here? The slow calcium channels. The slow calcium channels. Slow calcium channels. Because of which now potassium is going out, calcium is coming in, so charge remains constant. इसको बोलते हैं plateau potential. Because positive is going in also, positive is going down also, out also. That is why this is called as plateau potential. Plateau potential. And then the persistently open potassium channel restore the cell to resting membrane potential. Persistently open potassium channel restore the cell to resting membrane potential. Right? Further, next cell comes, next impulse come from the pacemaker cell. Next impulse comes from the pacemaker cell and the cycle will be repeated. So there will be rapid activation, there will be repolarization, plateau potential and repolarization to resting membrane potential. Then the next impulse will come. Next impulse from the pacemaker cell will come. So pacemaker cell impulses are coming at regular intervals. They come at regular intervals. And this is how the impulse is conducted in the heart. It is conducted in the heart. Okay. So I hope this is extremely clear. Arrhythmias is a topic. Arrhythmias is a topic which is always very scary to the medical students. Okay. So to make sure that you understand, I am starting right from physiology. We will do pathology. We will do pharmacology and then we will do medicine. Okay, everybody. So we have started with the physiology of the conduction system. Conduction system has got two types of cell. One are the pacemaker cell and the conducting cell. नाम बता रहा है, the name tells you pacemaker have ability to automatically produce impulse. Conducting cell will only conduct the impulse from the pacemaker cell and their physiology is different from each other, and that is a common MCQ question. That is a common MCQ question. Okay, this is what we must know. Take it forward. Once you know physiology, you come to second MBBS. In second MBBS, you are told pathology. You are taught the pathology. What are the mechanisms of tachyarrhythmia? You are taught pathology. What are the mechanisms of tachyarrhythmia? What are the mechanisms of the tachyarrhythmia? Mechanisms of tachyarrhythmia. So now we are dealing with pathology. We are dealing with the pathology we want to know. So the defects, so what we have got here, mechanism can be broadly divided into two. There can be there can be defect in impulse production. There can be defect in impulse production. That means where is the problem? In the pacemaker cell. The defect will be in the pacemaker. Or there can be B, defect in impulse propagation. There can be defect in the impulse propagation. Understand and right? Okay, so what we are going to do? Pathology. We are going to write pathology of tachyarrhythmia. Pathology of tachyarrhythmia. So we have got here, either the defect can be in the impulse production. Pacemaker cell is producing impulse fast. That is why heart rate is fast. Tachyarrhythmia. This is the more common mechanism. So between the two, this is the more common mechanism of tachyarrhythmia. And this mechanism is called as enhanced automaticity. This is called as enhanced automaticity of the pacemaker cells. This is called as enhanced automaticity of the pacemaker cell. Mechanism is called. So impulse production. So the pacemaker cell have started producing the impulse faster, and that is why heart rate has become faster. Heart rate has become faster. That is called as enhanced automaticity of the pacemaker cell. Now go back to the physiology. Physiology of pacemaker. Go back to the physiology of the pacemaker cell. So what is the abnormality? Enhanced automaticity. So there can be enhanced automaticity, that is pathology. Now enhanced automaticity can be due to ischemic heart disease, can be degenerative or electrolyte imbalance. Example, causes. So why does the pacemaker become abnormal? Either because of ischemia, or because of old age, or because of electrolyte imbalance. It can become rapid. So the impulse production starts becoming faster. Impulse production starts becoming faster. So you can see in the same time frame, this is all the time frame. So this axis is having time on the axis. So हम क्या compare करते हैं? Instead of having 3 beats, instead of producing only 3 beats, the pacemaker cell is producing 5 impulses. So the heart rate will also increase. Tachyarrhythmia can occur. Heart rate will also increase. Tachyarrhythmia can occur. This mechanism is called as enhanced automaticity of the pacemaker cell. So now you can understand. हम लोग बोलते हैं ना that in IHD patient can get ventricular tachycardia. In old age you can get atrial fibrillation. But ये क्यों होता है? Mechanism enhanced automaticity. Old age के वजह से abnormal pacemaker cell can become faster than the SA node, and that is why they produce arrhythmia. That is why they produce arrhythmia. Understood everybody? This is one of the most common mechanisms for development of tachyarrhythmia. Come to the other column. The other column is the second column, defect of impulse propagation. Defect of impulse propagation. So defect of impulse propagation can be divided into two types. Within the defect of impulse propagation, more common is the re-entry phenomenon. Within this group, more common is the re-entry phenomena. Okay, re-entry phenomena. And the least common mechanism is called as the after depolarization. It is called as the after depolarization. It is the least common mechanism responsible for less than 2% of tachyarrhythmias. Is the mechanism after depolarization. Okay, enhanced automaticity does not mean change in RMP. It is just faster activation. That's all. Faster activation. So impulse production is faster. That's all. Okay. So we have got three mechanisms in all. Most common mechanism, enhanced automaticity of pacemaker cell, that we already understood with the physiology. सेकेंड पॉइंट अंडरस्टैंड करते हैं, री एंट्री फिनोमिना, यहां पर लिखेंगे री एंट्री फिनोमिना is further subdivided. It is classified based on the site. Of re-entry. Into three types. The re-entry phenomena is further classified into three types based on the site of re-entry. So what are the points? Make a chart with me. So we have got right atrium, right ventricle, left atrium, left ventricle. Okay, how is the conduction system? We have got the SA node. Impulse from the SA node conducts to the AV node. Through the bundle of His, it enters into the ventricle. Bundle of His divides into two, right bundle branch and the left bundle branch, which terminates in the ventricle. So the re-entry phenomena is classified further based on the site of re-entry into three types. So normal impulse कैसे आना चाहिए? Normally impulse from the SA node reaches the AV node. From the AV node, it goes through bundle of His. It passes through the right bundle, left bundle, and terminates in the ventricle. This is normal conduction pathway. Everybody, this is the normal conduction pathway that occurs. Re-entry circuit, they are abnormal. They can be formed at different places. One of the re-entry circuit can be within the atria itself. Number one, within the atria, it is called as atrial tachycardia. It can cause atrial tachycardia, but it is rare, not common. So if there is abnormal re-entry circuit within the atria, it can lead to atrial tachycardia, but it is uncommon. Most common site of re-entry is the AV node. most common site of re-entry is the number 2 AV node. AV nodal re-entry tachycardia. It is the AV nodal re-entry tachycardia. It causes tachycardia. This is the most common and it is responsible for 60 to 65% cases of PSVT, paroxysmal supraventricular tachycardia. It is responsible for 60 to 65% cases of PSVT. Third possibility, there can be re-entry circuit, aberrant pathway in the connecting the ventricle and the atria, which allows the backward conduction, allows the retrograde conduction, and this circuit will become continuously active. This is the third circuit. This is presence of abnormal pathway, AVRT, atrioventricular re-entry tachycardia, atrioventricular re-entry tachycardia, which is seen in 5 to 10% of WPW syndrome. 5 to 10% of WPW syndrome, when the accessory pathway, WPW has accessory pathway, allows retrograde conduction. It allows retrograde conduction. Okay, so WPW syndrome, you have know that there is accessory pathway connecting the atria with the ventricle. If the connection allows retrograde conduction, then there can be re-entry of the impulse from the ventricle back into the atria. This type is called as AVRT. This type is called as AVRT. Understood? This is called as re-entry phenomena. समझ के लिखना. Okay, so understand the point here. So one mechanism we thought कि pacemaker ही abnormal, fast production, or pacemaker was normal, but there is abnormal conduction due to formation of re-entry circuit in the heart. So there is impulse propagation defect. There is an impulse propagation defect due to abnormal re-entry circuit in the heart. That is another mechanism of our tachyarrhythmia. That is the another mechanism of tachyarrhythmia. Coming to the number 3, least common mechanism is after depolarization. Least common mechanism is after depolarization. But उसको समझने के लिए we have to welcome our third MBBS subject. The third MBBS subject is pharmacology, anti-arrhythmic drugs. To understand after depolarization, we are going to welcome our third MBBS subject, that is pharmacology. Okay, so we have got here, that is first we studied physiology, we understood the mechanisms. Now we want to understand the pharmacology, anti-arrhythmic drug. So we know anti-arrhythmic drugs, we use William Vaughan classification. For anti-arrhythmic drugs, we use William Vaughan classification, and they are broadly divided into 5 classes. They are classified into the 5 classes here. Okay, so atrial tachycardia. So William Vaughan classification. Okay, yeah, second year subject, but the third subject I mean to say, like we did physiology, we are reviewing pathology. Now we are going to review our anti-arrhythmic drugs. We are going to review anti-arrhythmic drugs. Okay, we will go back to last slide, है ना? So don't panic, इतना मत करो, है ना? Re-entry phenomena, we have just written that much. ओके चलिए, सो इट इज ओके, इट मे बी 4 क्लासेस, है ना? जो मॉडर्न है फार्मेकोलॉजी में उसको फॉलो करेंगे, बट व्हाट आई वांट टू एम्फसाइज इज द क्लिनिकल इंटरप्रिटेशन. ओके, क्लिनिकल इंटरप्रिटेशन, डोंट गेट स्ट्रेस्ड. सो व्हाट आई वांट टू डू, वी आर गोइंग टू रीड एंटी-arrhythmic ड्रग्स फ्रॉम द मेडिकल पर्सपेक्टिव. पे अटेंशन, we are going to learn the medical perspective here. William Vaughan classification, how it's working. So what we want to know, which are the drugs used in the emergency management. Let us classify which are the drugs used in the emergency treatment of tachyarrhythmias. Okay, we are going to understand what the totally different concept here. We are going to understand it in a proper way. Okay, so make tables with me, come on, थोड़ा सा fast हो जाइए. Okay, so let us take it faster now. So drugs used in the emergency management of tachyarrhythmia, we want to understand. Drugs used in the emergency management of tachyarrhythmia, we want to understand. Okay everybody, let us try to get this very clear, that we have got the mechanisms of tachyarrhythmia. It is either because pacemaker is sending fast impulse, or there is going to be re-entry phenomena. So in emergency we may not be able to understand the mechanism. So you want to prescribe broad spectrum. You want to prescribe broad spectrum anti-arrhythmic drugs which will control the heart rate, irrespective of mechanism. So emergency में we may not be able to know what is the mechanism. So we want to prescribe those broad spectrum anti-arrhythmic drug which are going to control the heart rate, control the heart rate irrespective of mechanism. Okay, irrespective of the mechanism, that is the drug we want to give in emergency. So let's understand the concept here. Very simple. Though understand the concept here, that what it is there. Okay, so what we want to look at is very simple, that go back to the our chart, physiology of conducting cell. Open physiology of conducting cell, page in front, come on, physiology of conducting cell. Now look at the answer, what do we do to reduce the heart rate? So suppose the impulse from pacemaker has become enhanced. How can we control the heart rate? We want to reduce the conducting cell. We want to slow the conduction in the heart. है ना? ध्यान से सुनिए story. Listen to this story carefully. How can we slow down a fast person? How can we slow down a fast person? Either you delay his start, or you prolong his distance. Okay, either you delay his start or you want to prolong his distance. Okay, so in cardiac context, what we will say, we want to delay the depolarization or prolong the repolarization. So just understand concept, very simple, logical. How can I slow the heart rate? By making the activation, depolarization late, or by prolonging the repolarization, making the time for repolarization longer. The ions are in front of you. You don't have to memorize. Ions are in front of you. What you want to do? Depolarization. Who does depolarization? Who does the depolarization? Rapid sodium. है ना? Block कर देते हैं. So what is the first class 1 antiarrhythmic drug? Is the sodium channel blocker. Mark it in color. Different colors we will use. So class 1 antiarrhythmic drug is the sodium channel blocker. So if I give sodium channel blocker, okay, sodium channel blocker, if you give, what will happen? The depolarization will take longer. The depolarization will take longer. Instead of getting active here, depolarization will get longer. Rest of the process will be same. Rest of the process will be same. Okay, rest of the process will be the same. But what you have done? Delayed the depolarization. By giving sodium channel blocker, you are delaying the depolarization. Delay the depolarization. Okay, so rest of the process remains constant. So write it down in the mechanism table. Write it down. So what you are doing in antiarrhythmic agent, in emergency, I can prescribe class 1 agents, that is sodium channel blockers. I can prescribe class 1 agent, sodium channel blocker. What do? They just do delay the depolarization. What they do? They delay the depolarization. This is for your understanding. Delay the depolarization. How can I prolong the repolarization? Prolong the repolarization. I have got potassium channel blocker. I have got potassium repolarizing ion. I block it. So I am giving potassium channel blocker. I am giving potassium channel blocker, class 3 antiarrhythmic agent. We have got here potassium channel, class 3 antiarrhythmic. What it will do? Depolarization will occur on time. Sodium is normal. Depolarization occurs on time. But the positive charge remains for longer. The cell remains positive for longer. Cell remains positive for longer. And that is what you have done. So we are giving this the potassium channel blocker mechanism. Potassium channel blocker mechanism we have written. So when you give potassium channel blocker, you are prolonging the repolarization. Prolonging the repolarization. But either of these classes, what are they doing? They are increasing the effective refractory period. Mechanism of action. What is mechanism? They increase the effective refractory period. They increase the effective refractory period. They increase the effective refractory period. They can increase. Okay, effective refractory period we can increase. Okay, and that is how we control the heart rate. That is how we control the heart rate. Because the impulse from the pacemaker will reach the cell when it is already in a depolarized state. So the cell will not respond to the impulse. the cell will not respond to the impulse, and that is why it goes into a refractory period. It goes into a type of refractory period. That is what we call as increase in effective refractory period. Now, if you increase effective refractory period, that is how you increase the heart rate. So, in emergency, we can give class 1 and class 3. Class 1 and class 3 because it prolongs the repolarization. It will prolong the repolarization. It will prolong. And that is how, by increasing the ERP, they control the heart rate irrespective of the mechanism. They will control the heart rate irrespective of the mechanism. So whichever drug I give in emergency, effect is the end point. It controls the heart rate by increasing effective refractory period. It controls the heart rate by increasing effective refractory period. It is going to happen. This is going to happen, right? So now let us name the drugs. In the class 1, it is further divided into class 1A, which are most potent and hence most preferred in emergency. The class 1 are most potent within this class. They are most potent and preferred in the emergency. So which are the drugs in class 1A? We have procainamide and quinidine. We have got 1B, which is the weakest and hence not in emergency. No emergency use. Remember this for MCQ. Not for emergency use. Lidocaine and maxilatin. Are no longer indicated in emergency. Class 1C has moderate efficacy. The drug is flecainide. So, if you want to give in emergency, you want to prescribe class 1 agent or class 3 agent. Among the class 1 agent, if I have to give, I will give class 1A because they are most potent. 1B no longer in emergency because it is weakest. 1C is moderate, we can use if there is no choice. But for MCQ and practice, most preferred agent in emergency is now amiodarone. Why amiodarone is the most preferred agent in emergency management? Answer: it is most preferred agent in the overall because it has additional class 1 action also and relatively safe. It is relatively safe compared to class 1A. Relatively safe. That is why it has now become single best choice. Other agent in the group, we have got sotalol. As the name says, it is called sotalol because it has got additional beta blocker action. It is called sotalol because it has got additional beta blocker action. And we have got ibutylide for MCQ. Ibutylide has got the best success rate. best success rate in reversing atrial fibrillation. It has got the best success rate in reversing atrial fibrillation. That is our answer here. So understand and write. Broad spectrum means irrespective of mechanism. हम बोलते हैं ना broad spectrum antibiotic means any bacteria it will kill. Like that, any mechanism it will control the heart rate. Any mechanism it will control the heart rate. Now you can see the similarity. 1 and 3 work similar. That is why the common dreaded adverse drug reaction. That is why the common dreaded adverse drug reaction is the increased risk of after depolarization. There is the risk of after depolarization. Common side effect. There is the risk of after depolarization. Increased risk of after depolarization. Our third mechanism. And that is why they are associated with. That is why they are associated with increased risk of torsades points. We learn in MCQ. It is with the increased risk of torsades points. Torsades points. That is our correct answer. Okay, please remember, common dreaded adverse drug reaction. Common dreaded adverse drug reaction. It is a risk of after depolarization. After depolarization, because it is associated with risk of torsades point. So let us draw this after depolarization on our chart. Understand and write, please. So pathology of conducting cell. You are giving the antiarrhythmic to control. But here what can happen? It can cause after depolarization. So the cell gets activated without reaching repolarization. This is called as after depolarization. This is called as after depolarization. This is called as after depolarization. So when the cell is activated before the repolarization, cell is activated before the repolarization. That is why the mechanism is called as after depolarization. So it is basically adverse drug reaction of class 1A and class 3 antiarrhythmic drugs. It is basically adverse drug reaction of class 1A and class 3 antiarrhythmic agent. Okay, so within the class 1A, but overall most preferred in emergency is amiodarone. Listen carefully, I am telling that within the class 1A and overall best single answer is amiodarone. This is your third mechanism. This is this third mechanism. I have explained. After depolarization means the cell, the impulse sometimes activates the cell even before the repolarization. It is abnormality. Why mat pucho? This is the mechanism. Mechanism means abnormality. When such thing happens, it is called as after depolarization. We have written it is a rare mechanism. It is a rare mechanism. Yes, it can get activated in relative refractory period. That is why it is a complication. It is a complication of antiarrhythmic therapy. Okay, so this is our mechanisms we have studied after depolarization. Antiarrhythmic drugs in emergency we have studied. Let's go to the next one. After emergency, we want to know which are the drugs for chronic prophylaxis. So which are the agents for chronic prophylaxis? So which are the agents used for chronic prophylaxis? Agents used for chronic prophylaxis. In arrhythmias, we want to understand chronic prophylaxis in arrhythmia. So here we have got next two, even class याद रखना, class 2 antiarrhythmic drug beta blocker, and we have got class 4 non-dihydropyridine group of calcium channel blockers. Okay, so we have got agents used for the chronic prophylaxis. So chronic prophylaxis we can give class 2 beta blocker, class 4 non-dihydropyridine calcium channel blocker. Again, common adverse drug reaction, both have got negative inotropic action. They have negative inotropic action and hence associated with increased risk of hypotension in a patient with impaired LV function, in a case of LV dysfunction. So when the patient is having LV dysfunction, you must take care while using these agents. Because they can cause risk of hypotension. But if you look at the survival benefit in LV dysfunction. The class 2 beta blocker has survival benefit. And that is why can be used with caution. So even in LV dysfunction, we can give beta blocker because it offers survival benefit in a patient of LV dysfunction. But calcium channel blocker has no survival benefit and hence contraindicated in presence of LV dysfunction. Contraindicated in a case of LV dysfunction. You will not prescribe this agent. So when the patient has got LV dysfunction, calcium channel blockers are contraindicated. We can say. And finally, the class 5 or the miscellaneous agents. These have got the specific indications. They have got specific indications for use. They are not used routinely. Okay, so what we want to see, class 5, which are the agents and what is the specific indication for use. So class 5 we have got IV adenosine. Adenosine is the drug of choice for PSVT. We have IV magnesium sulfate, drug of choice for torsades de pointes. And we have got IV digoxin. We use it only for atrial fibrillation with heart failure. What is the advantage of digoxin? Digoxin is the only anti-arrhythmic drug. It is the only anti-arrhythmic drug with positive inotropic action. It is the only anti-arrhythmic drug with positive inotropic action. These are our miscellaneous agents. Okay, so just keep the tables, Anna. So the questions that you are asking are very difficult to answer because the questions are only not there, Anna. Chaliye, okay, ready everybody? So this is where we are. We have taken care of physiology, pathology, and the anti-arrhythmic drugs. Anna? So we have done physiology, pathology, and anti-arrhythmic drugs. Now we are ready to start medicine. Now we are ready to start with the medicine. So let us start with classification of tachyarrhythmias. Let us start with the classification of the tachyarrhythmias. Okay. So note it, whoever has missed, just write it down and then we will go ahead. Okay. Right. Okay. Chaliye. So let us continue with the classification of arrhythmias. So if you have already done that, we will see, we will classify, just do a review of the quick points to complete our session. Chaliye. So we reach the classification of the tachyarrhythmias. Okay, classification of the tachyarrhythmia. Classification of the tachyarrhythmia. So tachyarrhythmias are divided into two types based on the QRS complex. Based on the QRS morphology. Based on the QRS morphology into two. QRS morphology into two. If the patient has narrow QRS complex or the patient has got a broad QRS complex. Narrow QRS complex or the patient has got a broad QRS complex. Patient has got broad QRS complex. We divide the tachyarrhythmias into the two. So narrow QRS means the patient is having supraventricular tachyarrhythmia. Means there is a supraventricular origin. Broad QRS means ventricular origin tachyarrhythmia. So go back to the classification table. We have written it can be supraventricular or ventricular origin tachyarrhythmia. So we have got here that based on narrow QRS means problem is supraventricular. Broad QRS means problem is ventricular origin tachyarrhythmia. Is the ventricular origin tachyarrhythmias we want to know, right? So how to approach this table? Learn the approach. So if you get narrow QRS complex tachyarrhythmia, see whether the patient has regular RR interval or the patient has irregular RR interval. So it's an approach table. It is an approach table. Approach table. So we have regular RR interval and irregular RR interval. If the patient has regular RR interval, the diagnosis is PSVT. So supraventricular tachycardia. So you can describe the whole PSVT. Patient is narrow QRS complex tachycardia with regular RR interval. With regular RR interval. If it is irregular RR, then there are two possibilities. Irregular RR has got two possibilities. Irregular RR interval is present with the presence of three or more different P wave morphology. Three or more different P wave morphology. Or there is a absent P wave, or there is a absent P wave. What is the diagnosis? All of you know, absent P wave means atrial fibrillation. Absent P wave means the patient is having atrial fibrillation. But more than three different P wave is the diagnosis of MAT, multifocal atrial tachycardia. Multifocal atrial tachycardia, which is also called as wandering pacemaker syndrome. It is also called as wandering pacemaker syndrome. It is also called as wandering pacemaker syndrome. It is also called as. Okay, write the simple classification. We have to write the simple classification here. So narrow QRS complex है ना. So normal finding ही है बेटा है ना. Normal ही है. Normal is narrow. Just to differentiate between the two, whether the problem is above the AV node or below the AV node. है ना. Everything you don't have to understand. है ना. Try to understand your best. But some points are complex with very low yield. That's why those points understand the flow chart. That's all you have to do. So narrow QRS complex tachycardia is there. Regular RR means PSVT. Irregular RR with absent P means AFib. Irregular RR with three or more P wave means MAT. Multifocal atrial tachycardia, we can say. Same side, other side you want to classify. Ventricular origin. Instead of RR, look at the QRS now. This is a regular RR interval, or there is a irregular RR interval. Same concept. Same concept you have to follow. Irregular RR means this is ventricular tachycardia. Broad QRS with a regular RR is ventricular tachycardia. Is the ventricular tachycardia. The ventricular tachycardia. But if it is irregular, there are again two possibilities. Irregular, three or more different QRS morphology. Three or more different QRS morphology. This is called as polymorphic ventricular tachycardia. Polymorphic ventricular tachycardia. Polymorphic ventricular tachycardia, which is also known as torsade de points. Also known as torsade de points. And if you have hello, बोलिए. Okay, unidentifiable QRS complex is ventricular fibrillation. Okay, so we have got here yes please. So just follow the chart here, just follow the chart. Yes, so what we have got, look at this chart here, simple. So patient has, based on whether it is narrow QRS or broad QRS. Okay, so this is the whole table in front of you, the whole classification of tachyarrhythmia in front of you. Okay, so we just have to see here that how to approach the arrhythmias. Okay, so my whole point today was not to actually teach the details of each arrhythmia that you have covered with Arvind sir. It is just to teach you an approach which is a separate one from the ECG arrhythmia, just to connect the whole topic together. So we have to just look at the whole concept here. So there are 6 tachyarrhythmia points that we would want to discuss, So how to approach? When you get a tachyarrhythmia, first you see whether it is sinus tachycardia. If it is not sinus tachycardia, then you look at the QRS morphology. Narrow QRS morphology means supraventricular. Broad QRS means it is ventricular origin. We want to know. If it is supraventricular or ventricular, first you will see whether it is regular RR or irregular RR. Regular RR, if it is irregular RR, we want to see whether P wave is present, QRS is present, or there are 3 or more different P wave, 3 or more different QRS complex. Okay, 3 or more different QRS complex. So this is our diagnosis. Right, so we continue with this point here. Right, so what we have got here, the 6 different topics to understand. So just we have to do one page each. So 1 page each for each of the 6 topics and we are done. 1 page each for 6 of the topics and we are done. Chalo. So let us take it one by one. So we have got 6 topics to do. PSVT, atrial fibrillation, multifocal tachycardia, ventricular tachycardia, ventricular fibrillation, ventricular torsades points, whichever order, 5 and 6 we will do. So we just do 6. Atrial flutter fibrillation management is the same. Okay, flutter management is the same. So we don't have to focus on anything else. Just we have to follow this chart and we have to know that we have to see 6 of the arrhythmias. Okay, so let us start one by one. First one, PSVT. So I hope you remember our order is very simple, from definition to prognosis. That's all. We have to follow the chart. From definition to prognosis we want to follow. That's all. So paroxysmal supraventricular tachycardia, remember, for MCQ is the only tachyarrhythmia which is more common in female gender. This is the only tachyarrhythmia which is more common in females. Typically affects middle age. That's all. 1 page each that you want to know about each of the arrhythmia. So PSVT is the only tachyarrhythmia which is more common in the females, 30 to 50 years. What is the most common mechanism? Read clearly. Most common mechanism involved in PSVT is the re-entry phenomenon. Most common mechanism is the re-entry phenomenon, and the most common type is the AVNRT, is most common site of re-entry, is the most common site of re-entry. Okay, so we have got here most common mechanism, re-entry phenomena, among which the most common site of re-entry is the AV node. Already we have discussed this. So it is the re-entry phenomena, we can say. Now, what are the causes or the risk factors associated with PSVT? What are the risk factors associated with PSVT? Risk factors include stress. Risk factor include alcohol consumption. And we have got WPW syndrome. We have got here the WPW syndrome. We have got risk factor infiltrative cardiomyopathy. Okay, so stress, alcohol, WPW syndrome, infiltrative cardiomyopathy are risk factors for development of PSVT. How do they present? Clinical feature. How do they present? They present as episodic palpitation. Most common presentation, followed by diuresis. So the typical symptom is episodic palpitation followed by diuresis, which is due to ANP release, atrial natriuretic peptide. So presentation of PSVT, middle-aged female presents with episodes of palpitation, typically followed by diuresis due to release of atrial natriuretic peptide. The important point about the diagnosis, if you record ECG when the patient is asymptomatic, it may be normal, and that is why what can happen here, we have discussed yesterday, can be confused with anxiety, panic attack, or panic attacks, because resting ECG can be normal. On the ECG, but ECG during the episode is the gold standard of diagnosis. And what will we see? Just to replace the index, it is a narrow QRS complex tachycardia with regular RR interval. Just index को याद करना है ना? You have to just follow classification of the arrhythmia. That's all. So during the episode, if you can get an ECG and if you find narrow QRS complex tachycardia with regular RR interval, that is confirmatory of the disease. The management is very important. Okay, the treatment of PSVT is very important, commonly asked in exam. How do you manage treatment of acute PSVT? Very important. Management of acute PSVT, very important. First step, you have to see whether the patient is stable or not. So whether the patient is hemodynamically stable. Patient is hemodynamically stable more commonly. Majority patients are stable. Rarely the patient is in shock. Rarely the patient is in shock. You also shock. The treatment is cardioversion. Remember the dictum in cardiology. In tachyarrhythmia, patient is in shock, you also shock. Patient is in shock, you also shock. First line will be cardioversion, but that is not common. First line treatment, if the patient is in shock with PSVT, the treatment is cardioversion. But if the patient is hemodynamically stable, the first line of treatment is vagal maneuver. First line of treatment is vagal maneuver, is the first line treatment because it has got 85% success rate. It has got 85% success rate. Read the question carefully. Vagal maneuver, what you do? External carotid massage. You give external carotid massage. External carotid massage, first line treatment. So if the person is stable and the patient has PSVT, first you will try for external carotid massage. If external carotid massage does not work, then you give the drug of choice, that is IV adenosine. IV adenosine, maximum 3 doses. You can repeat maximum 3 doses. But before you give adenosine, you must rule out the absolute contraindication. The absolute contraindication of adenosine is bronchial asthma. Absolute contraindication is bronchial asthma. So first you will try carotid massage. If carotid massage does not work, you will give adenosine injection. If adenosine also does not work or it is contraindicated, does not work or contraindicated, then what you do? You start the patient on anti-arrhythmic drugs. Which one can you give? Class 1 and class 3 agents can be prescribed except 1B. Except 1B, no longer approved for emergency. So you can use class 1 and class 3 agents except for class 1B. Except for class 1B. And if it is not controlled, you proceed for cardioversion. If it is not controlled, you proceed for cardioversion. Proceed for cardioversion. That's what you want to do. So this is acute management. Verapamil is for chronic prophylaxis, not for acute. Not for acute. We are talking about acute PSVT. Don't get confused. For chronic prophylaxis, after the acute attack is over, you can give class 2 and class 4 agents. That's why we first studied anti-arrhythmic drug. Now it is easy. Once you know anti-arrhythmic drug, it becomes easy to understand the treatment protocol. Okay, so chronic prophylaxis, you want to give class 2, class 4 agents. But please remember, medical treatment, medical therapy is only palliative, not a cure. It is only palliative. What is potential cure then? The potential cure, which is same as the best long-term treatment. MCQ, best long-term treatment. Best long-term treatment. Best long-term treatment is to go for radio frequency ablation. Is to go for radio frequency ablation, RFA, radio frequency ablation of the aberrant or accessory pathway causing re-entry. So that re-entry circuit we want to stop. Okay, re-entry circuit we want to stop. Okay, so radio frequency ablation is the best long-term treatment for the patient of PSVT. So what is the prognosis? The prognosis is good with treatment. Prognosis is good with treatment. Acute mortality is uncommon. Acute mortality is uncommon. Okay, it is uncommon. So for prevention, we can give beta blocker. For acute attack, chronic attack, we have written the two things. Okay, this is how we have got here. Carotid massage, how does it work? I have written no, vagal stimulation. Vagal stimulation, that's what we have written. Okay, so 6 milligram adenosine, okay, 12 milligram, 12 milligram. Adenosine 3 doses, 6 milligram, 12 milligram, 12 milligram. That's it. You cannot repeat anymore. This is your first arrhythmia done. First arrhythmia done. This is what our PSVT. एक quick points है. कुछ भी difficult नहीं है ना. Arrhythmias are easy once you get your concepts clear. So that's all we had to do. PSVT. We have written everything about PSVT. Right from the definition, epidemiology, mechanism, risk factor, presentation, treatment and prognosis. Aberrant pathway is located by EP studies, electrophysiological study you have to do. EP study, electrophysiological study has to be done to detect aberrant pathway. To detect the aberrant pathway, you have to perform electrophysiological study. Okay, that is the procedure that you want to remember. So this is about paroxysmal supraventricular is the answer, right? So simple here, there is no problem here. Next one, let us go. Are what is given for asthma? Why are you asking this question? The next choice, if not adenosine, a patient has asthma, I will give amiodarone. That is common sense, no? I will give the next agent, correct? You have to give the next agent. That's what you have to go for. Chalo. Next one, multifocal atrial tachycardia. Are full algorithm I have given you. You are still asking the same question. Multifocal atrial tachycardia, also called as wandering pacemaker syndrome. Multifocal atrial tachycardia, also called as wandering pacemaker syndrome. Wandering pacemaker syndrome, multifocal atrial tachycardia. This tachycardia is common among elderly patient in the ICU. It is common among elderly patient in the ICU. Okay, so we have got here that we have got that common among elderly patients in ICU. Why? So what we have got here, The why? Because the risk factor. The risk factor is severe sepsis, severe COPD, severe sepsis or severe COPD, chronic obstructive lung disease. Chronic obstructive lung disease. What is the pathology? What is the pathology? Increase in the cytokine cause hyperexcitability of the pacemaker cells, and that is why different pacemaker cell take over the rhythm. Okay, take over the rhythm. So what we have got here, that why it is common in ICU, because ICU we can see sepsis or COPD, because of which increased cytokine can cause hyperexcitability of pacemaker cells, of the pacemaker cells. So that is why you call it as wandering pacemaker syndrome. That's why you call it as wandering pacemaker syndrome. How does it present? Presents as palpitation. Remember, important for MCQ, never causes hypotension. It never causes hypotension. Multifocal atrial tachycardia can never cause hypotension by itself. Can never cause hypotension by itself. Right? So diagnosis comes from ECG. Diagnosis comes from ECG, is the gold standard. What do you see? Take from the index. Narrow QRS complex, tachycardia with irregular heart rate. Irregular heart rate. But 3 or more different P wave morphology. 3 or more different P wave morphology can be seen on the ECG. Can be seen on the ECG. More than equal to 3 different P wave morphology is seen on the ECG. This is your multifocal atrial tachycardia. That's why called multifocal atrial tachycardia. Okay, multifocal atrial tachycardia. What is the treatment? You have to correct the underlying cause. You have to correct the underlying cause. Heart is not the problem. Cytokine is the problem. You have to correct the underlying cause. Since it never causes hypotension, there is no role of cardioversion. Since it never causes hypotension, there is no role of cardioversion in MAT. So prognosis depends on the cause. MAT does not kill. The cause can kill. Septic shock can kill you, but MAT does not kill. MAT does not kill. Okay, I will show you the pictures. Okay, I will show you the pictures of all this arrhythmia back to back. I will show you. Okay, so don't worry. First we will take down, then we will do the back to back revision of the same points. Okay, supraventricular, ventricular. I will show you all the arrhythmias. I will show you all the arrhythmias. I can share with that. I will share it on the Facebook also today. Right? So first we will complete, then we will review the ECG. So this is multifocal atrial tachycardia. Okay, चलो atrial fibrillation पर आते हैं. Third, supraventricular atrial fibrillation. So atrial fibrillation has bimodal distribution. More commonly presents in elderly. More commonly presents in elderly. more commonly presents in elderly, but they can also present in young adults, 20 to 30 years also, males more than females. So the presentation, you can see more common in elderly. Why? Because of the risk factor. Most common risk factor is degenerative heart disease. Most common risk factor is degenerative heart disease. Okay, degenerative heart disease. Degenerative heart disease, followed by, in young, it is the structural heart disease. Most common, especially mitral stenosis. So next session we are going to start with mitral stenosis. Next session we are going to start with the mitral stenosis. So remember, okay, so remember the points. So this is the risk factor, but in elderly you must exclude thyrotoxicosis. You must exclude thyrotoxicosis. So for MCQ, thyroid function test is mandatory. So risk factor is there, but you must exclude in the elderly person with AFib. Before you say it is age related, you must exclude thyrotoxicosis. Thyroid function test is mandatory. In young patient, you must look for holiday heart syndrome. You must look for holiday heart syndrome, which occurs due to alcohol binge. You must look for holiday heart syndrome, that is your alcohol binge. Most common arrhythmia is the atrial fibrillation. It can also cause PSVT. So that's why alcohol as a risk factor you have written under both. Alcohol can be risk factor for both PSVT and atrial fibrillation. Alcohol is risk factor for both PSVT and atrial fibrillation. How do they present? Clinical feature. Clinical feature, you have to start, patient can come with palpitation. Patient can come with hypotension. Palpitation or hypotension, patient can come with. Palpitation or hypotension, patient can come with. Okay, ECG is the gold standard of diagnosis. Please remember, atrial flutter versus atrial fibrillation. There is difference only in the heart rate. Flutter means heart rate, that is atrial rate, is more than 220 to 350. In atrial fibrillation means more than 350. All rest is same. Rest is same. So no need to teach it separately. It is one and the same only. The causes are the same. Presentation is the same. Treatment is the same. Only heart rate is different. Heart rate is different. So how do you manage? So in acute attack of AFib also, acute attack of AFib comes to you. What do you see again? Whether the patient is hemodynamically stable or the patient is in shock. Patient is hemodynamically stable or the patient is in shock. You have to consider. You have to consider thyroid function test, TFT, thyroid function test, because thyrotoxicosis also can cause atrial fibrillation in elderly. You must exclude that. In hemodynamically unstable, the treatment is cardioversion. the treatment is cardioversion. But majority times patient is stable. In majority, more common, patient is stable. If patient is stable, you have to differentiate between the two. You have the choice of rate control drugs versus rhythm control drugs. Rate control versus rhythm control drugs. Which one to give is the question. So you have got a choice here. Now we have got a choice that we have got patient is hemodynamically stable. Patient is hemodynamically stable. Then you have to choose between rate control and rhythm control. Choose between rate control and rhythm control. You have to choose. For rate control, we have got class 2 and class 4 agents. For rhythm control, we have got class 1 and class 3 agents. Already discussed. But among the two, both offer equal survival benefit. Both offer equal survival benefit. And that is why, considering that the patient is elderly, the class 2 and class 4 are preferred due to safety. Because the class 1 have got higher adverse drug reaction, higher toxicity. So they are the second line agents. So in an acute patient who is stable, you want to consider rate control. Patient is in shock, you want to go for cardioversion. Along with this, you want to give chronic oral anticoagulation. Along with this, you want to consider chronic oral anticoagulation. You want to consider chronic oral anticoagulation. When you want to consider? When the patient's CHAD S2, we have got the CHAD S2 V2 score. We have got the CHAD S2 A2 vascular score. Vascular score more than equal to 2. Anna, I will tell you how to read this. So in a patient along with atrial fibrillation management, you have to consider chronic oral anticoagulation. If the CHAD, how to write it? See this, how to write it? CHAD S2A2 vascular score more than equal to 2. So we have to give oral anticoagulation if the patient has CHAD A2 S2 score, more than equal to 2. So what are the features? CHAD, congestive heart failure, 1 point. Hypertension, 1 point. A2 means 2 bar. Age more than 75 gets you 2 points. And if age is between 65 to 75, you will give 1 point. We will get 1 point. Diabetes mellitus, 1 point. S2, history of stroke, you will give 2 points. And if the sex is female, you will get 1 point. And vascular events, history of vascular events, example DVT, MI, pulmonary embolism, 1 point. So basically, except stroke, you want to give 1 point to vascular event, 1 point to the vascular event you want to know, right? So this is our atrial fibrillation. Okay, take this down. Atrial fibrillation, this is what we have, that complete management. So important is the management of atrial fibrillation that we want to remember. Management of atrial fibrillation we want to remember. Okay, clear till here? These are our supraventricular. These are our supraventricular arrhythmias. These are our supraventricular tachyarrhythmias. No, stroke scale is different. That is for TIA to stroke. That is different. This is for risk of stroke in atrial fibrillation. This is different. This is different from the stroke scale. Yes, everybody, supraventricular tachyarrhythmias. You must know PSVT, MAT and AFib. PSVT, MAT and AFib. Correct, everybody? Right? So this is what we have in the supraventricular arrhythmia. Supraventricular arrhythmia. Let us take you back to ventricular side now. Ventricular side. So from the arrhythmia, we have taken care of the supraventricular arrhythmia. We have taken care of. Supraventricular arrhythmia we have taken care of. Now we have to complete our last column, that is broad QRS, ventricular origin tachyarrhythmias. We want to talk about ventricular origin arrhythmias and complete the session. So starting with ventricular tachycardia. Starting with the ventricular tachycardia. We have got ventricular tachycardia. Very important. Simple topic, important. Epidemiology, more than 50 years. Male dominant disease. Among the risk factor, IHD is the most important, followed by infiltrative cardiomyopathy. Infiltrative cardiomyopathy. Infiltrative cardiomyopathy. Risk factor. Risk factor. So ischemic heart disease, infiltrative cardiomyopathy can cause degenerative heart disease. Degenerative heart disease can cause this problem. Okay, so these are risk factors for ventricular tachycardia. Risk factors for ventricular tachycardia. How do they present? Clinical feature. Majority present with shock. Majority present with shock. Majority present with shock. Okay. So what is the important ECG findings? Which are the ECG findings is the important question. ECG findings are the important question. Which are the essential features and which are the supportive features? Which are the supportive features on the ECG is important to remember. Is important to remember. Essential versus supportive features we want to remember. Okay. So essential feature, it has to be broad QRS complex, tachyarrhythmia more than 100 beats per minute. There has to be regular RR interval. There has to be regular RR interval. 3 or more consecutive VPC. 3 or more consecutive VPC. Ventricular premature complex must be there. So broad QRS complex. Broad QRS complex tachycardia. Broad QRS complex tachycardia, regular RR interval, and more than 3 consecutive VPC. Okay, so we will draw it here. So what it will appear as? Broad QRS complex. Broad QRS complex, more than 3 consecutive, this is VPC, each one is a VPC, more than 3 consecutive VPC constitutes ventricular tachycardia. Constitutes ventricular tachycardia. Now, in between the ventricular ectopic, there can be a sinus beat. Within the ventricular ectopic, there can be a sinus beat. This sinus beat is called as the capture beat. Sinus node has captured the rhythm of the heart. There can be sinus beat, capture beat. The next sinus can be taken over by the ventricular ectopic. This is called as the fusion beat. This is called as the fusion beat. So in the ECG, you can get capture beat, you can get fusion beat. Capture beat and the fusion beat can be there. Okay, so there will be continuation of the arrhythmia. Along with that, what can you have? You can get extreme axis deviation. Extreme axis deviation can be present, and concordance of the R wave. There can be concordance of the R wave in the chest leads. Concordance of the R wave in the chest leads. Okay, इसका मतलब if the R wave is positive, it remains positive in all the chest leads. It remains positive in all the chest leads. So these are all supportive evidence. These are all supportive evidence for ventricular tachycardia. Supportive evidence for ventricular tachycardia. The treatment of choice in ventricular tachycardia, treatment of choice. When the patient comes in acute emergency, majority times patient comes in shock, then you also shock, go for cardioversion. Go for cardioversion. And if the patient rarely, if stable, rarely, if the patient is stable, you can consider class 1 and class 3 agents. And if it doesn't work, you can go for cardioversion. You can go for cardioversion. Okay, so क्या है? Sinus node has taken the rhythm. अब ये sinus के साथ साथ ventricular ectopic has fused together. So ventricular ectopic beat has fused with the sinus beat. That is called as fusion beat. They have fused together. Concordance means the direction of the R wave. So R wave is positive. It will remain positive throughout all the chest leads. It will remain positive throughout the chest leads. Concordance means same pattern of R wave is seen in all the chest leads. Concordance, same pattern seen in all the chest leads. After the acute attack, chronic prophylaxis. After the acute attack, chronic prophylaxis is given by oral amiodarone. Remember this. Oral amiodarone is the only drug. It is the only drug to reduce sudden cardiac death. It is the only drug to reduce sudden cardiac death risk. Okay, so extreme axis means you have to calculate the axis on the ECG, that you refer to ECG class, how to calculate the axis. Accordingly, you will take down the points. Extreme axis deviation. Okay, so we have got here that chronic profile axis we have got here, that we will continue. But the prognosis of VTAC is poor because of acute mortality is high. Acute mortality is high. That is why it is poor. So I don't know why there is this confusion. So ventricular ectopic pacemaker. Listen carefully to ECG change. Ventricular ectopic pacemaker is the rhythm of the heart. Ventricular tachycardia mein the pacemaker is a ventricular ectopic. Within that, sometime one sinus beat will come. That is called as capture beat. Sinus beat has captured the rhythm of the heart. But at the same time, before, along with the sinus beat, there can be one VPC also fused together, and that is what I told you. That is the time when atria and ventricle will contract together, leading to Canon A wave on the JVP. This is the example. During fusion beat, you will get both the atria and ventricular contraction together. That is what is fusion beat. That is what is the fusion beat. Okay, so these are our ECG pictures here. That is our ECG pictures, right? So moving on to the next one, multifocal polymorphic VT or torsades de points. We have got polymorphic VT or torsades de points. This is the polymorphic ventricular tachycardia. Polymorphic ventricular tachycardia, torsades de points. Polymorphic ventricular tachycardia. In 10 minutes the topic will be over, no? So 15-minute break नहीं होता है, अभी lunch break ही होगा. 12:15 को break लेंगे, है ना? So torsades de points. Torsades de points. Okay, torsades de points is similar to the VTAC, but the risk factor is the treatment itself. Class 1A and class 3 agents. Class 1A and the class 3 agents is the main risk factor. Especially the risk is precipitated by hypokalemia, precipitated by use of other drugs, other agents like SSRI, antifungal agents, antifungal drugs. So the idea here is that if you are keeping a patient on anti-arrhythmic drug, you have to monitor for hypokalemia. You have to monitor for hypokalemia, and you must avoid the consequent use of SSRI or antifungal. SSRI, antifungal should be avoided. Should be avoided here. That is the point that we want to remember. That's the point we want to remember. So what happens? Clinical feature: majority present in shock. Majority present in shock. ECG is the gold standard. What will you get? Multiple VPC, different morphology, multiple VPC you will see on the ECG. So this is called as, you will see 3 or more different QRS morphology. Different QRS morphology with pointed appearance. With the pointed appearance. That is why it is called as torsade de points. Different morphology is there. Different morphology is there. 3 or more different morphology is there with a pointed appearance. That is why it is called as torsade de points. That is why it is called as the torsade de points. Okay, so fine, we will not give the lunch break now. Let's complete the topic. The treatment, the drug of choice is magnesium sulfate if patient is stable. If the patient is stable. Cardioversion if the patient is in shock. Cardioversion if shock is present. Here also there is high acute mortality. There is high acute mortality, making it poor prognosis. Making it a poor prognosis. Right. Okay. So let's look at these points here. Let us okay. Right. So you can just take this down, okay, and I will keep explaining the point here. Yes. So just I am putting the whole here. Prognosis of ventricular tachycardia we have written is poor because of high acute mortality. Because of high acute mortality. Okay, right. Okay, so I'm just explaining this for you again. So what we have got here. So scroll up means this is all there is there, Deepu. है ना? Scroll करने को. Okay, चलो. Okay, so what we have got here. So this is the typical of torsade de points. Clinical feature present with shock. Clinical feature present with shock. We have written the ECG finding, the drug of choice if stable, cardioversion if the patient is in shock. है ना? Just to complete, एक VFib का कुछ मतलब नहीं है. VFib is deadly after 65 years, male dominant disease. It is always in shock. Patient presents always in shock. Risk factor include age, degenerative followed by IHD. Degenerative followed by IHD. ECG आपका फ्री हैंड ड्राइंग कुछ भी ड्रॉ करो वो हो गया आपका VFib, है ना? ऐसा मत ड्रॉ करो, but just anything is ventricular fibrillation. So ventricular fibrillation you cannot make out the exact extent of the waves. It appears broad QRS complex. The only treatment is emergency defibrillation. the only treatment is emergency defibrillation. But here also prognosis poor. Prognosis poor due to high acute mortality. Due to the high acute mortality. Okay, so just copy this down so that we can complete our topic of arrhythmias. Okay, just copy this down so we can complete the topic of arrhythmias and start with another in the session. ECG I will show you in the end. Okay, right. Okay, so good afternoon everybody. So we have completed our first session. We have taken care of all the arrhythmias one by one. So today when we close, after finishing all our topics, we'll go through the ECG images. Okay, so at the end of all the class, I'll go take you through the ECG images at the end. Okay, so we'll go through the entire PowerPoint presentation. Till that time we will continue, right? Okay, so we'll taken care of the arrhythmia. Let us go forward. So let us take a look at our index of cardiology first. So in the index of right, so we have taken care of the arrhythmia topic. Now pericardial disease we completed yesterday. So today we are going to start with the valvular heart disease. We are going to start with the valvular heart disease. We are going to start with the valvular heart disease and then go on to cardiomyopathy. So this session we are going to be focused on the valvular heart disease. Next session we will complete cardiomyopathy and heart failure. Right. So when we talk of valvular heart disease, when we talk of the valvular heart disease, mainly the main cause in the valvular heart disease, one of the common causes is the rheumatic heart disease. So we have completed rheumatic fever. We spoke about rheumatic fever, which affects the mitral wall most commonly. Which affects the mitral wall most commonly. We have already completed rheumatic fever in rheumatology. We have taken care of rheumatic fever when we discussed the rheumatology end one. We completed here with vasculitis the rheumatology acute rheumatic fever. We completed acute rheumatic fever in rheumatology. So today let us look at the plan first so that we know what is coming at us. So it is 1:30. This session we are going to start with the mitral stenosis. We will complete aortic stenosis. We will complete the mitral regurgitation, mitral valve prolapse, and we will talk of infective endocarditis. And we will go for infective endocarditis. Okay, so aortic regurgitation I am not teaching because it is not very important for theory and MCQ. It is only those peripheral signs of AR that are asked in the Viva question that you can just read. There is nothing much to examine. So what we have got here, this session we are going to start from 1:30 to 3:40. 1:30 to 3:40 we are going to complete valvular heart disease, that is mitral stenosis, aortic stenosis, mitral regurgitation, mitral valve prolapse we are going to talk about, followed by infective endocarditis, followed by the infective endocarditis. Then we are going to start with cardiomyopathies and complete our day with heart failure between 4 and 7:30. Okay, so that is our target. In between we will take a small tea, coffee break, whichever you like, and then we will go. Okay, so this is the plan for the day. this is the plan for the day that we have got. So we have valvular disease, infective endocarditis for this session, cardiomyopathy, heart failure for the last session, and then we will come just review through the ECG images. Chal. So let us start with the set of valvular defects. Let us start with the valvular defects. So first one, we will start with mitral stenosis. We'll start with the mitral stenosis. So I want you to remember that how we have got here very simple points. Whenever we study about an individual topic, you start with the definition, you finish with the prognosis. So what is mitral stenosis? Mitral stenosis is defined as the narrowing of the mitral orifice or the mitral valve area. It is defined as the narrowing of the mitral orifice or the mitral valve area is the mitral valve area. Okay, so we are talking about mitral stenosis. Mitral stenosis, narrowing of the mitral valve area is the definition of mitral stenosis. So we must know, to understand what is narrowing, we must know what is the normal mitral valve area. When does the patient develop symptomatic? When does the person become symptomatic? And when do we call this as severe mitral stenosis? When do we label the patient as having severe mitral stenosis? I'll tell you, just simple points is that we have to just make every topic maximum in a page or two. We are not here to write any essay type question. We want to know salient features of the disease step by step. So we have to classify what is normal mitral valve area, when does the patient become the symptomatic, and when do we call this as severe mitral stenosis. Okay, so normal mitral valve area is 4 to 6 square centimeter. Normal mitral valve area is 4 to 6 square centimeter. It becomes symptomatic when the valve area becomes less than 2.5 square centimeter. Becomes symptomatic when it becomes less than 2.5 square centimeter, and severe when it is less than 1.5 square centimeter. We are going to call this as severe. We are going to call this as severe mitral stenosis. That's what we have. So going on, what are the causes? What is the cause of mitral stenosis? The main cause is the rheumatic heart disease. Most common is the rheumatic heart disease. Others are only rare causes. We have got like carcinoid syndrome, and we have got Lutem-Becker's disease. Lutem-Becker's syndrome, which is nothing but congenital atrial septal defect plus mitral stenosis. So we have got causes. So we can see that most common cause is the rheumatic heart disease. This is the first page after the break. We are starting with rheumatic heart disease, that is valvular defects. We are going to start. So first topic we have taken is the mitral stenosis, which is defined as narrowing of the mitral valve area. Most common cause being rheumatic heart disease. So based on the cause, you can predict the epidemiology. You can predict epidemiology of the disease. Atrial septal defect, atrial septal defect plus mitral stenosis, that is Lutem-Becker's syndrome. Epidemiology, we studied rheumatic fever. Rheumatic fever basically affects the school going children 5 to 15 years. So the valvular defect comes 10 years onwards. That is what? 1 decade later. So epidemiology is 20 to 30 years. 20 to 30 years is the presentation, and this is the only valvular disease which affects female more than male. So please remember, the only valve disease which is affecting the female more than male is the mitral stenosis, and that is why it is the most common valve defect complicating pregnancy. It is the most common valve defect complicating pregnancy, we can say that, because the age group is like that, 20 to 30 year female dominant disease. It is the most common valve defect complicating pregnancy is mitral stenosis. How does it present? What are the clinical features of the disease? How does it present? Clinical features of the disease. So please remember, the clinical feature depends upon the chamber involved, depends upon the chamber affected and the function affected. Please remember, in cardiology, this is the dictum. The dictum in cardiology is that it depends upon the chamber affected. It depends upon the chamber affected. You can predict the symptoms of the disease. So let us see them one by one. So we want to look at the progression. We want to look at the progression. Why the age group is 20 to 30? Most common cause is rheumatic fever. Rheumatic fever occurs between 5 to 15 years of age. After rheumatic fever, it takes 10 to 15 years for the valve defect to occur. That is why approximate age is 20 to 30 years. So the clinical feature depends upon the chamber involved. I want you to know how to understand the pathophysiology of the heart. So we will draw a small illustration here and match with the clinical feature. Match with the clinical feature. So mitral stenosis, mitral valve area has become narrow. Patient has developed mitral stenosis. Mitral stenosis. In mitral stenosis, the first chamber to be affected is the left atrium. The first chamber to be affected, there is the left atrial enlargement. There is the left atrial enlargement. Left atrial enlargement usually remains asymptomatic in majority. Left atrial enlargement in majority remains asymptomatic, but rarely it can be responsible for Ortner's syndrome. The presentation can be in the form of Ortner's syndrome. Ortner's syndrome means patient comes with hoarseness of voice. Hoarseness of voice due to mechanical compression. Due to mechanical compression of the left recurrent laryngeal nerve. Of the left recurrent laryngeal nerve. It can cause that Ortner's syndrome. But please remember, it is uncommon. It is uncommon. So mitral stenosis, please remember, remains asymptomatic for long time, because the first chamber affected is the left atrium, and left atrial enlargement alone most of the time remains asymptomatic. Rarely it can cause Ortner's syndrome, which is basically hoarseness of voice due to mechanical compression of the left recurrent laryngeal nerve. Left atrial enlargement, है ना? So context को रखिए ना थोड़ा सा, है ना? Remain in context of what is being taught. Left atrial enlargement will be there. But important point is the main chamber LV is spared. The main chamber left ventricle is spared. That is good news. Left ventricle is spared in mitral stenosis. But if you don't treat, what's going to happen? What is connected to the left atrium? There will be pulmonary venous hypertension. There will be pulmonary venous hypertension. Pulmonary venous hypertension can occur. So because the pulmonary veins drain into the left atrium, if due to mitral stenosis, left atrial pressure increases and the backflow of the pressure can lead to pulmonary venous hypertension. This pulmonary venous hypertension will reflect, leading to pulmonary capillary hypertension. This can lead to the pulmonary capillary rupture. This can lead to the pulmonary capillary rupture can occur. Pulmonary capillary rupture can occur. And if you still don't treat, the patient can develop pulmonary arterial hypertension. If you still don't treat, the patient can develop pulmonary arterial hypertension. Pulmonary arterial hypertension can occur. Pulmonary arterial hypertension can occur. Please remember, pulmonary edema is a wrong answer. Pulmonary edema occurs late in the disease when there is left ventricular failure also, not early. Okay, initially there is only capillary rupture. Pulmonary arterial hypertension can occur, which causes congestion in the lungs. This leads to right ventricular hypertrophy. And if you still don't treat, the patient can progress to heart failure. So this is the sequence that you can visualize with each cardiovascular structural defect. You can easily remember and then predict the features of the disease. So based on that, you can say number 2, what we have written, pulmonary venous hypertension. Number 2, pulmonary venous hypertension can cause capillary rupture. Pulmonary venous hypertension can cause pulmonary capillary rupture. Number 3, the pulmonary arterial hypertension. The pulmonary arterial hypertension due to congestion is associated with increased risk of lower respiratory tract infection. The pulmonary arterial hypertension can be associated with increased risk of lower respiratory tract infection. Number 4, late stages can present with heart failure, which can come as pulmonary edema. Late stages, heart failure can present with pulmonary edema, can occur. But all these present as hemoptysis, and that is why we say one of the common features is hemoptysis. One of the common feature is hemoptysis, which is odd man out. Why odd man out? Because hemoptysis is usually considered a symptom of the respiratory disease. It is usually considered a feature of respiratory disease. It is considered as, okay. So heart failure is usually not early. It takes years of the untreated disease to progress into heart failure. So this is the pathophysiology. This is how the physiology gets altered, leading to various manifestations of the disease. So to diagnose the condition, what are we going to use? So try to remember the yesterday's class that I told you, that when you suspect cardiovascular system disease, What you must do? Start with clinical examination, record ECG, then echocardiography with color Doppler. So here you tell me, for the diagnosis of the disease, if you have suspicion, what will you find on clinical examination? What will you find on clinical examination? What will you find on clinical examination? Come on, try to recall and connect the topics together. Yesterday we studied about heart sounds. We studied about murmur. I want you to recall and try to connect the topic together. Try to connect the topic together. So on examination, what sound? Heart sound. Can you recall? Heart sound. Very good. So you will get loud S1. You can get opening snap. Very good. Loud S1, opening snap can be heard on auscultation. Along with that, you will get mid-diastolic murmur. Very good. You will hear mid-diastolic murmur. But try to recall, what are the causes of mid-diastolic murmur? It could be tricuspid stenosis also. It could be left atrial myxoma also. So to help differentiate, what points you want to add? Mid-diastolic murmur best heard on expiration. Best heard on expiration. That means it is not TR. Best heard on expiration without preceding tumor plop. Without preceding tumor plop. Very good. So when I say this, I am excluding the other causes of the murmur. So in mitral stenosis, the patient will have loud S1, there will be opening snap, mid-diastolic murmur, which is best heard on expiration without preceding tumor plop. Right. On the ECG, what will you get? Come on the ECG, what will you get? Left atrial enlargement, P mitrale. Left atrial enlargement, P mitrale. That is your bifid P wave. You will get a bifid P wave. That is your typical finding on the ECG. And you will get right axis deviation, right bundle branch block, which is basically signs of right ventricular hypertrophy on the ECG. So on the ECG, you are going to get P mitrale, right axis deviation, right bundle branch block, which are the signs of right ventricular hypertrophy on the ECG. But the gold standard for diagnosis is the echocardiography. Remember, it's a structural heart disease. It's a structural heart disease. Gold standard of diagnosis is echocardiography. Gold standard is echocardiography. Okay. So left atrial myxoma, try to recall, left atrial myxoma will have tumor plop followed by MDM. So to say that it is not left atrial myxoma, you are going to say that there is the without preceding tumor plop. Okay. So before the murmur, tumor plop comes if it is a left atrial myxoma. Lower respiratory tract infection is common because of pulmonary congestion. Lower respiratory tract infection common because of respiratory congestion in the lungs. Okay, that's why I've given the keywords, told it again, remember. Now gold standard is echocardiography. Then let us go for the treatment. Management of the disease, very important. Remember the same chart format you have to use for all other respiratory disease also. Very important. I'll give you very simple chart. The management of mitral stenosis. The very simple chart, management of mitral stenosis. I'll give you simple table. Management of mitral stenosis. Please remember, in medicine, the treatment always depends on the severity of the disease also. Treatment depends upon the severity of the disease also. So please remember, when you get a patient or you get a question of mitral stenosis, you can get a patient or an MCQ question on mitral stenosis. What should we do? What should we do? We must see here mitral stenosis. First, we must look for the symptoms. So you must look for the NYHA class of symptoms. You must look for the severity of the symptoms, that how much it is affecting the patient. So whether the patient is feeling fatigue, breathlessness, we must know what is the NYHA class of symptoms. What will be the NYHA class of symptoms? Once we get that, we look for signs of heart failure. You will look for whether the patient has any signs of heart failure. I hope you know that. We will be doing it in the end. Heart failure means patient has elevated JVP, patient has congestive hepatomegaly, pedal edema, inspiratory crepitation. Inspiratory crepitation, we can see. So you look for signs of heart failure. You will look for mitral valve area. Okay, you look for mitral valve area. You look for left ventricular ejection fraction. You look for left ventricular ejection fraction. Look for left ventricular ejection fraction. You will look for. And finally, you will look for special condition like pregnancy. Mitral stenosis, the special condition is pregnancy. You will take into account all these points to identify first line of treatment. So based on all of this, you have to mark what is the first line of treatment. Answer will change. Everybody, note it down carefully. Every valvular disease, you will follow same protocol. You have to follow same protocol. You will follow the same protocol. NYHA class of symptoms, whether signs of heart failure are present, mitral valve area, left ventricular ejection fraction, pregnancy, you have to see. And based on this feature, you will mark the first line of treatment. You will mark first line of treatment. Yes, this is what we will see. So, if the patient, write in tandem, if the patient has NYHA class 1 to 2 only, that means mild symptoms. Patient has no signs of heart failure. The valve area is more than 1.5 square centimeter, means it is not severe. Left ventricular ejection fraction is preserved more than 40%. It is preserved, or rather we will write more than 50%. It is preserved. Pregnancy is not there. Pregnancy is not there. What pregnancy is not there? That means it is a case of mild, uncomplicated mitral stenosis. So you can say this is a case of mild, uncomplicated mitral stenosis. NYHA class is New York Heart Association. New York heart association. You have to read it from a clinical textbook. Ana Munteha, read NYHA class of symptom. So if the patient mitral stenosis is going to be mild symptoms, there is correlating with no features of heart failure, mitral valve area, ejection fraction preserved, no pregnancy, we can call this mild uncomplicated mitral stenosis. So this is a patient of mild uncomplicated mitral stenosis. This patient, mild uncomplicated mitral stenosis, can be managed by medical treatment alone, can be started on medical treatment alone, even though it is only palliative. So you can start the patient on medical treatment because patient is not having any serious problem. You can start the patient on medical management alone. The medical management is palliative. What drugs do you want to give? What drugs you want to give? Yes, to reduce the congestion. You want to give diuretics. Diuretics to reduce the pulmonary congestion. You want to give ACE inhibitor. Please remember, ACE inhibitor prevents ventricular remodeling. Prevents ventricular remodeling. Reduces the risk of heart failure. Reduces the risk of heart failure. This is how to remember. So when the patient or the question is mild uncomplicated mitral stenosis, the first line of treatment should be medical. First line of treatment should be medical in the form of diuretics and ACE inhibitors must be given. Along with, you must suggest annual echo follow-up. You must suggest annual echo to follow up the severity, follow up the mitral stenosis, because medical treatment does not cure the disease, but it will remain the first line treatment in a mild uncomplicated along with annual echo for follow up of severity. Annual echo for follow-up of severity, that will be first line treatment. But on the other side, remember and write, on the other side, I'll make it little small. So yes, on the other side, what we will see here, other side, if the mitral stenosis patient has got NYHA class 3 to 4, that is severe symptoms, 3 to 4, that is severe symptoms, signs of heart failure are present, signs of heart failure are present. Mitral valve area has become less than 1.5 square centimeter. It has become severe. Left ventricular ejection fraction is reduced. Left ventricular ejection fraction is reduced. And pregnancy is present. Pregnancy is present. So if any one of the above feature present, any one of the above feature is present, it is an indication for intervention. Is an indication for intervention. So you have to go for definitive treatment, because now the case has become complicated, or it has become severe, or there is pregnancy associated with the disease, or there is pregnancy associated with the disease. So if any one of the above is present, you want to consider the patient to be started on the intervention. In intervention, the most preferred intervention is to go for balloon mitral valvotomy. The preferred intervention is to go for balloon mitral valvotomy. The balloon mitral valvotomy must be considered. Most preferred intervention is to go for balloon mitral valvotomy. You must proceed with balloon mitral valvotomy is the preferred intervention. If the patient has any one of the severe complication or pregnancy, you will proceed with balloon mitral valvotomy. You will continue. Only if contraindicated. Only if it is contraindicated. Balloon mitral valvotomy cannot be performed. Then you will consider MVR, mitral valve replacement. Then you will consider mitral valve replacement. Then you will consider the mitral valve replacement. So after the diagnosis, you will grade the severity of the disease. If the severity of the disease is mild, uncomplicated, go for medical management. If the patient has severe disease, complicated disease, or associated with pregnancy, you want to go for balloon mitral valvotomy. Only if contraindicated, you will consider mitral valve replacement. So what are the contraindications? The contraindications to BMV are divided into two. Contraindications can be divided into relative contraindication and absolute contraindications. The contraindications for balloon mitral valvotomy are divided into two. Relative contraindications or absolute contraindication. Relative contraindication, absolute contraindication we want to see. Relative contraindication is presence of LA thrombus. Is the presence of LA thrombus. This is a relative contraindication because there is a risk of embolization during the procedure. There is a risk of embolization during the procedure. There is a risk of embolization during the procedure. Contraindications of BMV. Yes, we are writing contraindications of BMV. Relative contraindication. Presence of left atrial thrombus. There is a risk of embolization. But why we are calling it relative? Because you can proceed with BMV. You can proceed with BMV after giving 3 or more weeks of anticoagulation. 3 or more weeks of anticoagulation. We can proceed with the balloon mitral valvotomy. So it is a relative contraindication. That means it is a relative contraindication, we can say. Okay, relative contraindication. Absolute contraindication is when the patient has associated, when the patient has got associated moderate to severe mitral regurgitation. When the patient has got associated moderate to severe mitral regurgitation, you cannot do BMV. Or when the patient has got calcified mitral valve leaflets. When the patient has calcified mitral valve leaflets, you cannot proceed with BMV. You have to go for mitral valve replacement. You have to go for mitral valve replacement. Okay, so mitral valve area, so what is there? Mitral valve area. Yes, both severe MR and MS can occur together. Of course it can occur. That is why we are reading, no? So what is the point here? So the question, what is our table? So signs of heart failure present. This is what we have written. So these are, any one of the feature is there, then we go for severe. What to do in pregnancy, Neha Dwivedi? What you have to do? Do balloon mitral valvotomy. It's already written, no? You have to go for balloon mitral valvotomy. That's what I have written down for you. Why are you asking the same question? We have written BMV should be done. Now if BMV is contraindicated, it is uncommon that it will be contraindicated in pregnancy. And if it is contraindicated, you will proceed for surgery. If surgery is going to be done, then you have to maybe consider termination depending on severity of disease, right? So this is our management chart. This is our management. Okay, so what we have got, the risk here. So this is the treatment of mitral stenosis, our topic in the end. What is the risk of infective endocarditis in this patient? Answer, low. Risk of infective endocarditis is low. Risk of infective endocarditis is low. Risk of endocarditis is low. Right? And that is why the prognosis is good. The prognosis is good, we can say. The prognosis of mitral stenosis is good. That's all. Simple, we have to say. So it is a very, very simple points that I have made for you. Okay. So can you see the table clearly? So this is the whole treatment of mitral stenosis. This is the whole treatment of mitral stenosis in front of you. So you can summarize the whole table together. You can summarize the whole table together. The choice whether you give the prosthetic wall or metallic wall does not depend on the condition. It depends upon the patient's age. Okay, that is for another day. This you try to recall first. So patient of mitral stenosis is typically young female. Comes with mitral stenosis, and many times the mitral stenosis is diagnosed during pregnancy. So if there is pregnancy, then you have to go for intervention. Otherwise, you have to see the severity of the disease, the complications, the presence of heart failure, and the class of symptom. Based on that, you have to go for the first line of treatment. So mild cases, medical management, follow-up, endocarditis is very good, and prognosis is good. Even with intervention, balloon mitral valvotomy is a daycare procedure. Prognosis is good. Infective endocarditis, IE का मतलब होता है infective endocarditis. Okay, it is the infective endocarditis. चलिए, okay, so this is our mitral stenosis. आगे चलते हैं. to the next lesion. So similar to stenotic lesion, second point लेते हैं aortic stenosis. एक और stenotic lesion को पहले complete कर दें. Aortic stenosis. Aortic stenosis, what we want to use? Aortic stenosis, we want to see narrowing of the aortic valve area. Narrowing of the aortic valve area is the definition of the aortic valve area. In pregnancy, you can never try the medical management. In pregnancy, both diuretic and ACE inhibitors are contraindicated. So do not think of silly questions. So you have to look at the whole profile of the patient. It is to be understood like that. So narrowing of aortic valve area, like MS, same pattern I want you to write. What we can see, what is normal aortic valve area? What is the normal aortic valve area? When does it become symptomatic? And when do we call it as severe aortic stenosis? Same one we want to follow. Same pattern we want to follow for aortic stenosis also. Same pattern we want to follow for the aortic stenosis. What is normal aortic valve area? When does it become symptomatic? And when do we call it severe? We want to remember that. So normal, starting with normal aortic valve area is 2 to 4 square centimeter. Normal aortic valve area is 2 to 4 square centimeter. It becomes symptomatic when it is less than 1.5 square centimeter, and consider severe when it is less than 1 square centimeter. When it is less than 1 square centimeter, it becomes severe. It becomes severe. That is the aortic valve area related classification. The epidemiology of the disease correlates with the cause, correlates with the causes. The causes of aortic stenosis. Most common cause is degenerative or sclerotic AS is the most common cause. Degenerative, that is the sclerotic AS, is the most common cause, followed by it can be due to bicuspid aortic valve. Bicuspid aortic valve is a congenital heart disease which causes faster degeneration of the aortic valve, and very rarely it can be seen in rheumatic heart disease. And a prognosis, risk of endocarditis in MS दोनों के लिए, both, है ना, in both. You have to follow the thing also यार, what we are talking also try to follow. Only audio visual में, कभी visual कभी audio ऐसा मत सोचिए, है ना. Overall prognosis is good. Mitral stenosis question का आंसर दे दिया मैंने. Sorry to go in a tangent. So let's come back here. Yeah. So based on this, you can predict the epidemiology of the disease. You can predict the epidemiology of the disease. So the causes of aortic stenosis can be degenerative, most common, bicuspid aortic valve, which is a congenital heart disease with faster degeneration, and rarely rheumatic heart disease. And that is why most commonly you get above 50 years of age, male dominant disease, most common age group. Bicuspid valve can come between 30 to 50 years, and rheumatic disease comes between 20 to 30 years. We studied with mitral stenosis. We studied with the mitral stenosis already. This is epidemiology of the disease. Epidemiology of aortic stenosis, that will give you clue to the probable cause of the disease. What are the clinical features? Remember the acronym. Mitral stenosis patient, aortic stenosis patient are typically sad. Aortic stenosis patient are typically sad. That is the acronym to remember. The clinical presentation, aortic stenosis patient are typically sad. What is this sad? What is the presentation? Syncope, angina, dyspnea. They present with syncope, angina, dyspnea. They present with the syncope, angina, dyspnea. Present with the syncope, angina, dyspnea. So syncope is the earliest feature. Syncope is due to LVOT obstruction, due to left ventricular outflow tract obstruction. The stroke volume will become low. The stroke volume will become low, and that is why it is one of the earliest feature. It is the earliest feature, but the problem is non-specific. But it is non-specific for the diagnosis of the disease. Non-specific for the diagnosis of the disease. Diagnosis of the disease. Okay. So here the problem is elderly patient have many causes for syncope. Just because they have a syncope, you don't directly think of aortic stenosis. So diagnosis may be delayed. Then they come with the angina. Angina can be due to massive. What is happening? There is pressure overload. There is pressure overload to the left ventricle, which causes massive left ventricular hypertrophy. Which causes massive left ventricular hypertrophy. Massive left ventricular hypertrophy, which can lead to increased demand of the myocardium, leading to angina. Leading to angina, right? There are no types of AS beta. Anna Soumya, there are no types of AS. AS is only one. We have written causes, epidemiology, sab kuch. I have written the headings also. The doubt is making me scared. Anna, doubt is making me scared. Then there is dyspnea. Dyspnea is the dreaded feature. It is the dreaded feature because it marks the onset of heart failure. Once breathlessness has come, that means the patient has developed heart failure. Okay. So first table we have drawn for the valve area. Second table we have drawn for causes of aortic stenosis. Third table we have drawn for epidemiology. Fourth table for clinical features of the disease. Clinical features of the disease, which has got explanation to what is the mechanism. What is the mechanism of each symptom? The mechanism of each symptom, we have got it here. Mechanism of each symptom, we have got it here. Now, continuing further, on clinical examination, what will you find? On clinical examination, what will we find? So for diagnosis, on examination, याद रखिए, mitral stenosis में S1, यहाँ पर क्या याद करोगे? Paradoxical S2 split. Paradoxical S2 split. Ejection click. Patient can have ejection click may be present, and there can be ejection systolic murmur, best heard on expiration, ejection, systolic murmur, best heard on expiration, and important point, radiating to the carotids, radiating to the carotids. This is very, very important. Radiating to the carotids. Very good. We can also get pulsus parvus et tardus. Pulsus parvus et tardus can be seen on examination. Very good. Can be seen on examination. So ejection, systolic murmur, best on expiration. We have got this thing, that one of the radiating to the carotids, radiating to the carotids, right? This is the examination finding. On the ECG, what will you find? On the ECG, you will find left axis deviation. You can see left bundle branch block, signs of LVH, signs of LVH, and you can see generalized ST depression. You can see generalized ST depression, strain pattern. That is why it is called as the increased demand. The myocardium is hypertrophy. Myocardium is hypertrophy, and that is why you get generalized ST depression. You get generalized ST depression. You can get generalized ST depression. You can get. So once you have reached the diagnosis, left axis deviation, left axis deviation, left bundle branch block, you can see, right? Once the diagnosis, gold standard is echocardiography. Gold standard of diagnosis is echocardiography. Again, same pattern. For the treatment of aortic stenosis, make the chart. For the treatment of aortic stenosis, same way like how we did for mitral stenosis, make the chart. What all we want to see? NYHA class of symptoms. You want to look at the NYHA class of symptoms. We want to look for left ventricular ejection fraction. We want to look for aortic valve area, aortic valve area, and here the special condition you want to look for, again, signs of heart failure, signs of heart failure, and special condition if the patient needs cardiac surgery. Patient needs cardiac surgery for another disease, for another disease. Example, the patient needs coronary artery bypass graft for ischemic heart disease. You want to take into consideration. Based on this, you will mark first line of treatment. Okay, you want to look at the first line of treatment. You want to look at. You want to look at the first line of treatment. First line of treatment you want to see. Okay, so we are looking at the treatment of aortic stenosis. You are looking at the treatment of aortic stenosis. Same way like we did for mitral stenosis. Same way like we did for mitral stenosis. So what we will say, come on, write it fast. Same order I am writing again. Write it faster now. What we have to see, if the aortic stenosis has only class 1 to 2 symptom, ejection fraction is preserved, valve area is more than 1 square centimeter, there are no signs of heart failure, patient does not have any other heart disease requiring surgery, okay, requiring surgery. ST segment changes. Okay, so first line of treatment in this situation will be medical management. We can try for medical management. Can be attempted. Medical management can be attempted in this patient. Medical management can be attempted in this patient. What drugs you want to give? There is increased demand. How to reduce angina? Beta blockers we can give to reduce the demand. Beta blockers to reduce the demand. ACE inhibitor, remember सब जगह ACE inhibitor देने का, reduces the risk of heart failure. CABG, coronary artery bypass graft surgery for ischemic heart disease. Anna, you have attended myocardial infarction class. Anna, you have to catch up. You have to take that in the point. So beta blocker, ACE inhibitor, and you can consider statins because statins have shown to slow the degeneration. They slow the degeneration of the valve. They are known to slow the degeneration of the valve. You can consider medical management along with the annual echo follow-up. You want to continue because this is a mild, uncomplicated case. You can try for medical management with annual echo follow. On the other side, if the patient is having NYHA class of symptom 3 to 4, that is severe symptoms have come. LVEF has become reduced. Valve area has become less than 1 square centimeter. Patient has features of heart failure. Patient needs surgery for another heart disease. You want to go for intervention, aortic valve replacement. Aortic valve replacement has to be performed. Now, in this place, in mitral stenosis, BMV was there. In aortic stenosis, the intervention is only aortic valve replacement. But we want to know which are the drugs contraindicated, avoided in aortic stenosis. Which are the drugs which can be avoided in aortic stenosis? So number 1, nitrates. And number 2, diuretics. So here we must remember which drugs are avoided in the aortic stenosis. Nitrates reduce the afterload. Diuretics reduce the preload. So both of them can increase risk of hypotension. Both of them are associated with increased risk of hypotension. We are not going to give nitrates. Okay, if you recall the first one, how many criteria ne? Anyone means severe hai. Severe uncomplicated means go for aortic valve replacement. This is not a criteria. This is an algorithm I have made for you from the Harrison so that it is easy for you to answer your questions in MCQ. All these points are given in the MCQ. You have to just pick them up. Any one severity marker is there. Answer becomes aortic valve replacement. So problem is that nitrates can reduce the afterload, diuretics reduce the preload and increase the risk of hypotension. They are best avoided. They are best avoided in this patient. There is best avoided. Balloon aortic valvotomy is there, but it is not the first choice because it has complications. First choice MCQ तक रखेंगे. First choice is to go for aortic valve replacement. Okay, so what do we want to know? Prognosis. The risk of infective endocarditis is moderate, and unfortunately the risk of surgery is high, so the prognosis is unfavorable. The prognosis is unfavorable. The prognosis is unfavorable. Please take into account the entire topic. Take into account the entire topic. Patient is already elderly. Patient is likely to have other heart problem also. The surgery itself is a major risk for person. And ऊपर से complication endocarditis can also happen. That is why overall prognosis is unfavorable. Nitrates reduce both. Nitrates are veno and arterial dilators. Nitrates are both veno and arterial dilators. They can reduce both. Afterload also, preload also can be reduced in this patient. Now take a look here. So simplified chart we have made. So because all we need to remember is this much only. In aortic stenosis, that is all we have to learn. In aortic stenosis, we have written all the points in a page. That's all. Simple. One page topic. I call this medicine in a page. Medicine in a page. Just you have to remember salient feature, but you have to organize your information. Organizing the information makes your notes very concise but accurate. Okay, so concise your notes. That's why I gave you the pro forma first thing, that about every disease what is the topic you want to know. So every disease you will follow from the definition, epidemiology, etiopathogenesis, the clinical examination, then go for diagnosis, treatment and prognosis, right? So this is our mitral stenosis, aortic stenosis done. Let's proceed further to mitral regurgitation. Let us proceed to mitral regurgitation. Come on, mitral regurgitation. Before we learn mitral regurgitation, we have to revisit anatomy of the mitral valve. We have to revisit anatomy of the mitral valve, has to be revisited so that we can understand that what are the mechanisms involved in mitral valve competence. Mitral valve competence. We have to again understand this. What are the mechanisms involved in mitral valve competence? We have to know, right? So anatomy of the mitral valve. Anatomy of the mitral valve you must know. I'll tell you, stenotic lesions are easy to understand because stenotic lesions are basically sclerosis of the valve. But why should there be regurgitation is important to understand. It is important to understand how the mechanisms are there. So let us draw this mitral valve anatomy. I want you to remember. And parallelly we will write the causes of the mitral regurgitation. Okay, parallelly we will write. So understand and write with me. So we have got here the mitral valve. Let's draw a little clear picture. Draw a clear picture of the mitral valve. So we have got the mitral valve which has got two leaflets, anterior and posterior. Mitral valve has got two leaflets, anterior and posterior. It's got two leaflets, anterior and posterior. Okay. So this mitral valve leaflets are attached to the chordae tendineae, which are anchored to the ventricular wall by papillary muscles. There are the chordae tendineae anchoring the leaflet to the ventricular wall by the papillary muscles. So understand this anatomy, very, very important. Understand the anatomy, very, very important. Okay. How to remember? I told you yesterday when we discussed S1. Please remember that mitral valve has got two leaflets. Think they are two parts of the door. Now imagine, when will the door not leak? When the door is aligned perfectly. When the two leaflets, that is the two parts of the door, are aligned perfectly in the center, then there will be no leakage. Also, the board, that is the wood of the door, must be strong. The leaflet should be healthy. So for competence to occur, number one, the leaflet related points, there has to be very healthy leaflets. There has to be healthy leaflets, and there has to be perfect alignment also of the leaflets. There has to be perfect alignment of the leaflets. That's all you have to remember. So it is a simple analogy. Darwaze ko yaad karo. Remember the door. If the door has to prevent leak, the board has to be strong and the door must block perfectly alignment so that there is no gap for leakage. Along with that, the door only opens in one direction. It does not go another direction. There is a door stopper and a hinge attached. Same way, what we have got here is the chordae tendineae. We have got here. So we have got also the chordae tendineae. So chordae tendineae are delicate thread-like structures. They are the delicate thread-like structure. And we have got papillary muscle. We have got papillary muscles also. So what are the points? Healthy leaflet should be there. Perfect alignment should be there. Okay. So perfect alignment should be there. There should be normal chordae tendineae, normal papillary muscles. Okay. Normal papillary muscle. Because what they do, they prevent the bulging. Of the mitral valve into the LA. They prevent the bulging of the mitral valve into the LA. That's what we want to remember. Okay. So prevent the bulging. This is like a hinge that we have. That prevents the backward opening of the mitral valve. Okay. Very clear. So what we need? So the mitral valve competence depends upon not only the leaflet. It depends upon not only the leaflet but also the health of the supporting structures. Once you know normal, you can switch to abnormal. So I want you to write down what are the causes of mitral regurgitation. What are the causes of mitral regurgitation? Abnormal, I want you to write. Very simple. Once you know the normal, you have to translate it to opposite. Opposite will become abnormal. So between the leaflet and the supporting structure, the disease of the leaflet is more common. Disease of the leaflet is more common. So we can get number 1, rheumatic heart disease. Rheumatic heart disease. Number 2, MVP. We will discuss after this. MVP, mitral valve prolapse. MVP is there. Number 3, there can be in connective tissue disorder. In connective tissue disorder like RA, we have studied in rheumatoid arthritis. Most common valvular defect is mitral regurgitation. Connective tissue disorder like rheumatoid arthritis. But all these causes, as you can see, are chronic in nature. All these causes are chronic in nature, and that is why the presentation is in the form of chronic MR. It is in the presence of chronic MR is more common. Chronic MR is more common presentation. More common presentation. Okay, so what we want to know here, that the defect of the leaflet, defect of the chordae can cause the problem. Okay, so we have got here leaflet defect, rheumatic heart disease, MVP means what? Myxomatous degeneration. MVP means there is degeneration of the leaflet. Degeneration of the leaflet leading to the leaflet becomes weak, which can lead to mitral regurgitation. Mitral regurgitation. Defect of the supporting structure. A, chordae tendineae rupture. Defect of the supporting structure. Chordae tendineae rupture can occur. Chordae tendineae rupture can occur. Chordae tendineae rupture can occur. Chordae tendineae rupture. What are the causes of chordae tendineae rupture? Chordae tendineae rupture can occur just due to blunt chest trauma. It can occur due to blunt chest trauma. It can occur during cardiopulmonary resuscitation. It can also occur during cardioversion. Occur during cardiopulmonary resuscitation. It can occur during cardioversion. It can also happen in Marfan's syndrome and in Ehlers-Danlos syndrome. Ehlers-Danlos syndrome, we can have this problem in Ehlers-Danlos syndrome where there is degeneration of the chordae. There is degeneration of the chordae which can lead to spontaneous rupture. Means without trauma itself, spontaneous rupture can occur. Spontaneous rupture can occur. Okay, connective tissue disease, RA is rheumatoid arthritis. MVP, next topic, mitral valve prolapse. MVP, mitral valve prolapse हो सकता है. So these are chordae tendineae rupture causes. B, papillary muscle necrosis. Papillary muscle necrosis can occur in acute MI. Vascular. Papillary muscle necrosis can be vascular in acute myocardial infarction. You have studied one of the important complications of anterior wall MI is papillary muscle necrosis. One of the important is papillary muscle necrosis. So you can see that the mitral regurgitation can be either due to defect of the leaflet, which is more common and presents as chronic MR. It can also be due to damage to supporting structure, but these tend to present as acute MR. So in short, we have written the causes of acute MR. It is luckily rare. It is luckily rare. There are few other causes of acute MR also. Acute MR can also occur iatrogenic post BMV, when we inflate the balloon to dilate the mitral valve. Inflate the balloon to dilate the mitral valve. You can end up developing mitral regurgitation. And due to dehiscence means destruction of the valve leaflets. Destruction of the leaflets due to our next topic, infective endocarditis. Dehiscence of the mitral valve leaflet due to infective endocarditis. So these are defect of the leaflet. These two are defect of the leaflet, but the presentation is acute MR. Okay, so try to understand this point here. So I'll see if we can fit this so we can see the whole picture together. We can see the whole picture together and see if it helps you understand. See if that helps you understand. So this is our whole point here. Okay, they can cause acute MR. Very good. This is the whole chart that you want to remember. This is the whole chart that you want to remember. Hana? So color change kiya na? That difference in the table, I have broadly divided the causes due to leaflet problem and causes due to supporting structure problem. Causes due to leaflet problem and causes due to supporting structure problem. Okay, you can see this clearly now. The causes related to leaflet are more likely to be chronic. The causes related to the supporting structure are likely to be acute. Mayuri Deshmukh, you have just joined BMV. Abhi likha na? Balloon mitral valvotomy. We have just studied no balloon mitral valvotomy. Okay, so just we have to understand, this is the very simple point here that we must remember. We have to use the colors because they make it easy for us to remember. Just we have to remember the points here. Just go through. So the note should be neat. In one page, next topic should be done. Okay, so let's continue. So we have to discuss further what we have done, the clinical features. We have discussed the causes. Now we want to start with clinical feature. Chalo, no problem. Don't say sorry re. Sorry ki zarurat nahi hai. We are all students. We are learning many things. I also don't know. So there is nothing like that. But just I want you to be attentive. That's all. When I'm just shouting at you, it is not because I'm angry with your question. I just want you to do better. Okay. So don't feel offended at any point of time. We want to continue this chart. So divide it further. The acute mitral regurgitation. Let us divide this next page column. Okay. So right, next one column, what we want to do. So we have to do acute MR versus chronic MR. The topic MR is not over. MR topic is not over. We have to divide between acute MR and chronic MR. Hana? So yesterday I told you, you want to compare between the two. Yesterday I told you, murmur alag hai na? The murmur is different. Murmur is different. Okay. So just remember how to go about. So causes we have written. What is there? We want to know the clinical feature से start करें. We have already written the causes. Now we want to know what are the clinical feature, diagnosis and treatment. Clinical feature, diagnosis and treatment. Right? So clinical feature क्या होता है? Acute MR. Acute MR. What is the problem? In both the situation, in both these condition, MR, okay, mitral regurgitation causes volume overload state. Volume overload state to the LV, which can lead to compensatory LVH. Which can lead to compensatory LVH can occur. This is what is occurring in both of them, right? Not both of them per se. It is for MR, pathophysiology of the MR itself. Pathophysiology of the MR itself. It causes volume overload, which eventually leads to compensatory hypertrophy to maintain the point. But in acute MR, there is no time for compensation. There is no time for compensation. In acute MR, there is no time for compensation. And that is why the clinical presentation, they present with features of acute heart failure. There is no time for compensation, so they present with features of acute heart failure. Is the most common presentation of acute MR. Most common presentation of the acute MR. So why LV? LV को volume overload क्यों मिलता है? अंजलि गुप्ता's question. Come on everybody. So remember, left ventricle contracts. Some blood regurgitates back into left atrium, but in the next cardiac cycle, that blood from the atrium comes back to the ventricle. So left ventricle squash खेल रहा है, जितना जोर से मारेगा उतना वापस उसको ही मिलता है. So the chamber affected is not LA, the chamber affected is LV only. The chamber affected is LV only, right? That is what I have explained. Good, many people had same doubt. I hope it is clear now. So acute heart failure is the most common presentation. Same way, there is no time for left atrial enlargement also, because everything is happening suddenly. There is no time for left atrial enlargement also, and that is why on examination you only get early systolic murmur. You get only early systolic murmur. Okay, you get a early systolic murmur. Early systolic murmur. Early systolic murmur because only the left atrium is a small chamber. Left atrium is a small chamber and gets filled. It gets filled in the early part of left ventricular systole itself. It gets filled in the early part of left ventricular systole itself, and that is why remember yesterday we had specifically written acute MR comes with the early systolic murmur. It is specific, not pansystolic. It comes with the early systolic murmur. Okay, early systolic murmur. Please remember the point. Early systolic murmur. It comes to you. That is examination finding. But the gold standard diagnosis is done by echocardiography. Diagnosis is done by echocardiography. Will reach the diagnosis. After the diagnosis, what is the treatment? The treatment is only one. The treatment is to go for emergency mitral valve replacement. The treatment is to go for emergency mitral valve replacement. Is to go for emergency mitral valve replacement. Emergency mitral valve replacement is the only potential cure. It is the only potential cure. You cannot do anything. This is associated with high mortality. High mortality. And that is why poor prognosis. That is why poor prognosis. That is why associated with a poor prognosis. Okay. So what we have got here, that acute mitral regurgitation. Let me show you once. We are looking at the acute mitral regurgitation. एक बार देखिए, acute mitral regurgitation. Acute mitral regurgitation happens suddenly. There is extra volume to the left ventricle, but there is no time for the ventricle to hypertrophy. So ventricle fails. So ventricle fails. Okay. So ventricle fails and presents as acute heart failure. Acute heart failure. So there is no time for LA enlargement also. So the murmur you get is only early systolic murmur. Confirmed on echo, only treatment is emergency mitral valve replacement, which has high mortality, poor prognosis. Okay, poor prognosis. Come to other side, chronic MR. Let's come to other side. The chronic MR, let us write about. So chronic MR, there is time for compensation. So in the early stages of the disease, the patient only comes with palpitation. Patient only comes with palpitation due to increased force of contraction. Patient comes with palpitation due to increased force of contraction. Increased force of contraction we have got here. Right? So here there is no characteristic echo ray. Echo shows the problem. Regurgitation by color Doppler you can see. There is no characteristic finding. ऐसा नहीं होता. So early में when the initially LV gets more volume by Frank-Starling law. By Frank-Starling law, there will be initially increased force of contraction, and that is why patient develops our palpitation. It is a well tolerated lesion. Please remember, LV is a strong chamber and hence it is well tolerated. It is a well tolerated lesion. ऐसे हम इसको बोलते हैं. Because if you give enough time for the LV to compensate, the left ventricle can pull the load. That is why well tolerated lesion, we can say well tolerated lesion. Only in late stages of the disease, when the LV cannot do anymore, patient develops hypotension and heart failure symptoms. Only in the late stages they develop hypotension and heart failure. On examination, you get a pan-systolic murmur. You get a pan-systolic murmur. You are going to get a pan-systolic murmur. You are going to get. See the difference. Here it is a pan-systolic murmur throughout the systole. Throughout the systole, we have got here. Throughout the systole, pan-systolic murmur you are going to get. How is the murmur? Pan-systolic murmur, which is best heard on expiration. Better heard on expiration and classically radiates to the axilla. radiates to the axilla or to the interscapular area. Axilla or the interscapular area. Interscapular area, it will radiate. Again, gold standard remains echocardiography. And the treatment of mitral regurgitation. Come on, this chart should be very fast. This chart should be very fast. Okay, because we are doing it for the upteenth time now. We are doing it many times we have done. What points we have to know? NYHA class of symptoms. NYHA class of symptom. We must know whether the patient has signs of heart failure. You will see what is the left ventricular ejection fraction, and if the patient needs cardiac surgery for another cause. Whether the patient needs cardiac surgery for another cause. Based on that, we can write first line of treatment. We can write the first line of treatment can be written. First line of treatment can be written. First line of treatment can be written. Okay. So questions that are coming are why hypotension. So look at like this. Anna, look at the story. Suppose left ventricle is a strong chamber. Anna, so Sanjana, think of it that there is a bodybuilder, a weightlifter, जो रोज 100 किलो उठाता है. Weightlifter can pick up 100 kilos every day. That is left ventricle. Now suppose tomorrow morning you go and join and tell the weightlifter that आज 101 उठा के दिखा. You challenge the weightlifter that instead of 100, today you lift 101. Will he be able to lift that? Answer, yes, because he is strong. So LV, when it gets small increase in volume, it actually has got increased force of contraction. That is why palpitation. And then if he trains every day with 101 kilo for a week, then 102 kilo, he can slowly increase. He can slowly increase. But there will come a time when the bodybuilder's status, the end also will be achieved. The maximum capacity of the weightlifter will be achieved. उसके बाद आप रोज 1-1 किलो बढ़ाओगे तो कभी ना कभी तो गिरेगा ना. Eventually it will fall. Eventually it will fall. है ना. Here atrial chamber is not small ना बेटा, है ना, chronic है ना. So there will be left atrial enlargement, है ना. Left atrial enlargement होता है यहाँ पर. This is a chronic disease and that is why you get a pansystolic murmur. That is why you get a pansystolic murmur. Okay, that you want to remember. Pansystolic murmur. Okay, so chalo, let us come down to the treatment. Treatment हमारा same analogy हम continue कर रहे हैं. So if the patient has got mild symptom, there are no features of heart failure, EF is preserved and patient does not need surgery, you can go for medical management. You can go for medical management. Can be done. Which drug you want to give? Fluid overload, no, volume overload है. Diuretics देंगे, ACE inhibitor देंगे और palpitation के लिए beta blocker देंगे. So very simple points you want to remember. So medical treatment can be started. Medical treatment can be started. If the disease is severe, 3 to 4, heart failure is present, EF is reduced, patient needs surgery, लगे हाथों कर दो MVR. So go for mitral valve replacement. You can go for mitral valve replacement. You can go for mitral valve replacement. You can go for. Okay. So please see the explanation she has written. Anna, Shreya, see that the pansystolic murmur, mitral regurgitation में सोचिए throughout the LV systole. throughout the LV systole, the pressure is more than the left atrium. That is why regurgitation should occur throughout the systole. Pan-systolic murmur milna chahiye in mitral regurgitation. Exception is acute MR, because acute MR may no time for Lelle enlargement. That is why the flow stops in early systole. Hence, murmur is also early systolic murmur. That is our point here, right? Pan-systolic murmur. That's why we are having. Why systolic murmur? Systolic murmur क्यों है? I think now we are gone into another level. It is time that I ignore the chat for few minutes. Then we will come back. Okay. So mitral valve replacement can be done. So here the prognosis is overall favorable. The prognosis is overall favorable, we can say. Okay, prognosis is overall favorable. Mitral valve replacement. Mitral valve replacement. Okay, MVR. Prognosis is favorable. So look at it together. So this is our acute versus chronic MR. Acute versus chronic MR. We have written down here. So among the causes of MR, can we do direct MVR? MVR only we have to do. Mitral valve replacement we have to do. Okay. So this is our acute versus chronic MR. Acute versus chronic MR. Okay. Chali. Next level. What we have got here? MVP. Then we go to infective endocarditis. We have to complete MVP. Mitral valve prolapse. Mitral valve prolapse. MVP. Mitral valve prolapse is the MVP. Mitral valve prolapse. So what is the definition? The mitral valve prolapse is due to myxomatous degeneration. It is defined as myxomatous degeneration of the mitral valve leaflets. Myxomatous degeneration of the mitral valve leaflets. Mitral valve leaflets which is there, which commonly affects predominantly affects posterior leaflet alone. Posterior leaflet alone is affected predominantly. Mitral valve leaflet, that is predominantly affecting posterior valve leaflet, leading to bulging of the leaflet. Bulging of the mitral valve more than 2 mm beyond the annulus. 2 mm beyond the annulus. This is the definition of mitral valve prolapse. So prolapse, ये शब्द हम कहाँ पढ़ते हैं? This prolapse where we typically read in gynecology. Uterine prolapse means what? When the uterus falls, comes below the normal limit. Same way, we saw that beyond the mitral valve annulus, the valve leaflet should not bulge into left atrium. But if the bulging occurs by more than 2 mm, bulging occurs by more than 2 mm, then it is called as prolapse. Then it is called as prolapse. Degeneration होता है, इसीलिए इसको बोलते हैं floppy valve syndrome. It is also called floppy valve syndrome. The valve has become weak. The valve has become weak. So mitral valve prolapse epidemiologically affects middle-aged females. Typically affects middle-aged females. There is no cause. The cause is idiopathic. We don't know why the degeneration occurs. We don't know. but in some of them there is degeneration of the mitral valve leaflets. How do they present? Clinical feature, how do they present? Majority of them present with palpitation secondary to chronic MR. They present as palpitation secondary to chronic MR, because we studied one of the causes of chronic mitral regurgitation is MVP. So if you do not treat the MVP, slowly over many years it will cause chronic mitral regurgitation, which will present as palpitation, but rarely it presents as atypical chest pain. It presents as atypical chest pain, which can mimic angina, causing anxiety. It can mimic angina, leading to anxiety. That can occur. Atypical chest pain can occur. Mimic angina. The reason is unknown. It is due to unknown mechanism. We don't know why it occurs, but we know that it responds best to beta blockers. It responds best to beta blocker. That is known to us. So clinical feature, mitral valve prolapse. Clinical feature, mitral valve prolapse. This is what we are going to get. है ना? So आप ध्यान दीजिए, MVP valvular defect है क्या? MR है क्या? नहीं, है ना? तो शेफाली शर्मा, mitral regurgitation is overall common in males. MVP is a defect, not the lesion itself. Okay, so that way speaking, MS is the only one common. Okay, so this is what MVP is a defect, not necessarily. MR की most common cause MVP नहीं होता. MR का most common cause MVP नहीं है. MR is common in males only. MVP, the one of the defect is common in females. That's all, not the entire lesion itself. So on examination, what happens? तो चलो दोनों question और आपको बताते हैं that how can the prolapse occur, how can degeneration cause bulging. थोड़ा ध्यान से देखिए. Look at the illustration carefully, then you will understand. Explain palpitation means MVP is a cause of chronic mitral regurgitation. एक पेज पीछे खोल के देखो, chronic mitral regurgitation का symptom होता है palpitation, है ना? That is why it is a correlation. So what we have got here, इसको ध्यान से देखिए. So we will draw only the LV here. Let me enlarge the LV. So LV cavity को बड़ा करते हैं. This is the mitral valve leaflet, which has got anterior and posterior leaflet. The chordae tendineae attached to the papillary muscles. Attached to the papillary muscles. इसको enlarge करते हैं. हाँ, लेफ्ट एट्रियम को एनलार्ज कर दो. रेस्पॉन्स टू बीटा ब्लॉकर मींस इट इंप्रूव्स विद बीटा ब्लॉकर. एटिपिकल चेस्ट पेन के लिए हम देते हैं बीटा ब्लॉकर, इवन दो वी डोंट नो एज द मैकेनिज्म. सो व्हाट इज हैपनिंग? सपोज एग्जांपल देखिए, ध्यान से सुनिए. अभी ट्राई टू रिमेंबर दिस पॉइंट हियर. दरवाजे का दो हिस्सा है ना. दीज आर टू पार्ट्स ऑफ द डोर and they perfectly close in the center. In the monsoon, एक दरवाजा क्या हो गया? कमजोर हो गया. हिंज उसका हिल गया, है ना? One of the door has become abnormal. Common example in rainy season. Then it does not shut properly, no? What happens to the leaflet? It closes like this. So what is happening? It is bulging, है ना? ध्यान देखो, elongated and bulging. डीजेनरेशन से वेल लीफलेट क्या होता है? इलोंगेटेड एंड बल्जिंग. दरवाजा बराबर अलाइन नहीं है. इट इज बल्जिंग इनटू द ऑपोजिट स्पेस. सो फॉर एग्जांपल, So what we have got here, suppose posterior valve commonly becomes degenerated. The posterior leaflet is commonly affected. Posterior leaflet is commonly affected. That leads to bulging. That leads to the bulging that occurs. Once it is bulging, now remember, आपका दरवाजा पूरी तरह से बंद नहीं हुआ, मतलब क्या है, इट इज प्रोन टू रिगर्जिटेशन. ऐसा नहीं कि रिगर्जिटेशन हवा से हो जाएगा. देयर हैज टू बी इनफ फोर्स टू कंटिन्यू टू हैव रिगर्जिटेशन. देयर हैज टू बी रिगर्जिटेशन. सो इमेजिन लाइक दिस, एमवीपी में दरवाजा बराबर बंद नहीं हुआ. The door is not aligned perfectly, but it still needs to be pushed open for somebody to walk in. Now you go back and remember, you have to remember the cardiac cycle. In the first part of cardiac cycle, there is isovolumic contraction. The pressure in the LV is getting stronger. It is not strong enough. In the mid systole, the LV aortic valve opens and blood goes into the aorta, because physics principle says the blood follows the path of least resistance. Only in the late systole, when aortic pressure is high and LV is finding another area, it pushes the elongated, deformed valve and has a jet of regurgitation can occur. So regurgitation can occur through the abnormal valve. It can occur, but the regurgitation MR occurs only in the late systole. Only in the late systole. Only in the late part of the systole. And before the regurgitation can occur, when the valve tries to bulge in the opposite direction, the chordae which is attached will get a tug. So before the regurg, there is a tug on the chordae tendineae. There is a tug on the chordae tendineae. Okay, and that is why which produces a click, followed by the murmur, of MR, and that is why it is also called as click murmur syndrome. So मैंने explain कर दिया आपको that in MVP there can be late systolic murmur. There can be late systolic murmur. So this is called as click murmur syndrome. MVP also called as click murmur syndrome. Gold standard of diagnosis is echocardiography. And the treatment is to treat the underlying MR. You have to treat the MR as per protocol. And you can give beta blocker for atypical chest pain. You can give the beta blocker for atypical chest pain. Prognosis is favorable. It is a degenerative, not an emergency. Prognosis is favorable. The prognosis is favorable. In the early part of the systole, the LV pressure has not reached a peak, no? LV has just started to contract. Left ventricle has only started to contract. It has not reached its full force. In the mid systole, when it reaches the full force, it forces the aortic valve open and the blood gushes into open empty aorta. And that is why only in the late systole, when aorta starts resisting resisting the flow, that the LV starts exerting pressure on the degenerated leaflet, and that time the degenerated leaflet gives way. Gives way means it bulges backwards, it opens backward into the left atrium. So before it opens backward, उसको नीचे जो hinge ने पकड़ा है chordae tendineae, उसको tug करेगा. So there is a tug on the chordae tendineae which produces a click sound, followed by the jet of regurgitation produces a systolic murmur. And that is why it is called as click murmur syndrome. That is why it is called as a click murmur syndrome. That is why important MCQ इस बार भी आया था. The important MCQ, what is the type of murmur in MR? What are the types of murmur in MR? It is asked. What are the types of murmurs in MR? Yeah. So the question, MCQ question is, what are the types of murmur in MR? So you look at this. What are the types of murmur in MR? You can get all types. So in MR, if the MR is acute MR, if the MR is chronic MR, and if the MR is due to MVP, MR is due to the MVP. Yeah, if the MR is due to the MVP. Prognosis of MVP is favorable. Prognosis of MVP is favorable. क्यों जा रहा है? So you can get the early systolic murmur, you can get pan-systolic murmur, and you can get a late systolic murmur. It can be a late systolic murmur. So the murmur can have different one. Okay. So the murmur in MR can be, all three types can be present. It can be early systolic, pan-systolic, or late systolic murmur. Okay, the prognosis of MVP is favorable. That's all I have written. So just to take you back, just I am making it small. Okay, this is what it is. Okay, so this is what we have reached MVP. We have reached MVP. Mitral valve prolapse. We have reached mitral valve prolapse. Early systolic and ejection systolic, are they the same? It is not the same. Ejection systolic is mid systolic murmur. We have written before yesterday. So look at this chart. I'll take you back to that murmurs chart that we have made. Yesterday when we spoke about the murmur, so now see if you are able to understand the chart better. See if you are able to understand this chart better. So these are our murmurs. Look at it very carefully. This is the murmur that we have written also. So systolic murmur we have noted. Acute MR can cause early systolic murmur. Chronic MR can cause pan-systolic murmur. And MVP can cause late systolic murmur. Can cause the late systolic murmur. Okay. So grades of MVP not important to us. Okay. Not important for our MCQ and MBBS practice. Right. So we have completed all our structural, that is valvular heart disease. We have completed valvular heart disease. Yeah. So yes, it has been a little underestimation of the time by me. Infective endocarditis will take 1 more hour. So what we will do now is take a 15-minute break. We will take a 15-minute break now till 3:45. Till 3:45 and then start with infective endocarditis. Okay, we'll take a short break and start with the infective endocarditis. We will begin with. Okay, click का मतलब बस इतना ही है रे. हाँ, click का मतलब क्या है? That when the tug is happening, है ना? When you imagine करो ना, दरवाजे को जोर से धक्का मारते हो, opposite direction, the hinge आपको कड़क हो जाता है ना? Hinge will hold on. It will prevent backward the bulge, and that will cause a tug. That sound will be there. You try opening your door in the opposite direction, है ना? You will hear the sound. That is called is the tug, right? So infective endocarditis we will do. Okay, so break till 4. 4 का क्या है? 4 significant क्या है? Okay, चलो, no, 3:45, 3:50, है ना? Maximum I can extend till 3:50. Okay, you can come back. We didn't have lunch. Okay, didn't have lunch. Okay, take till 3:55. Okay, don't worry, come by 3:50. We'll start. Okay, have lunch and come 20 minutes. Chalo, bye. Right, so welcome back. So now we want to start with our infective endocarditis. So after valvular heart disease, we want to learn about infective endocarditis. We want to learn about infective endocarditis. Right. Okay. So infective endocarditis, again a topic which typically we tend to get stressed about. So again we are going to make simple flow charts, make it very simple for us to remember. So it is easy. Infection of the endocardium. Infective endocarditis. Infection of the endocardium. Please remember, intact endocardium cannot be infected. Please remember that the intact endocardium cannot be infected. Intact endocardium cannot be infected. It cannot be infected, and that is why for infective endocarditis to occur, we need to have presence of predisposing conditions. Okay, slide to slide I want you to carry, slide to slide. So there is predisposing conditions for the risk of infective endocarditis. I want us to know predisposing conditions for the risk of infective endocarditis. I want us to know here. Intact endocardium cannot be infected. So we want to know what are the different predisposing conditions for infective endocarditis. Number 1, we can have congenital heart disease. Congenital heart disease, among which VSD has got the highest risk. Among which with the VSD has got the highest risk. It can be due to valvular heart disease, among which the MR has got more risk. MR has got the most common valvular lesion associated with native valve endocarditis. Associated with native valve endocarditis. Associated with native valve endocarditis. Number 3, it can be due to prosthetic valve. Can be due to prosthetic valve. It can be related to IV drug abuse. IV drug abusers. IV drug abuse, or it may be due to intracardiac device. Intracardiac devices which have got the least risk. Which have got the least risk of developing endocarditis. Okay, least risk of endocarditis we want to know. So the dental surgery is not a predisposing condition. Wrong. That's not the way. Native valve endocarditis. Native valve endocarditis. Okay. So infective endocarditis cannot occur in an intact endocardium. Usually there is damage to the endocardium by any one or more of these disposing features, which can make the valve weak and predispose it to getting an infection. Okay, predispose it to getting an infection, right? Next point, what are the causative organisms? Let us write down. What are the list of causative organisms? Let us make a list of causative organisms. The causative organisms causing infective endocarditis depends on the following factors. 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 Causative organism. So first we broadly classify endocarditis into native valve endocarditis. We classify them into native valve endocarditis. We classify them into native valve endocarditis. And we can have prosthetic valve endocarditis. We can have prosthetic valve endocarditis. The prosthetic valve endocarditis can occur. So the causative organism are different based on the type of the valve affected. Based on the type of the valve affected, the causative organism that you will suspect will be different. Causative organism will be different. So in the native valve, we are going to further classify them into those which are treatment naive cases. Those which are treatment naive cases. And those who have been exposed to the healthcare. Those who have been exposed to the healthcare within the past 90 days. Within the past, there are variable figures, so we can look at 60 to 90 days. We can look at the spectrum here, 60. So we can take for convenience past 60 days exposed to the healthcare. That is another category. Okay. So what we have got in the native valve endocarditis, we will divide the risk probability, probable causative organism, probable causative organism. चलो last slide एक देखते हैं. Okay, so after break, this is the first slide. This is the first slide after break. We have started with the topic of infective endocarditis. We have written the predisposing conditions. We have written the predisposing conditions. Infective endocarditis. Done, everybody? Then we have started writing what are the causative organisms. What are the causative organisms? Causative organism can be broadly classified based on the valve affected. Native valve endocarditis versus prosthetic valve endocarditis. We can divide them into two groups. So treatment naive versus those exposed to healthcare. That means what? Treatment naive means those who have not visited the doctor, not gone to the healthcare within the last 60 days. Within the last 60 days. आगे आंसर है ना, उसके ऊपर ध्यान दो ना थोड़ा सा, है ना. ट्रीटमेंट नैव केस का मतलब क्या है? Those who have not visited a doctor within the last 60 days. That means in the last 2 months. Just imagine this scenario. Imagine the scenario. Suppose the patient, background noise. Suppose this scenario that suppose I visit a dentist for my root canal treatment, and suppose I have received the amoxicillin antibiotic for my dental procedure. So does the amoxicillin know कि तेरे को dentist ने prescribe किया है? Answer: no. Amoxicillin does not know. Dentist has prescribed. Amoxicillin is going to eradicate all the bacteria which are sensitive to amoxicillin in the body. So suppose in spite of taking amoxicillin today, I develop endocarditis 1 month later, that is within 60 days. What the organism is likely to be? The organism is likely to be resistant to amoxicillin. But which if I do that we get it treatment naive, means patient has never gone to the healthcare before within the last 2 months, and now we have got the infection. But the infection is likely to be with sensitive organism. Infection is likely to be with sensitive organism, we can say. So in a treatment naive case, the most common causative organism is Streptococcus viridans. Most common causative organism is Streptococcus viridans. Is the streptococcal viridans, we can say, is the streptococcal viridans. So along with that, followed by at number 2, we have got Staph aureus. But which type of Staph aureus? Methicillin sensitive Staph aureus. Methicillin sensitive Staph aureus, that is MSSA. Methicillin sensitive Staph aureus that we have. Sorry, I have not written the full thing. Treatment naive cases. Sorry, इसको full लिख देता हूँ. Treatment naive cases. Okay, treatment naive cases that we have got. So those who are not exposed to the antibiotic therapy. It can also be due to the Hasek group of organism. Can be due to the Hasek group of organism. So what is the full form? Hasek. H for Haemophilus. A for Aggregatobacter. A for Aggregatobacter. C for Cardiobacterium. C for Cardiobacterium. E for Eikenella species. And K for Kingella species. So note down the point. So when the patient has not been visiting the doctor or not received antibiotic within the last 60 days, then they are likely to be infected with sensitive organism. They are likely to be infected with the sensitive organism. But if the patient has been exposed to the healthcare, they are likely to be due to resistant organism. But in MCQ, the answer still is methicillin sensitive Staph aureus. Even in the healthcare exposed situation, even today, the most common type of staphylococcus is the methicillin sensitive Staph aureus. You can also get infection with enterococci. Infection with enterococci. Infection with cornybacterium. Infection with cornybacterium can be there. Patient can have infection with MRSA. Can have infection with Pseudomonas. Infection with Pseudomonas, can have infection with Candida species also. So we are all familiar, if the patient takes broad spectrum antibiotic, then they are prone to develop fungal infection. They are prone to develop fungal infection that can happen. So among the treatment naive patient, if the patient is treatment naive, you can get infection with strepto, MSSA, HSA group of organism. In exposed setting, methicillin sensitive Staph aureus, enterococci, cornybacterium, MRSA, Pseudomonas, Candida species are the possible causative organism. The odd man I want you to remember in the treatment naive group is the Coxiella species, because it is a fastidious organism. Fastidious organism means those who are difficult to grow in culture. I want you to remember specifically Coxiella species, which are difficult to grow in culture. Which are difficult to grow in culture. In the prosthetic valve endocarditis, depending on within the first year of surgery. Within the first year of the surgery or the procedure, within the first year of valve replacement and after the first year of the surgery. After the first year of surgery, the answer will be different. Within the first year of surgery, the most common organism is cons. Most common organism is cons. Cons is coagulase negative. Coagulase negative staphylococci. Coagulase negative staphylococci. Example is your Staphylococcus epidermidis. Staphylococcus epidermidis is the most common causative organism. Correct. Staphylococcus epidermidis. Coagulase negative staphylococci. Right. So after the first year, the organism is same as native valve endocarditis. The answer will be same as native valve endocarditis. About Coxiella, I said that they are fastidious organism. Fastidious is a microbiology term which tells you that they are difficult to grow in culture. They are difficult to grow in culture. Yes, correct. And the special category, those in IV drug abusers. In IV drug abuser, most common causative organism is Staph aureus. In IV drug abuser, most common okay. So please write them. Coxiella is a sensitive organism. So maybe the column had got misplaced. It include it under treatment naive patient. Causes, treatment naive cases you can get. So these are the various causative organisms of infective endocarditis. So these causative organisms are typically, they are called as the typical organisms causing endocarditis. They are labeled as the typical organisms causing infective endocarditis. They are called as the typical organisms causing infective endocarditis. Okay, so we are going to learn infective endocarditis in the steps. We are going to learn it in the different steps. Break down the topic into parts. First, we have understood which are the predisposing conditions. Second, we have understood which are the causative organism. You can make out from the chart who will be overall most common. Overall most common, who will be there? Staphylococcus aureus. Overall most common will be Staphylococcus aureus. IVDA is a separate category. This column is over, a separate column है. IV drug abuser ये separate column है. IV drug abuser is a separate column. It is not under anybody. And there also it is going to be Staphylococcus aureus. That is why overall most common is staph. And most common is not MRSA. It is MSSA. Methicillin sensitive staph aureus. Important point. Methicillin sensitive staph aureus. That is what is important to remember. Okay, so continue further. So once we know the causative organism, we want to know pathophysiology with clinical feature. So what is the pathophysiology of infective endocarditis with the corresponding clinical feature? This page is very important. This page is very important. So write it neatly. What is the pathophysiology? Pathophysiology of infective endocarditis. So what happens here? First, the predisposing condition. The predisposing condition causes endocardial injury. The predisposing condition causes endocardial injury. Predisposing condition causes endocardial injury. It causes endocardial injury. It causes. Okay. Whenever there is an injury in the body, obviously what is going to happen? Healing will occur. There will be healing by formation of. There will be healing by formation of fibrin-rich clot. Formation of fibrin-rich clot at the site of injury. At the site of injury, there will be a formation of fibrin-rich clot. Fibrin-rich clot. Okay. Now, this stage is called as the non-bacterial thrombotic endocarditis. This stage is called as the non-bacterial thrombotic endocarditis. Because healing means inflammation is present, endocarditis present, but this endocarditis has no infection. Till now, it is a sterile, it's a sterile clot which is physiological so far. But if the patient unfortunately at the same time develops transient bacteremia, if the patient at the same time develops transient bacteremia, which is most commonly post dental surgery. Most commonly it is post the dental surgery. Most commonly it is post the dental surgery. Post the dental surgery. most commonly post the dental surgery. Most commonly post dental surgery occurs at this time. So what is happening on one side? The patient has got a predisposing condition which has caused injury to the endocardium. Endocardium is trying to heal itself by formation of a fibrin rich clot. But at the same time, there is bacteremia. So this bacteremia can bind to the clot. This bacteremia binds to the clot. This bacteremia binds to the clot and forms the infective endocarditis vegetation, and it forms the infective endocarditis vegetation. Okay, what is vegetation meaning? I'll tell you. Vegetation means fertile growth, area for the growth. Vegetation, it is the growth. Okay, it is the growth. याद रखिए, it is the growth. Infective endocarditis vegetation. Come understand. So the endocardium is injured. On that the bacteria bind to the clot, and over that there is platelet adhesion. So bacteria क्या करता है? घर बसा लेता है. The bacteria forms a roof of platelet around himself, and that is why it cannot be cleared by the immune system, and sitting there the bacteria proliferates. That is why it is called as a vegetation. That is why it is called as a vegetation. Now colors will come. So infective endocarditis vegetation में most common symptom. What is most common feature? 90%. Most common feature. Sorry. So the most common feature we will see, infective endocarditis vegetation is formed. In that, the most common feature is fever due to bacteremia, seen in 90% of the cases. So the most common feature of bacterial endocarditis is fever. Most common feature of bacterial endocarditis is color. So this is the fever, 90% of the cases. But unfortunately, it is non-specific, because fever alone cannot be used to diagnose the infection. Cannot be used to diagnose the infection. So infective endocarditis presents with fever, most common feature, but that is non-specific for the diagnosis. The other diagnosis, the other features of endocarditis depends on the following mechanisms. Depends on the following three mechanisms. The further manifestation depends upon the following three mechanisms, which I am going to teach you. So what can happen at the vegetation? There can be direct spread of the bacteria. There can be a direct spread of the bacteria. There can be direct spread of the bacteria to surrounding structures. There can be direct spread of the bacteria to the surrounding structures, which can lead to different manifestation. Number two, there can be vascular embolization. There can be vascular embolization of the infected clot. Vascular embolization of the infected clot. And finally, there can be immune complex formation. There can be immune complex formation. leading to the different manifestation of the disease. So we are writing mechanism, not just a clinical feature. We are writing the clinical feature with mechanism. We are writing the clinical feature with mechanism. We are trying to understand here. We are trying to understand here. So, most common feature of infective endocarditis was fever. That is due to the associated bacteremia. But features can also occur. Features can also occur due to direct spread of infection to the surrounding structure. Vascular embolization of an infected clot and immune complex formation can occur. Now, direct spread of infection to surrounding structure, where can it go? It can lead to the underlying valve or the prosthesis. The infection of the endocardium can affect the underlying valve or the prosthesis, which can lead to dehiscence or damage to the structure. Dehiscence or damage to the structure, which can lead to either acute MR, can lead to acute AR, or it can lead to abnormal prosthetic function. It can lead to abnormal prosthesis function. Abnormal prosthetic function. Abnormal prosthetic function. All this can lead to heart failure. This can lead to acute heart failure patient can present with. So the patient of infective endocarditis can present as heart failure is a true statement. And why the heart failure occurs? Either due to damage to the valve, which can cause acute regurgitation, or abnormal prosthetic function leading to acute heart failure. Number 2, it can lead to formation of paravalvular abscess. The infection can spread to the para, what is around the endocardium. This indicates spread to the myocardium. The muscle develops abscess. याद रखिए, पैरा का मतलब है नेबरिंग. पैरा मीन्स नेबरिंग स्ट्रक्चर. So endocardium is the primary site of infection. Primary site of infection. But beyond the endocardium, there is also myocardium, which can develop paravalvular abscess, which can lead to septicemia. Which can present as septicemia. It can present as septicemia. We can say that. It can present as septicemia. We can say that. Okay. So we have got different manifestation. Why AR? Aortic valve can also be affected, no? Aortic valve can also get endocarditis. So this can lead to septicemia. Aortic valve can also get damaged. So patient can come with septicemia. So we can see patient can come with acute heart failure. Patient can present with septicemia. Can present as septicemia. And these features are due to direct spread of the infection to the surrounding structures. Vascular embolization, these are called as vascular phenomena. Vascular phenomena can be due to systemic embolization to the organs. Systemic embolization to the various organs. Which are the organs? It can spread to the brain, the spleen, the kidney and the lungs. we say no, flea bitten kidney in bacterial endocarditis. So the infected clot can spread to the organs, leading to infarct plus microabscess formation. There is not just infarct, along with that there is microabscess formation can occur. Okay, it can lead to microabscess formation. Okay, so there is flea bitten kidney. You remember flea bitten kidney. All the valves can be affected. Most common is mitral valve, because remember it is the endocardium has to be defective. Mitral regurgitation, aortic regurgitation are risk of endocarditis. That is why they are more commonly affected. Number 2, there can also be embolization to the periphery. Embolization to the periphery can present as the classical toenail hemorrhages. There can be toenail splinter hemorrhages. So peripheral embolization, toenail, you can see the splinter hemorrhages. You can see Genovese lesions. Genovese lesion can be present on the palms. Genovese lesion can be present in the periphery. Toenail will have splinter hemorrhages. Genovese lesion can be present. Genovese lesion can also be present. And then there can be intracerebral hemorrhage. Intracerebral hemorrhage can occur, especially in mycotic endocarditis. In mycotic endocarditis can lead to aneurysm formation and rupture. Intracerebral hemorrhage is a complication of fungal endocarditis. Remember, it is a manifestation of fungal endocarditis. We want to remember fungal endocarditis. Genovese lesion is painless. Okay. Immune complex formation can lead to glomerulonephritis. It can lead to arthritis. It can lead to inflammatory arthritis with RA factor positive. Roth spots can occur in the retina, and there can be Osler's nodes. Which are the painful nodules on the fingertips. Osler's nodes are the ones which are painful nodules on the fingertips. So you must remember, MCQ पूछते, which are the vascular phenomena, which are the immunological phenomena of bacterial endocarditis. Okay, so we have classified all the manifestations of endocarditis along with its mechanism. We have written down all the different manifestations of the disease along with its mechanism. We have written it down. So एक बार पूरा chart देखिए. Look at the whole chart together. What we want to know in the pathophysiology. एक बार और, है ना? So look at it closely. This is the whole concept of infective endocarditis. infective endocarditis, है ना. Honestly speaking, Abhishek, आजकल इमेज का जमाना चला गया. I mean, if you want to see an image, all you have to do is Google it. Okay, you Google and you can see. Why are you stressing out on seeing the image? First, get the theoretical concept here. Images are freely available, online, but the concept is not. This whole information is there in every medicine book, but the way of explanation is what is unique in this class, right? So otherwise, this information is freely available. So आप पहले ध्यान किस पे देंगे? Concept पे ध्यान देंगे, है ना. Try to understand here that the way to remember what are the clinical points I want you to take home with you. Okay, so what we have got here pathophysiology. So predisposing condition से injury होता है. उसके बाद clot formation. After clot formation, if there is bacteremia, you will get infective endocarditis. You can get. Beyond that, endocarditis can come as fever, can come as heart failure, septicemia. They can come as systemic embolization, peripheral signs, or intracerebral hemorrhage. And there will be glomerulonephritis, arthritis, rod spot, osseous nodule can occur. Osseous nodule can be occur. So this is what here. So these are our clinical manifestation and pathophysiology of infective endocarditis. So come to the diagnosis. Next step. What is the diagnosis here? Let us see how to make the diagnosis of infective endocarditis. Then we will cover the treatment. So for the diagnosis of infective endocarditis, we are using the modified Duke's criteria. We are using the modified Duke's criteria for diagnosis of the disease. The good part of the criteria is what? It is 98% specific. The specificity is better than the sensitivity. 96% sensitivity. Matlab, it is preferred criteria because it has got high sensitivity, high specificity. Mycotic aneurysm can lead to rupture, which can cause intracerebral hemorrhage. RA factor is rheumatoid factor. Okay, this is the one that we want to use here. So what will be the points? Let us see. Yes, so what are the points here? Modified Duke's criteria. They are divided into the two major criteria. We have got the two major criteria for diagnosis. And we have got the 5 minor criteria for diagnosis. So we have got the 2 major and the 5 minor criteria for diagnosis of infective endocarditis. We want to know infective endocarditis. So the first major criteria is to have positive bacteriological evidence. A positive bacteriological evidence is to have a positive bacteriological evidence. That is the first major criteria. Okay, there is a positive bacteriological evidence. Okay, positive bacteriological evidence. So what are the components? It can include if there are 2 or more blood culture positive for the typical bacteria, for the typical organism, more than equal to 2 blood cultures are positive for the typical organism. Can be there, or you can have persistent blood culture positive. Persistent means blood culture is positive. Blood culture positive drawn 12 hours apart. Two blood cultures are positive drawn 12 hours apart. So persistent means two blood culture positive which are 12 hours apart, or the patient has got single culture, one blood culture positive for fastidious organism. One blood culture positive for the fastidious organism. Means which organism? Coxiella. Fastidious organism. Or the patient is having antibody titer. Patient is having more than 1:800 titers of IgG antibody. IgG antibody against Coxiella. Against Coxiella. This is called as positive bacteriological evidence. Positive bacteriological evidence. Okay, so what we have got here? First, when you suspect endocarditis, what we do? We send at least 3 sets of blood culture. Each set of blood culture contains 2 bottles. So total we send a minimum of 6 blood cultures in a 24-hour period. When we suspect the diagnosis, we send at least 6 blood culture bottle. 6 blood culture bottle in the laboratory within 24 hours. So if more than 2 of those blood cultures are positive for typical organism, they are persistently positive, or one culture for fastidious organism, or more than 1:800 titer of IgG against Coxiella, we have to know. Against Coxiella is the one. Number 2, the positive echocardiographic evidence. There is the positive echocardiographic evidence. Positive echocardiographic evidence must be there. So when do you say the echo evidence is positive? When you see oscillating intracardiac mass. You see an oscillating intracardiac mass. Okay, intracardiac mass, oscillating intracardiac mass. Or if there is a presence of paravalvular abscess. If there is a presence of paravalvular abscess, or there is a presence of partial dehiscence of the prosthesis. There is a partial dehiscence of the prosthesis, or there is a new onset regurgitant lesion. There is a new onset regurgitant lesion which is present, can be taken as a major criteria for infective endocarditis. For the infective endocarditis, the 2 blood culture are taken minimum 6 hours apart. Minimum 6 hours apart you have to take. So you have to send, but you send multiple bottles. Out of that, the one bottle which was sent first and one bottle which was sent last, difference of more than 12 hours, come positive. Then also you consider it as the positive bacteriological evidence. Okay, so this is our major criteria. Minor criteria include the presence of number 1, presence of predisposing condition. The presence of predisposing condition. Number 2, presence of fever more than 38 degrees Celsius. Presence of any one or more vascular phenomena, vascular phenomena, or presence of immunological phenomena, presence of immunological phenomena, or the blood culture is positive, blood culture is positive but not enough to satisfy the major criteria, not enough to satisfy the major criteria. So these are the 5 minor criteria. These are the 5 minor criteria. These are the 5 minor criteria that needs to be satisfied. That are the minor criteria that need to be satisfied. So for diagnosis of the disease, what do you want? For diagnosis of the disease, for diagnosis of the disease, what you want? You can have 2 major criteria positive, or you can go for 1 major plus 3 minor positive, 1 major plus 3 minor positive, or you can go for all 5 minor positive for diagnosis of the disease. So this is our modified Duke's criteria. This is our modified Duke's criteria that we have written now. It is the most preferred criteria. It is the most preferred criteria because it is both sensitive and specific. Because it is both sensitive and specific. So major criteria are 2 in number. Listen carefully. You are asking questions and confusing everybody else also. Okay. So positive criteria, what I told you, when you suspect bacterial endocarditis, you will send the 3 sets of blood culture. You will send 3 sets of blood culture drawn at least 6 hours apart. So total you will be sending, each set contains 2 bottles. So total you will be sending 6 blood culture bottles. But the first set and the second set will be drawn 12 hours, 6 hours minimum apart. So the difference in first and third will be at least 12 hours apart. So 1 bottle from first set and 1 bottle from third set comes positive, then you consider it as a major criteria. Okay, that is the point here. That is the major point. It is not like difference. It is just another way of confirming that it is a positive bacteriological evidence. That's all. Keep it simple. Echocardiography mein any one has to be satisfied. Any one has to be satisfied. Minor criteria, total for diagnosis we need 2 major or 1 major plus 3 minor, or presence of all 5 minor criteria can confirm your diagnosis. Can confirm your diagnosis. Okay. So once the diagnosis is confirmed, let's proceed to the treatment. Once the diagnosis is confirmed, let's proceed to the treatment. The treatment and prognosis of infective endocarditis. Okay, prognosis of the infective endocarditis. Let us start. Okay, so vascular phenomena. Yes, vascular phenomena all blue. Immunological phenomena all purple ones that we want to know. 5th minor criteria is blood culture positive, not enough to satisfy major criteria. That's all. Okay. So come to the treatment, management of infective endocarditis. So remember the first line treatment, infective endocarditis, infective endocarditis, infective endocarditis. The first line treatment is always medical. Remember the point. the first line treatment is always medical, but there are specific indications for surgery. There are specific indications for surgery. There are specific indications for surgery. So, first line treatment is always to go for the medical management. After that, you must search for indications for surgery. Indications for surgery, right? That is how we want to understand specific indications for the surgery. So, first line treatment, medical treatment is in the form of IV empirical antibiotic. It is in the form of IV empirical antibiotic. IV empirical antibiotics need to be prescribed for minimum duration. For a minimum duration of 3 weeks. That is 21 days. So every patient who is confirmed case of infective endocarditis must receive at least 3 times. It requires at least 3 weeks of antibiotic therapy. Okay, 3 weeks of antibiotic therapy needs to be given. But important question is, what is the choice of antibiotic in MCQ? Choice of antibiotic in MCQ. Okay, so let us write down different phases and what is the choice of antibiotic. Let us make a chart here. If the patient has treatment naive, if the patient is a case of treatment naive native valve endocarditis, that means it is a sensitive organism. That means it is a sensitive organism. Sensitive organism, right? So here we can do single drug therapy. You can give IV penicillin, or you can give third generation cephalosporin. You can prescribe IV penicillin, or you can give third generation cephalosporin. So in a patient of treatment naive native valve endocarditis, you want to know single drug therapy, IV penicillin or third generation cephalosporin can be given. Okay, now next point here, if the patient is not treatment naive, patient is native valve endocarditis who is exposed to healthcare, the healthcare within the past 60 days. That means risk of resistant organism is there, but the treatment will be IV nafcillin plus IV gentamicin, dual antibiotic therapy. IV nafcillin plus the IV gentamicin is preferred in this patient. It is preferred in this patient. If the patient has got the suspected MRSA, patient has got suspected MRSA, then what happens? You will replace the penicillin group. You will replace the penicillin group with IV vancomycin. Replace the penicillin group with IV vancomycin. से replace करोगे. If you have a suspected MRSA in a patient who is critical state or with additional renal failure, then vancomycin is not considered reliable. So what you have to do? Here we have to consider IV linezolid, or you can consider IV daptomycin. IV daptomycin can be considered in this patient if the patient has got prosthetic valve endocarditis, you will add rifampicin to cover for cons. You will add rifampicin to cover for the cons. Coagulase negative को कवर करने के लिए you will add rifampicin. You will add the rifampicin. That is the simplified chart. So read the question in the exam. What are they describing? If the patient is having native valve and treatment naive single antibiotic therapy, patient is exposed to double antibiotic therapy. If you consider MRSA, give vancomycin plus gentamicin. If MRSA is critical or renal failure where vancomycin cannot be given, then you will consider linezolid or daptomycin. And in a prosthetic valve, you will add rifampicin to cover for cons, coagulase negative staphylococcus. Specific indications for surgery. Specific indications. What are the things? Emergency indications. Means within 24 hours you have to operate. There will be emergency indications can be there. Emergency indication will be there. So you have to add rifampicin to whatever else is there. So if the patient has prosthetic valve along with exposure to healthcare, then you will give the nafcillin, gentamicin and rifampicin. And if you have native valve, you will give cephalosporin plus rifampicin. Accordingly, you have to add. Yes, correct. Vancomycin plus gentamicin. Correct. That's the way to think in MRSA. Emergency indications when the patient has got acute MR, acute AR leading to heart failure. Patient has got intracardiac fistula. Patient has got intracardiac fistula. Then that is an emergency indication. Patient has got unstable prosthesis leading to heart failure. Then there will be no other choice but to operate the patient, remove the infected valve and put a new valve, should be given. Next indication can be elective indication. There can be elective indication. That means you want to do the surgery within 7 days. Elective indications. Here, when the patient has got large vegetation, more than 10 millimeter in size, because there is increased risk of embolization. There is the increased risk of embolization. If the patient has got mycotic vegetation, because there is increased risk of intracerebral hemorrhage, or if the patient has got, है ना, ये add rifampicin अभी मैंने समझाया आपको, है ना, सुमन गुप्ता. Again rewind and hear. When the lecture is uploaded, you will get the answer. Mycotic vegetation is there. Then you go for planned surgery because there is increased risk of intracerebral hemorrhage. Intracerebral hemorrhage. Yes, prosthetic valve can get infected. It is possible. Or if the patient has got or if the patient has got refractory, resistant organism as per blood culture, resistant organism as per the blood culture, then I will give empirical. Along with that, I will proceed for surgery. I will proceed for the surgery has to be performed in these cases. When there is resistant organism, antibiotic is showing resistant to the organism in the blood culture, then I have to go for the elective surgery. And then there is delayed indication. That means after 7 days. Delayed indication after 7 days. What we have to do? Delayed indication. When the patient is still having persistent culture positive. Patient has culture positive in spite of 10 days of appropriate antimicrobial therapy. Appropriate antimicrobial therapy. Antimicrobial therapy. Even after giving 10 days of antibiotic, if the patient continues to have culture positive, then it becomes an indication for surgery. Becomes an indication for surgery. We can do that. Becomes indication for surgery. Screen is little blurred. Screen is little blurred, but I think we can make out if you hear what I am talking also. हेलो हाँ एक बार देखना स्क्रीन ब्लर हो रहा है थोड़ा सा एक बार चेक कर हाँ हाँ ओके 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 Yes, ठीक है. So we'll continue here. Now it's all fine. I can also see this. So my app is also in front of me. Okay, so all is well, and we can clearly see as well as hear. Okay, chalo. It's not blurred. Everything is clear. So we have written down the treatment of infective endocarditis. Treatment of infective endocarditis we have written down. Chalo. So what is the point here? Prognosis. So final point is the prognosis. The prognosis depends upon the success of response to medical treatment. The prognosis depends on success of medical treatment alone. Success of medical treatment alone decides the prognosis. Decides the prognosis. Decides the prognosis. So in a native valve endocarditis and a prosthetic valve endocarditis, the success is different. In native valve endocarditis, the success rate is almost 60 to 70%. That is why the prognosis is favorable. Prognosis is favorable. But in prosthetic valve, only 30 to 40%. Means majority need surgery making the prognosis unfavorable. Majority require surgery, making the prognosis unfavorable. That's what we want to know. Okay, so what we have got here, prognosis of infective endocarditis. We have written down the prognosis of the infective endocarditis. So the endocarditis vegetation is seen on echocardiography. When you do the surgery, you remove the infected part of the endocardium. If it's a valve, you will have to replace the valve. You will have to replace the valve. If surgery is required, the prognosis becomes poor because cardiac surgery itself is a high risk surgery. Cardiac surgery itself is a high risk surgery, right? So this is our topic of infective endocarditis. Okay, so there is no, we continue, empirical therapy has to be given even if organism is resistant. Okay, so we complete the topic of infective endocarditis. तो चलो ले जाता हूं आपको, कहां पर हम स्टार्ट करें. So we said that we want to start in this session. थोड़ा हम लोग लेट चल रहे. So we have completed this topic instead of 3:40. We have completed at 5 o'clock. But with break. So what we have done? We have completed the topic valvular heart disease and infective endocarditis. Valvular heart disease and infective endocarditis we have written, right? So what is remaining here? 5 o'clock. We will start cardiomyopathy. So revised time 8 o'clock हो जाएगा, है ना. Revised time 8:30 with break, without break 8 o'clock, है ना. So we will keep. So revise कर देते, टाइम थोड़ा सा आगे कर देते, 1 hour possible we will do. So today's class we will continue cardiomyopathy and heart failure. We will complete at 8:30. Okay, so we will take a break in between. Okay, we will take a break in between, don't worry. So but we will be able to complete that in our scheduled time. Okay, चलिए, इतना break we don't want here. So we'll continue further with cardiomyopathy. चलो, so let us start with the topic cardiomyopathy. Very simple. Start with the topic cardiomyopathy. Okay, chalo. So we let us start with the topic of cardiomyopathy. We'll start with the topic cardiomyopathy. We want to start with. Chalo. So what is cardiomyopathy? It is basically the primary disease of the myocardium. So cardiomyopathies are basically primary disorders of the myocardium. Primary disorders of the myocardium are called as cardiomyopathy. The primary disorders of the myocardium is called as the cardiomyopathy. These cardiomyopathies based on echocardiography are divided into 3 types based on the echocardiography. Based on the echocardiography finding, echocardiography finding and the color Doppler, and based on the left ventricular ejection fraction, based on the echocardiographic findings and the left ventricular ejection fraction, based on the echocardiographic finding and the left ventricular ejection fraction. The cardiomyopathies are divided into 3 types. They are divided into 3 types. So based on the echocardiography finding and the left ventricular ejection fraction, they are divided into the three types. Okay, so that is why we have to divide them. Let us learn it together. Simple topic. Cardiomyopathy actually is only one page. You can see this in this picture now. The dilated cardiomyopathy, that is DCMP, is the most common. They are divided into three types. The most common is our dilated cardiomyopathy. We have got second column for restrictive cardiomyopathy. We have got the restrictive cardiomyopathy. And finally we have got the hypertrophic form of cardiomyopathy. The hypertrophic form of cardiomyopathy. Please remember, HCM is important. HCM is important. So dilated form of cardiomyopathy, there is restrictive cardiomyopathy, hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, divided into the three types based on echocardiography finding and left ventricular ejection fraction. So why the name dilated cardiomyopathy? Why the name? Let us write about it. The dilated cardiomyopathy is called so because there is dilatation of the ventricles. There is dilatation of the ventricles with loss of systolic function. That is why the name dilated cardiomyopathy. So on the echocardiography, you can see that the ventricle has dilated, but the pumping has become poor. Left ventricular ejection fraction can come down dramatically to 10 to 20%, very severe. So 10 to 20% severe loss of systolic function. There is a severe loss of systolic function, and that is why it is called as the dilated cardiomyopathy. The restrictive form, as you can see the name, what happens? It restricts the ventricular filling. Remember yesterday's class, predominantly affects which phase? Early filling or late filling? You tell me. Yesterday we understood that ventricular filling occurs in two phases. Early filling depends on the compliance of the ventricle, muscle itself. Late stage is because of the atrial kick. तो muscle किसको affect करेगा? Early filling phase is affected, which causes mild reduction in the ejection fraction, because the disease is slowly progressive. अचानक कम नहीं हो जाता. It is going to be slowly progressive, leading to reduction in the ejection fraction. Very good. Hypertrophic cardiomyopathy is characterized by the presence of ASH. What is ASH? Asymmetrical septal hypertrophy. With preserved ejection fraction. There is a asymmetrical septal hypertrophy. is seen on the echocardiography. That is why the name is given hypertrophic cardiomyopathy. That is why the name is given hypertrophic cardiomyopathy. So cardiomyopathies are luckily rare in clinical practice but common in MCQ. They are important in practice because of the epidemiology. The epidemiology of cardiomyopathies makes the topic important because it typically affects young 20 to 40 years. Young healthy males are affected. So whenever a disease affects healthy adults, it is considered important because 20 to 40 is the productive age group. That is the time when you are having education, you are having job, you are having a career. If this age group is affected, it can destroy the quality of life very severely. That is why, luckily, though rare, cardiomyopathies are extremely important topics in clinical practice also. In the clinical practice also. Take it forward. Our same protocol we have to cut paste. So we have written definition, epidemiology, come to the causes. Rather than causes, we have got risk factors. There are causes or risk factors for development of different types of cardiomyopathy. Different types of cardiomyopathy is going to be there. Okay, so in dilated cardiomyopathy, it can be due to alcohol consumption. Alcohol use can lead to the dilated cardiomyopathy. It can be secondary to post-myocarditis. Post-myocarditis, most common being adenovirus infection. Among the infection, most common being adenovirus infection. Number 3, it can be due to adriamycin toxicity. Adriamycin toxicity can lead to dilated cardiomyopathy. It can be due to nutritional causes. So nutritional causes include beriberi, thiamine deficiency. Beriberi can lead to our dilated cardiomyopathy. It can be also due to peripartum cardiomyopathy. It can be due to peripartum cardiomyopathy. Peripartum cardiomyopathy, right? And number 6, it can be also due to uncontrolled PSVT. It can be due to untreated PSVT, paroxysmal supraventricular tachycardia. If you do not treat the patient by radiofrequency ablation, the patient can develop tachycardia associated cardiomyopathy. Can develop tachycardia associated cardiomyopathy can occur, leading to the dilated cardiomyopathy. So, in a dilated cardiomyopathy, predict the clinical feature. Predict the clinical features for me. When the severe loss of the function occurs, and it occurs acutely. So, most common presentation is acute heart failure is the most common presentation. It can present as the heart failure, adenovirus, myocarditis, adenovirus. So acute heart failure, it can also present as chronic heart failure. It can gradually progressive heart failure can be presentation of the disease. Yes, presentation of the disease. Compare it. Restrictive cardiomyopathy. Restrictive cardiomyopathy, 95% cases are due to infiltrative disorders. That is why restrictive is also known as infiltrative cardiomyopathy. It is known as infiltrative cardiomyopathy. Infiltrative cardiomyopathy. Yes, so both are correct. You can write here. Infiltrative cardiomyopathy can be due to amyloidosis. Amyloidosis can be due to sarcoidosis. Can be due to hemochromatosis. Due to hemochromatosis, it can cause. It can also be due to lymphoproliferative stage. Lymphoproliferative disease can cause this problem. 5% is post-radiation. Post-radiotherapy for cancers, post-radiation can also cause restrictive cardiomyopathy. It can cause restrictive cardiomyopathy can occur. So the clinical feature in early stages of restrictive cardiomyopathy. Please try to recall. This is like a restrictive cardiomyopathy is very similar to constrictive pericarditis, because being a chronic disease, the volume ventricular filling is slightly impaired. So the stroke volume will become less. To compensate for reduction in stroke volume, there is compensatory increase in the heart rate. That is why in early stages they present with palpitation with increased risk of tachyarrhythmia. With increased risk of tachyarrhythmia, the most common being PSVT. Most common being PSVT. Paroxysmal supraventricular tachycardia. So it is right. Untreated PSVT can lead to dilated cardiomyopathy. But infiltrative disease are associated with risk of developing PSVT. Risk of developing PSVT. It is only in the late stages where they develop hypotension and heart failure. Late stages they develop hypotension and heart failure is a late complication of the disease. Late complication of the disease. The third column we have got hypertrophic cardiomyopathy. The causes, remember, 10% can have familial or genetic risk factor. 10% can have genetic defect. Familial means genetic defect can be present. The most common genetic defect is the beta myosin heavy chain defect. Beta myosin heavy chain defect is the most common genetic defect associated with hypertrophic cardiomyopathy. It is the most common genetic defect associated with the hypertrophic cardiomyopathy. Since the ejection fraction is preserved, most common presentation is asymptomatic. Most common presentation is asymptomatic. Most common presentation is asymptomatic. Nothing has to be done. Most common presentation is asymptomatic. Nothing has to be done. The gold standard of treatment diagnosis we have written echocardiography. So come to the treatment and prognosis. Come to the treatment and prognosis of the disease. In dilated cardiomyopathy, you want to start the patient on anti-heart failure measures. That is the last topic. Management of heart failure measures. We will read. We have to first treat anti-heart failure measures. But remember, anti-heart failures are only palliative. Only palliative. The only potential cure is the cardiac transplant. Cardiac transplant is the only potential cure. It is the only potential cure, but it is not easily available. It is not easily available. So the prognosis of the dilated cardiomyopathy is poor due to high acute mortality. Due to the high acute mortality and the poor availability of a heart transplant. Poor availability of a heart transplant. याद रखिए, अभी भी heart donor is not available on Amazon Prime, है ना? It is not that कल मंगा लो 72 hours में आ जाएगा, 24 hours में आ जाएगा. So it takes time and the patient does not have time. The systolic function is so severely affected that the patient ends up requiring only heart transplant. Requires only heart transplant here. The treatment of the restrictive cardiomyopathy, you can give trial of steroids. You can give trial of steroids. Steroids also slow the progression. They slow the progression. That means they can be palliative in infiltrative disorders. They can be palliative for infiltrative disorder. But here also only cure is the cardiac transplant. Cardiac transplant is the only potential cure. Others are only palliative. So that prognosis is unfavorable, not poor, because relatively it has lower mortality. It has lower acute mortality. So thoda poor से better is unfavorable. Poor से better is the unfavorable. So we can say that. है ना, HOCM अभी आया नहीं है, है ना, we are only at HCM only. HCM में सिम्टम ही नहीं था, HCM में सिम्टम ही नहीं था, so the treatment भी नहीं है, reassurance only. Reassurance only. So prognosis is best. So prognosis is best. Okay. So prognosis of HCM is the best. Prognosis of HCM is the best. Ana heart failure में, Ana you will understand what is the role of ACE inhibitor. वो heart failure में पढ़ेंगे. Ana so we have written as a total group anti heart failure measure. ऐसे लिख के छोड़ दिया. So this is our answer here. Very simple topic here. That is our dilated restrictive hypertrophic cardiomyopathy. Very clear in front of you. Okay. So we have got here dilated cardiomyopathy, restrictive cardiomyopathy and the hypertrophic cardiomyopathy. And the hypertrophic cardiomyopathy, I have put it in front of you. But please remember, asymptomatic है in 90%, but 10% can have HOCM. 10% of the cases can be HOCM. Okay, so 10% can be HOCM. 10% can be HOCM. HOCM, 10% HOCM is associated with risk of sudden cardiac death. It is associated with the risk of sudden cardiac death. Okay, so 10% have risk of sudden cardiac death. Sudden cardiac death. So if it is HOCM, you will have to consider amiodarone to reduce the risk of sudden cardiac death. Reduce the risk of sudden cardiac death. And transplant is the only cure. And transplant will be the only cure. Transplant will be the only cure. And prognosis is poor. And the prognosis is poor. Okay. So very, very important points. So cardiomyopathy is a very simple topic. Cardiomyopathy is a very simple topic. Based on the echocardiography, we have to first classify them into the three types. है ना, थोड़ा सा बड़ा करते हैं. We have to classify them into the three types, and accordingly we have to write the clinical features, the prognosis, the treatment of the disease. So what we are noticing, HCM is best prognosis, HOCM is poor prognosis. So ये O क्या बदल जाता है? What is the big difference between HCM and the HOCM? चलो लिखते हैं. Difference between HCM and the HOCM. Very important point. The difference between HCM. What is the difference between HCM and the HOCM? What is the difference between HCM and the HOCM? I want you to remember. Okay. So HCM आप कहते हो good prognosis है, and HOCM में poor prognosis है. HOCM में poor prognosis है. Listen carefully. This is a very important point where cardiologist, where the cardiology is giving you message of the heart, to all the young couples out there, जो भी boyfriend girlfriend लेके घूम रहे हैं, उनके लिए message from cardiology. The message of cardiology comes from the topic of HCM and the HOCM. Let's draw it with me, right? Sudden cardiac death. SCD means sudden cardiac death. We have used it 4 times. Sudden cardiac death. HCM, sudden cardiac death. है ना? Come on. So HCM और इसमें क्या फर्क होता है? Draw it with me. Everybody ready? Draw it with me. Okay? Draw it with me. Otherwise you may miss this. So we will draw first the right atrium. We will draw the right ventricle. There is the right atrium and we have got the right ventricle. We have got here the aorta, arch of aorta. We have got the arch of aorta. We have got the arch of aorta. Yes. Behind the arch of aorta is the mitral valve. Behind the arch of aorta is the mitral valve. There is the left atrium and there is the left ventricle. Remember this, left ventricle. Right. So what is the message of cardiology? Okay, so let us write this. This is the mitral valve leaflet. So in a 3-dimensional picture, mitral valve is posterior to the aortic root. Mitral valve is behind the aortic root. behind the aortic root. Okay, so what we have got here, HCM versus HOCM, HCM versus HOCM, ये हमको पढ़ना। तो फर्स्ट ड्रॉ करते हैं। HCM में क्या लिखा हमने, asymmetrical septal hypertrophy. HCM has got asymmetrical septal hypertrophy. Okay, so HCM is characterized by asymmetrical septal hypertrophy. Characterized by asymmetrical septal hypertrophy. Asymmetrical septal hypertrophy. But as you can see, the hypertrophied septum does not cause, there is no significant LVOT obstruction. There is no significant LVOT obstruction. No significant LVOT obstruction. And that is why the prognosis is good. That is why there are no symptoms. That is why no treatment is needed, and the prognosis is best prognosis. The prognosis is best prognosis, right? So coming to the message of the heart, what is the message of the heart? So over years I realized the message is different for the girls, different for the boys. ध्यान से सुनना. The message to the boys first. हम स्टार्ट करते हैं. HCM क्या कहता है? जब तक आपके लाइफ में only one heroine is there, Ash, है ना? So message to the boys, HCM says that as long as you have only one girlfriend in your life, your prognosis is excellent. As long as you have got only one girlfriend, Ash, in your life, you have got best prognosis. There is no obstruction. But the moment you bring the Sam also home, along with Ash, you bring Sam also home, what are you going to do? Sudden cardiac death. A sudden cardiac death is going to happen. So Ash plus the presence of Sam. The moment you do double dating, Ash का मतलब पिछले पेज में लिखा ना आसिफ, asymmetrical septal hypertrophy, asymmetrical septal hypertrophy, उसके साथ Sam जोड़ दो तो पक्का मरोगे. तो what is this Sam? Sam is the systolic, it is the systolic anterior movement of the mitral valve. It is the systolic anterior movement of the mitral valve. Anterior movement of the mitral valve, right? So what will happen? This anterior movement will cause obstruction. So this systolic anterior movement can lead to significant. Where is the aortic valve? Here. This is aortic valve. The site of obstruction, subvalvular LVOT obstruction. Subvalvular LVOT obstruction associated with risk of sudden cardiac death, poor prognosis. Sudden cardiac death, poor prognosis can occur. So simple way to remember, Jana? So for the boys out there, the moment you have more than one, you are going to die. But yaad rakhna, there is also message to the girls also. What is message to the girls? That सारे लड़के कमीने नहीं होते. Message to the girls is all the boys are not bad, because majority of them are dating only one. Majority of them is dating only one. ओनली 10% चीट ऑन यू, उनको मारो, वो 10% के लिए सब लड़कों को मत गाली दो. सो डोंट किल all the boys just because 10% will cheat on you. Otherwise all of them are going to be nice only. Okay, so be nice to all the boys, all the girls out there, है ना. Be nice to the boys, don't worry, आपके सपोर्ट में ही बात कर रहा हूँ, है ना. So don't worry, it's all good. So this is the difference between HCM and HOCM. This is the difference between HCM and HOCM. Okay, HCM versus HOCM, right? Understood here? Very simple points. So what we have got here, we have understood now the three basic types of cardiomyopathy. We have understood the three basic types of cardiomyopathy. There is the dilated, restrictive, hypertrophic cardiomyopathy. So cardiomyopathy का टॉपिक खत्म हो जाता, but now we have to introduce the special variants. Which are the special variants of cardiomyopathy we want to discuss? There are few special variants of cardiomyopathy which we want to discuss here. Okay, the special variants of cardiomyopathy we want to discuss here. चलिए, so what are the one by one we will solve them out. What are the special variants? Quickly let us write them. Let us start with arrhythmogenic. Let us start with the arrhythmogenic right ventricular dysplasia. Let us start with the arrhythmogenic right ventricular dysplasia, ARVD. Let us start with the ARVD, arrhythmogenic right ventricular dysplasia से शुरू कर दें. So special variant, the special variant. Okay, so special variant, what we have? Arrhythmogenic right ventricular dysplasia. Right ventricular dysplasia. So write down. What is it? This is a inherited defect. It is a inherited defect in the desmosomal protein. In the desmosomal protein. It is a inherited defect. It is a inherited defect in the desmosomal protein. Desmosomal protein present in the intercalated disc. Present in the intercalated disc of the myocardium. Intercalated disc of the myocardium. Myocardium leading to its replacement. किसका replacement? Myocardium का replacement. Myocardium is replaced by fatty and fibrous tissue. It is replaced by fatty and fibrous tissue. Okay, so what is the point here? It is a inherited defect in desmosomal protein present in the intercalated disc of the myocardium, leading to its replacement by fatty and fibrous tissue. Because of this replacement, it can cause arrhythmia. But the girl, mainly the syndrome here, it predominantly affects right ventricle alone. But 10% can have LV involvement also. 10% can have LV involvement also. can have LV involvement also. Okay, this is going to be there. So epidemiology, this is inherited disease. So inherited disease typically presents in 10 to 20 years, male dominant disease. 10 to 20 years, male dominant disease. Male dominant disease. 10 to 20 years, male dominant disease. Okay, most common genetic defect. Most common genetic defect is the PKP2 gene defect. Most common genetic defect is in the PKP2 gene. PKP2 gene is the problem. Clinical feature, they present with cardiac arrhythmias. They present with cardiac arrhythmias. That is why the name arrhythmogenic right ventricular dysplasia. That is why the name right ventricular arrhythmogenic dysplasia. That is what we want to know. Present with arrhythmia. So MCQ आ गया. MCQ क्या पूछता है? What is the most common arrhythmia? Is PSVT. Most dreaded arrhythmia is the ventricular tachycardia. Most dreaded is the ventricular tachycardia, and that is why they present with episodic palpitation, but always have got a risk of sudden cardiac death. They present with episodic palpitation with increased risk of sudden cardiac death. This is the clinical presentation of arrhythmogenic right ventricular dysplasia. Arrhythmogenic right ventricular dysplasia. So please remember, क्या हो रहा है यहाँ पर? Inherited defect, where the muscle is replaced by, मतलब infiltrated by fatty and fibrous tissue. Muscle is replaced by fatty and fibrous tissue, presenting as arrhythmia. That is why it is a variant of RCMP. It is a variant of RCMP. It is considered a restrictive cardiomyopathy. Restrictive cardiomyopathy. Restrictive cardiomyopathy में भी there is a infiltration. यहाँ पर भी infiltration of muscle by fat and fibrous tissue, and presentation is arrhythmia, considered a variant of ARRCMP. For the diagnosis, on the ECG you can see epsilon wave. On the ECG you can see epsilon wave due to delayed RV contraction. Due to delayed RV contraction. Due to delayed RV contraction. Epsilon wave can be seen on the ECG, but gold standard remains echocardiography. The treatment, you want to start amiodarone, palliative, to reduce the risk of sudden cardiac death. Palliative, to reduce the risk of sudden cardiac death. But only potential cure is to go for transplant. Only potential cure is to go for transplant, making the prognosis poor. Hence it is still associated with a poor prognosis. Associated with a poor prognosis. Okay? Associated with a poor prognosis. Arrhythmogenic right ventricular dysplasia. So this is what we are going to do here. So this is our first variant. ARVD is the first variant. है ना, that is the first variant of cardiomyopathy. अब एक टाइप को वेरिएंट दिया तो बाकी दोनों ने क्या किया? सो वी नीड टू नो टू मोर वेरिएंट्स, स्पेशल वेरिएंट्स ऑफ कार्डियोमायोपैथी. वी वांट टू लर्न टू मोर स्पेशल वेरिएंट्स ऑफ कार्डियोमायोपैथी. वी आर गोइंग टू लर्न Yamaguchi's syndrome. We are going to learn Yamaguchi's syndrome and compare it with the Takotsubo cardiomyopathy, and we are going to compare it with the Takotsubo cardiomyopathy. Compare it with the Takotsubo cardiomyopathy. We are going to compare the two different special variants of cardiomyopathy to complete this topic. Okay, so to complete the topic of cardiomyopathy, we want to learn these two variants, है ना. How it is a variant? साहिल कुमार, है ना, आप सुन रहे हैं क्लास को? What I am telling, क्या होता है रेस्ट्रिक्टिव कार्डियोमायोपैथी में? इन रेस्ट्रिक्टिव कार्डियोमायोपैथी एक बार फिर से देखिए, है ना. इन रेस्ट्रिक्टिव कार्डियोमायोपैथी क्या हो जाता है? देयर इज लॉट ऑफ इनफिल्ट्रेशन. Infiltration means what? There is replacement of the muscle, and the presentation is PSVT, tachyarrhythmia. So the disease looks like that. The disease looks like that, and that is why you are going to call this as a variant of the restrictive cardiomyopathy. We are going to remember like that. Okay. So last point. Yamaguchi's versus Takotsubo cardiomyopathy. Okay, Yamaguchi's versus Takotsubo cardiomyopathy. We want to right? चलो एक एक करके करते. What is Takotsubo? It is a apical only variant of HCM. It is a apical only variant of HCM. Apical only variant of HCM. So what happens here? Only the apical part of the septum. Only apical part of the septum is hypertrophied. Apical part of the septum is hypertrophied, and there is no LVOT obstruction. Okay, apical only variant of HCM, hypertrophic cardiomyopathy, where only apical part of the septum is hypertrophied with no LVOT obstruction. The Yamaguchi's is a good boy. Affects the same age group, 20 to 40 years, male dominant disease. So Yamaguchi, like all other cardiomyopathies, affects relatively young boys. Young males are affected. What is the clinical feature? Please remember, HCM, what does it cause? Asymptomatic, most common. Asymptomatic, most common. But rarely it can present with angina due to increased demand of the hypertrophied myocardium. Increased demand of the hypertrophied myocardium. Okay, so we have got here the hypertrophied myocardium. Rare, it can cause angina, and that is why what can Yamaguchi's do? It can mimic acute coronary syndrome. It mimics acute coronary syndrome. So it can look as if the person has developed a myocardial infarction. Looks as if the person has developed a myocardial infarction is present. It is present. But at the other side, Takotsubo cardiomyopathy. We must know ना कि compare क्यों कर रहे. Takotsubo is your Valentine's Day special, है ना? Broken heart syndrome, Valentine's Day special, broken heart syndrome, stress induced myocardium, है ना? So what we have, Takotsubo cardiomyopathy is what is happening. There is going to be a stunned myocardium. There is a stunned myocardium secondary to intense stress or emotion. Intense stress or emotion leading to apical akinesia. Leading to apical akinesia. Apex does not contract. There is the stunned myocardium and the apex does not contract. So you can look from the color coding. Takotsubo is a variant of dilated cardiomyopathy. It is a variant of dilated cardiomyopathy. It is the only cardiomyopathy which affects elderly female, postmenopausal female. Postmenopausal females are affected by Takotsubo cardiomyopathy. Clinical feature. Most commonly, they present with shock, hypotension, like dilated cardiomyopathy. But they can also present with angina due to decreased supply to the coronary. Because of the shock, the coronary supply also becomes reduced. And that is why we call it as, again, it can mimic acute coronary syndrome. So what they show in our movies, no, कि एकदम सदमा पहुंचा, हाथ पे आ करके मर गया, है ना? तो सदमा, इमोशनल स्ट्रेस एंड द पर्सन डाइज. That is not MI, that is Takotsubo cardiomyopathy. So please remember, Takotsubo looks like MI. Takotsubo looks like MI, but it is not. These are all cardiomyopathy, means disease of myocardium, not vascular disease. Disease of myocardium. That is what we want to know. So we are studying the two variants together because both of them can mimic acute coronary syndrome. Otherwise तो दोनों अलग अलग है. One is variant of HCM, other is variant of dilated. But we are studying them together because they both of them mimic acute coronary syndrome. आगे बढ़ते हैं. If you mimic acute coronary syndrome, what test are you going to ask? You are going to ask for ECG. What does the ECG show? In Yamaguchi, it will show ST depression. Where? In the apical and lateral leads. In the apical and lateral leads only, it will show ST depression. It will show ST depression. हाँ बोलिए सर. अभी भी गया क्या? देखो वापस. बीच बीच में आ रहा है. ओके. Yeah. So ST depression because of increased demand, no? All of us know ST depression is a sign of ischemia. ST depression is a sign of ischemia. Okay, increased demand. That's why where the hypertrophy is, you will get ST depression. Takatsubo, on the other hand, 30% can have ST elevation also. Others will show generalized ST depression. Others will show generalized ST depression. Can be seen on the ECG. So that is why Takatsubo can very much look like a myocardial infarct only. Very much look like the myocardial infarct only. Okay, so what we have got here, that here we have got the echocardiography. After ECG we can go for cardiac biomarker troponin. We can go for cardiac biomarkers, that is troponin. Okay, so there is a troponins. When you check the troponin in Yamaguchi, it is always negative because there is no infarction. But in the Takatsubo, 30% may be false positive. 30% may be false positive. That is why it mimics myocardial infarction. It can mimic myocardial infarction. It can look like, right? But the diagnostic test, gold standard is to go for, we want to go a ventriculography. Sorry, before that, when you do, how do you know that it is not the coronary? Because in both of them, the coronary angiography reveals normal coronaries. Coronary angiography reveals normal coronaries. That is how we know that it is not myocardial infarction. It is not myocardial infarction. It is not myocardial infarction. So both of them look like acute coronary syndrome. Yamaguchi can look like non-specific ST changes, negative troponin, normal coronary. While Takatsubo can look exactly like a ST elevation MI. It can even have the false positive troponin. It can even have false positive troponin. But the coronary angiography reveals normal coronary. And the gold standard is the ventriculography. The gold standard is to go for a ventriculography. We want to check. Ventriculography we want to check. Ventriculography we want to check. In the ventriculography, Yamaguchi's shows spade-like appearance. Spade-like appearance of the LV. Spade-like appearance of the left ventricle is seen. Spade-like appearance of the left ventricle is seen. Okay, so what we do? We do a ventriculography. Ventriculography shows a spade-like appearance. So when you inject dye into the LV, it appears like this. Spade-like appearance of the LV is there. Spade-like appearance of the left ventricle. That is the diagnostic of Yamaguchi's cardiomyopathy. Yamaguchi's cardiomyopathy. Yamaguchi's cardiomyopathy. Spade मतलब पत्ते का स्पेड. You have played cards, no? पत्ते का स्पेड. थोड़ा सा ओरिएंटेशन घुमा दो. पत्ते का स्पेड है ना, कार्ड्स, प्लेइंग कार्ड्स, द स्पेड लाइक अपीयरेंस. एंड वेंट्रिकुलोग्राफी, you get the Takatsubo appearance. the Takatsubo or the octopus spot appearance. The octopus spot appearance. That is why the name. What is this octopus spot appearance? So when you do the ventriculography during the diastole, you will see that the ventricle appears normal. It receives the blood. Ventricle appears normal, receives the blood. So when you check the ventriculography का मतलब है inject dye into the ventricle, inject dye into the ventricle. But during the systole, when you see what happens, the apex area, ये जो है ना apical area, this apical area को क्या हो गया, akinesia हो गया, does not contract. In the Takatsubo, apical area does not contract, and that is why you will have only lateral wall contraction. You will have only lateral wall contraction. Only the lateral wall contracts due to apical akinesia. This is called as apical ballooning. You will see apical ballooning during cardiac systole. Apical ballooning during cardiac systole can be seen. That is why it is called as octopus trapping pot. So you keep that pot open for the octopus to enter, and then you will pull the string so that you can choke the neck. So inside the octopus will be trapped. In the heart, the reference of octopus is to the blood. The blood can enter and the blood remains in the ventricle. The blood remains in the ventricle. Remains in the ventricle. This is called as Takatsubo appearance. Takatsubo appearance. Ventricle appearance is normal. The function is affected, no? Echocardiography cannot be giving you this point. Okay, so this is our ventriculography. So come to the treatment. What treatment you want to do? In Yamaguchi's, you want to give plenty of reassurance. It is a benign condition, and you want to give beta blocker to reduce the recurrence of angina. To reduce the recurrence of angina. It is very, very good prognosis. Very, very good prognosis. Like HCM. Like HCM. It is good prognosis. Like HCM is a good prognosis. But Takatsubo, you want to start the patient on anti-heart failure measures. Want to start on anti-heart failure measures, but this is only palliative, temporary. But the good news, it is a reversible cardiomyopathy. Takatsubo is a reversible cardiomyopathy. That means the survivors regain complete ejection fraction. They regain complete systolic function within 6 months. They regain complete ejection fraction within the 6 months of recovery. So हमको क्या करना है? We only want to save the patient temporarily from the effect of heart failure. From the effect of heart failure. So once you can do that, what is there? You just have to wait for the reversal. And if you can tide over a few months, the patient will learn complete regain of the systolic function. They will completely learn the systolic function within the 6 months. Within the 6 months. And that's why important note is, it is an example of reversible cardiomyopathy. Reversible cardiomyopathy, right? So this is what we have here, the topic of cardiomyopathies we have completed. We have completed the topic of cardiomyopathies. Have a look here. So we studied these two special variants together. Special variants together because they can mimic acute coronary syndrome. We studied them together because they mimic acute coronary syndrome. Okay, and that is why we have got here the two variants of the cardiomyopathy. Right, so हमने complete किया है यहाँ पर. We completed the entire topic of cardiomyopathy. Cardiomyopathy, right? So the last topic is left, that is the topic of heart failure. The last topic is left, that is the topic of heart failure. Okay, which we will now change after the break. Okay, so we'll take a small break of 15 minutes. We'll take a 15-minute break. Okay, we will start at 6:20 and we will finish at 8 p.m. Okay, we will finish at 8 p.m. The last topic is left, that is heart failure, and we will finish at the 8 p.m. Ventriculography means it is just injecting dye into the ventricle. And a ventriculography means injecting dye into the ventricle. So during the diastole, the dye can enter the ventricle. But when during the systole, apical area does not contract, akinesia, due to stunned myocardium. And that is why only lateral wall will contract, leading to apical ballooning, leading to the problem. Typical sign, Takotsubo appearance. ठीक है, चलो. We'll take a quick break here and we will come back at 6:20, finish at 8 p.m. We will finish with the topic heart failure and I will review with the ECGs. Chalo. Okay. So let us start with our last topic. So let me show you the classification table. So in the classification of CVS disorders, okay, we one by one we have taken care of each individual disease. We studied the topic cardiomyopathies, we studied pericardial disease, and along with your knowledge of your hypertension coronary, we reached the last topic, that is end point, heart failure. We reached the end point, that is the topic of heart failure. We will continue, right? So our journey today, DM cardiology, right? So DM cardiology, क्या तुम MD की बात कर रहे हो, है ना? So we are already ahead. So just keep it going, okay? Keep simple. Let's do that. So we will go here to the heart failure. है ना? Octopus spot, Vivek Kumar. Just think it is like a noose appearance. Though you keep the bag open, है ना? You keep the pot open. Once the octopus goes inside, you choke the noose. तो नूस ऐसे कर दिया पर स्ट्रिंग जैसा, तो अंदर वो ऑक्टोपस चला जाता है एंड दैट क्रिएट्स अ अपाइकल बलूनिंग, बिकॉज ऑक्टोपस अंदर चला गया ना, तो यहाँ पर ब्लड अंदर जाता है. अपेक्स डज नॉट कॉन्ट्रैक्ट, ओनली लैटरल वॉल कॉन्ट्रैक्ट्स, लीडिंग टू दिस अपीयरेंस ऑफ Takotsubo और ऑक्टोपस स्पॉट अपीयरेंस. राइट, सो लेट अस कम टू द टॉपिक ऑफ हार्ट फेलियर. Let us come to the topic of heart failure. Let us see. Right, so heart failure has undergone lot of changes and we want to understand those basic updates here. Right, so we want to know how to go for heart failure. Right, so what is this heart failure? Heart failure is defined as a complex clinical syndrome. It is defined as a complex clinical syndrome. Complex clinical syndrome due to, it is defined as a complex clinical syndrome due to functional or structural or vascular heart disease, or vascular heart disease, that we have always written like that. We have classified like that only. It is a complex clinical syndrome due to functional, structural, vascular heart disease leading to the characteristic symptoms and signs of heart failure. Leading to the characteristic symptoms and the characteristic signs of heart failure. Characteristic signs of heart failure. This is the complete definition. Okay, so what we must know, that heart failure was previously called as a neuroendocrine syndrome. Now heart failure is studied as a complex clinical syndrome. The reason we will understand today. It is a complex clinical syndrome which occurs due to any heart disease. It can be functional, structural or vascular heart disease presenting with the characteristic symptoms and the characteristic signs. Characteristic symptom and the characteristic signs. That is the definition we have. So characteristic symptoms of heart failure. What are the symptoms of heart failure? The symptoms of heart failure include, what is the most common symptom? Most common symptom is fatigue. We will go MCQ with. Most common symptom of heart failure is fatigue. Most common symptom of heart failure is fatigue. The most specific is dyspnea on exertion. The most specific is the breathlessness, dyspnea or exertion. Dyspnea on exertion. Dyspnea on exertion is the most specific feature of the heart failure. Earliest is the PND, paroxysmal nocturnal dyspnea, is the earliest feature. Paroxysmal nocturnal dyspnea. Paroxysmal nocturnal dyspnea is the earliest feature. They can present with edema. Please remember, edema is both symptom and a sign. It can be seen by the patient also and can be examined by the doctor also. So fatigue, dyspnea on exertion, paroxysmal nocturnal dyspnea, there is edema, there can be palpitation, there can be palpitations. Characteristic symptoms: dyspnea on exertion, DOE, dyspnea on exertion, that is breathlessness on exertion, breathlessness on exertion. Characteristic signs क्या हो सकते हैं? Elevated JVP, there can be elevated JVP, there can be congestive hepatomegaly, there can be congestive hepatomegaly, ascites, there can be pedal edema, there can be pedal edema, there can be hypotension, and there can be bilateral inspiratory crepitations. There can be bilateral inspiratory crepitations. So keep it very simple. Five symptoms, five signs, characteristic symptoms and signs of heart failure. I want you to remember. So heart failure is now defined as a complex clinical syndrome due to any of the heart disease which has either become severe or has remained untreated, which leading to the characteristic signs and symptom. Correct. Number 6 also, thank you very much. We have got S3 S4 gallop rhythm. S3 S4 gallop rhythm. Pulses alternance is not a characteristic feature. So S3 S4 correct gallop rhythm is a characteristic sign. PND is paroxysmal nocturnal dyspnea. Okay, great. So how do you make the diagnosis of heart failure? Diagnosis of heart failure, Anna, in Harrison you will study the Framingham criteria. ये फ्रेमिंगहैम क्राइटेरिया अगर आपने पढ़ा होगा, है ना, आई एम श्योर यू हैव नो द नेम, बट अगर आपने पढ़ा होगा, आई अश्योर यू पढ़ते पढ़ते हार्ट फेलियर आपको हो जाएगा, है ना. इट इज अ कॉम्प्लेक्स क्राइटेरिया. इमरजेंसी में पेशेंट हार्ट फेलियर में आया है, वो हम लोग फ्रेमिंगहैम क्राइटेरिया से डायग्नोस करते करते हम खुद को हार्ट फेलियर हो जाएगा. वी वांट समथिंग सिंपल. Framingham is a complex criteria, but thankfully now we have got a European Society of Cardiology guidelines. Now we have got a European Society of Cardiology guidelines. European Society of Cardiology guidelines has become available to us. That is student friendly also, doctor friendly also, MCQ friendly also. So unlike the dangerous Framingham criteria, this is a much more student friendly criteria. It is a student friendly criteria. So what does it tell you? It says for the diagnosis you require 2 or more characteristic symptoms. 2 or more characteristic symptoms plus 2 or more characteristic signs. 2 or more characteristic signs along with the positive biomarker. Along with the positive biomarker. That's all. So to diagnose the disease, all you have to know is to diagnose heart failure, you need more than 2 characteristic symptoms. You plus 2 or more characteristic sign with a positive biomarker. Which are the approved markers? Pro-BNP. Yesterday we wrote in the first session. Approved biomarkers for heart failure. Approved biomarkers for heart failure. We have studied in the first session yesterday when we discussed the symptom of breathlessness, which we studied the symptom of breathlessness. So pro-BNP, soluble ST2 and galectin 3. है ना. गैलप रिदम का मतलब है sounds like a gallop of the horse. That's all. Sounds like gallop of the horse. ऐसा कुछ नहीं रे. Gallop is to describe the sound. It is not anything more. It sounds like gallop of a horse. That's all. You don't have to have any more understanding. So this can help to confirm diagnosis of the disease. So once we diagnose, we must know what is the role of echocardiography in heart failure. What is the role of echocardiography in heart failure? So it is wrong to believe that echo can confirm heart failure. No, echo cannot confirm heart failure. Echo can only tell you the types of heart failure. The types of heart failure based on the left ventricular ejection fraction. So echocardiography with color Doppler can only tell you the types of heart failure based on left ventricular ejection fraction. Left ventricular ejection fraction. Right? So what are the things? Based on that, you divide the heart failure into two types. Divide the heart failure into two types. The two types are: one, heart failure with reduced ejection fraction. Heart failure with reduced ejection fraction, that is less than 40%. And the other category is there is heart failure with preserved ejection fraction. Heart failure with preserved ejection fraction. Heart failure with preserved ejection fraction. So we are going to dividing the patient. After confirming diagnosis, you will take the help of echocardiography to understand the type of the heart failure, and that type of heart failure helps understand the probable cause. What it does? It helps identify the probable cause. Identify the probable cause. That's all. It gives you a differential diagnosis. It helps identify the probable cause. It helps identify the probable cause. Heart failure with reduced ejection fraction, R for reduced ejection fraction, and heart failure with preserved ejection fraction. Heart failure with preserved ejection fraction. We want to know. Heart failure with reduced ejection fraction. Most common is ischemic heart disease. Most common is the ischemic heart disease. It can also be due to dilated cardiomyopathy. Dilated cardiomyopathy due to valvular heart disease. So when you have a patient with heart failure who has an ejection fraction of 30%, most likely it will be ischemic cardiomyopathy. If it is not ischemic, then it can be dilated cardiomyopathy, or you must search for valvular heart disease. If it is preserved ejection fraction, it is hypertensive heart disease. It can be infiltrative cardiomyopathy. It can be infiltrative cardiomyopathy, or due to arrhythmias. So we have studied these topics. The topics that we have studied, we are writing it down here, that which are the types of heart failure that they can cause. So please remember, old time the words were used, that forward failure, backward failure, systolic failure, diastolic failure, acute failure, chronic failure. All these terms are no longer preferred. All these words are no longer preferred. Now we are going to focus on the heart failure with reduced and preserved ejection fraction. है ना? Infiltrative arrhythmia के साथ correct है. You want to look for also degenerative heart disease. The degenerative heart disease. Very good. So in elderly patients, sometime we can get the normal fraction ejection, but patient may have features of the heart failure. So this is what we want to know. So helps identify the probable cause. Okay, it helps identify the probable cause. Right? So once the diagnosis is made, you want to learn the management of heart failure. So first we will start with management of acute heart failure. Let us start with the management of acute, also called as overt heart failure. Management of acute, ऑल्सो कॉल्ड ओवर्ट। ओवर्ट का मतलब सिम्टोमैटिक हार्ट फेलियर, इसका मतलब सिम्टोमैटिक हार्ट फेलियर। ऐसा नहीं और का नहीं, वो भी कॉज है ना, जगह नहीं था करके लिख दिया मैंने। degenerative also is there. Okay, so management of acute or overt or symptomatic heart failure के बारे में पढ़ते हैं, symptomatic heart failure मैनेजमेंट को पढ़ते हैं। so MCQ के लिए MCQ here, okay, MCQ, diabetes does not directly cause heart failure. Diabetes causes ischemic heart disease, okay, not direct here. Heart failure confirmed by ESC guidelines, लिखा नाम ने, confirmed by guideline, presence of symptom, presence of sign and positive biomarker can confirm heart failure. That's all is required. But if the patient is severely symptomatic, acute, you want to start the treatment. The first line treatment is based on the systolic blood pressure. Remember the dictum, based on the systolic blood pressure. For MCQ, it is based on the systolic blood pressure. Okay, it is based on the systolic blood pressure you want to know. So if the systolic blood pressure of a patient with acute heart failure is more than 100 millimeter of mercury, more than 100 millimeter of mercury, or if it is less than equal to 100 millimeter of mercury, read in the MCQ what is asked. If the patient has got heart failure with a blood pressure of systolic blood pressure more than 100 millimeter of mercury, the first line of choice, the first treatment is IV loop diuretics, is to give IV loop diuretics. Along with that, IV nitroglycerin can have synergistic action. Nitroglycerin can be having synergistic action. So if the patient has got preserved blood pressure, systolic blood pressure is more than 100, systolic blood pressure is more than 100, then you can start with IV diuretics. Along with diuretic, you can also give IV nitroglycerin. It has got a synergistic action. Remember, both these agents can cause hypotension. That is why you will give them only when the systolic blood pressure is more than 100 millimeter per minute. When it is less than 100 millimeter, first you have to go for inotrope support. First you have to go for inotrope support. Along with inotrope support, after the blood pressure improves, you can go on to giving loop diuretic and nitroglycerin. But here, first we will start with the inotrope support. है ना, degenerative आपको बहुत तंग कर रहा है, चलो है ना, बहुत ही I understand, है ना, वो आप लोग या सो यहां पर से निकाल देता हूं इसको, ठीक है, ये निकाल दिया, ओके, यहां पर लिख देता हूं, नंबर 4 लिख देते हैं, डीजेनरेटिव हार्ट डिजीज, ओके, डीजेनरेटिव हार्ट डिजीज, ओके एवरीबॉडी, है ना, तो ये प्रॉब्लम को सॉल्व कर देते हैं. सो दैट सेम वन स्मॉल थॉर्न इज स्टक इन एवरीबॉडीज माइंड, उसको हटा देते हैं, है ना. सो हार्ट फेलियर बेस्ड ऑन द इको, we are enumerating probable causes. So degenerative, one of the probable causes is degenerative heart disease, heart failure of preserved ejection fraction, है ना, heart failure of preserved ejection fraction. चलो आगे चलते हैं. So now we come to acute management of heart failure, which is based on the blood pressure. Based on the blood pressure. The choice of inotrope. To make the choice of inotrope. Again, we want to look at the systolic blood pressure. The choice of inotrope depends on the systolic blood pressure. Depends on the systolic blood pressure. Systolic blood pressure. If the systolic blood pressure is more than 85 or between 85 to 100 millimeter of mercury, or the systolic blood pressure is less than 85, less than equal to 85 millimeter of mercury, that you have to divide into 2. So which inotrope to choose? Which inotrope to choose also depends upon the systolic blood pressure. Also depends on the systolic blood pressure. It depends upon. If the systolic blood pressure is between 85 to 100, systolic blood pressure is between 85 to 100, the first choice will be to go for IV dovutamin. To go for IV dovutamin. Okay, there is one more. Their alternatives are IV milrinone. You can give IV milrinone, can be given. What is milrinone? It is a phosphodiesterase 4 inhibitor. Phosphodiesterase 4 inhibitor, which has additional leucotropic action. Which has additional leucotropic action is available. Leucotropic action is available. Okay. So here what we have, if you will start the patient on dovutamin, you will, if dovutamin is not in your options, you can also consider approved alternative is milrinone. Approved alternative is milrinone, which is a phosphodiesterase inhibitor. Phosphodiesterase 4 inhibitor with additional leucotropic action. Okay, वो 3 को हटा दो, है ना? 3 correct? Okay, yes. So what we have got? Very good. I am just hoping कि आप लोग ध्यान दे रहे हो. Phosphodiesterase 3 inhibitor. Correct? Very good. I am very very happy. चलो ध्यान देंगे हम लोग थोड़ा सा. Phosphodiesterase 3 inhibitor हमारे पास है. Leucotropic का मतलब होता है improves relaxation. Leucotropic means improves relaxation. Leucotropic means improves relaxation. The choice is also of IV levosimendan. Choice is levosimendan is also there. Levosimendan is a calcium sensitizer. It is a calcium sensitizer is available. Anna, calcium sensitizer is available. IV omecamtiv mecarbil. IV omecamtiv mecarbil is also approved. It is a direct myosin activator. It is a direct myosin activator. So all these agents are approved. All these agents are approved. Hana? So leucotropic means, Hana? So what we have got here, the improves the relaxation. Okay. If the blood pressure is less than 85, blood pressure is less than 85, then the choices are IV dopamine in cardiac dose. The choices are IV dopamine in cardiac dose. We can give IV norepinephrine. IV norepinephrine can be given. IV norepinephrine can be given. We also have IV vasopressin. IV vasopressin. But please remember, vasopressin is approved only as a add-on agent. Only as a add-on agent, not alone. So at least one of the above inotrope must be written. One of the above inotrope must be written. Vasopressin is approved, but approved as only as a add-on agent. Only approved as a add-on agent. Okay. So inotropes are never given long term. In the long term, they all can precipitate tachyarrhythmias and cause mortality. They increase the demand of the myocardium. So it is a temporary. It is a temporary mechanism. It is a temporary mechanism. So what you do when the patient comes with adverse acute heart failure, when the patient comes with acute heart failure, now you understand, when the patient comes with acute heart failure, in the MCQ, what you will check? Check the blood pressure. If the blood pressure is more than 100, directly go for loop diuretic and NTG infusion. But if the blood pressure is low, first stabilize the blood pressure by using inotrope support. After the blood pressure improves, you can start IV loop diuretic, IV NTG to resolve the symptoms, of heart failure. तो ये कैसा है ना, temporary, acute management, palliative management, है ना, acute management you want to start. This is the approach to management of acute heart failure. But after the acute symptoms are gone, we must learn how to prevent heart failure. And to learn how to prevent heart failure, we are coming to the last page of our class today. Last page of cardiology today, and that is the pathophysiology of heart failure. We are coming to the last page of today's class. It is the last page of today's class, pathophysiology of heart failure. So acute मतलब symptomatic है, but after the acute symptoms are over, after the acute symptoms are over, how to prevent the heart failure? How to prevent the heart failure is important. To learn how to prevent heart failure, we are first going to understand pathophysiology of heart failure. We are first going to understand the pathophysiology of heart failure. Okay? Pathophysiology of heart failure. Right? So tell me, first thing, how does the heart failure starts? It all begins with the index event, है ना? Index event का मतलब होता है onset of heart disease. Onset of heart disease. The most common index event is a acute coronary syndrome. So a very, very, very important chart I want you to make here. Very, very important chart. So pathophysiology of heart failure you want to understand so that you can understand the treatment options for prevention. So you can understand the treatment options for prevention of heart failure. For the prevention of heart failure. Acute failure होने के बाद you will do emergency management. But after the emergency is over, you want to prevent the recurrence. And how will you do that? You want to take the pathophysiology of heart failure. Okay, so this is a integrated approach I want you to understand. ACS is acute coronary syndrome. ACS is acute coronary syndrome. The most common heart disease leading to heart failure is acute coronary syndrome. Among all the diseases that we have learned, the most common is acute coronary syndrome. So now listen to this question carefully. After the patient has developed a heart disease, why does the patient not go immediately into heart failure? बीमारी तो आ गई. Why doesn't the patient immediately go into heart failure? Because there are multiple compensatory mechanisms. Because there are multiple compensatory mechanisms. Write them down. The compensatory mechanism. What is the neurocompensation? What is the neurocompensation? Let us write down. So once the heart disease starts, there is a compensatory mechanisms which will initiate in the body. The neurocompensation, there is going to be increased sympathetic activity. There is increased sympathetic activity which leads to increase in the heart rate. Remember yesterday's first session. What is cardiac output? Cardiac output is stroke volume into heart rate. So what happens the moment we have any heart disease which reduces the stroke volume? In order to preserve the cardiac output, the compensatory tachycardia occurs. This tachycardia is mediated by sympathetic activity, catecholamine release, which is called as neurocompensation. याद रखिए, compensation is good only in the acute time. याद रखिए, every time we are in a very difficult situation, how many times have we given away too much to get rid of the bad situation? है ना, कभी क्या होता है, हम कहीं पर फंस गए तो we are ready to pay anything to get out of the situation. After getting out of the situation, many times we repent, we regret कि इतना सब हमने क्यों दे दिया, है ना? Isn't it very common that many times we feel that after getting out of the situation, हम सोचते हैं इतना compromise मैंने क्यों कर दिया? Same way, compensatory mechanism initially तो अच्छे होते because बच जाते हो तुम, but long term में all compensatory mechanisms are not good. In the long term, all compensatory mechanisms are not good, and by stopping those not good mechanism, we can prevent heart failure. That's the point here. So neuro compensation होता है. आगे चलते हैं. Second one, what is happening? Endocrine compensation. That is why the heart failure was previously called neuroendocrine syndrome. इसको हम बोलते हैं. Heart failure was called neuroendocrine syndrome. They used to call. In the endocrine, there is increased nitric oxide release from the vascular endothelium. There is increased nitric oxide release from the vascular endothelium. There is increased nitric oxide release with the vascular endothelium. there is also increased BNP and ANP release. There is again increased BNP and ANP release. ANP release. We know that both of them cause natriuresis. This peptide BNP and ANP are metabolized in the body. They are metabolized in the body by the neprilysin enzyme. By the neprilysin enzyme. So BNP, ANP is released in response to heart disease. Okay, and it is metabolized in the body by the process of the neprilysin enzyme. We also have activation of renin angiotensin. In the body. Increased renin angiotensin increases aldosterone levels. Aldosterone causes increased sodium and water retention. Can occur because of aldosterone. Right, so we have got here. So ANP, these are all the endocrine mechanisms. These are all the endocrine compensatory response. न्यूरोएंडोक्राइन के साथ क्या होता है? जेनेटिक मॉड्यूलेशन. The third response is the genetic modulation. It is the genetic modulation causes increased rate of apoptosis. Why? In order to conserve the energy. We all know that, as I just told you, in emergency, what does the heart say? That जो रोज काम नहीं करते, which cardiomyocyte does not work regularly, we want to just let them die. Programmed cell death will begin to conserve energy. And there is also cytokine release. So cytokine release, pro-inflammatory cytokines are released. There is increased TNF alpha levels. There is increased interleukin 1 levels in a patient of heart disease. That's what we want to know. So compensatory mechanisms occur once the patient has developed heart disease. Compensatory mechanism occur once the patient has developed heart disease. So these compensatory response lead to ventricular remodeling. These compensatory responses leads to ventricular remodeling. So what is the prevention? We have written, no, ACE inhibitor prevents ventricular remodeling. So ventricular remodeling can tide over the acute crisis. but in the long term it is a maladaptation. In the long term it is like a maladaptation. It is a maladaptation which eventually lead to heart failure. It is a maladaptation which eventually leads to heart failure. That is the point here. Okay, so यहाँ पर समझते हैं. So what we have to know here, that once the heart disease begins, heart disease कोई भी होने दो, heart disease can be arrhythmia, valvular disease, congenital disease, cardiomyopathy, ischemic heart disease, hypertension. Any heart disease comes, that is called as index event. उसके बाद compensatory responses begin in the body. Compensatory responses begin in the body. Not all of them are good in the long term, and that is how it causes ventricular remodeling, which eventually leads to heart failure. So we have to assess each compensatory mechanism, see if it is good or bad. If it is good, you want to promote the mechanism. If it is bad, you want to inhibit the mechanism. Okay, you want to inhibit the mechanism, right? So take it forward, please. So what we have got here, let us start with the first mechanism. So first mechanism, neurocompensation. As I told you, neurocompensation is good only short term. Long term neurocompensation can cause increased risk of tachyarrhythmia, increased demand of the myocardium. So हमें क्या करना है, inhibit करना है. That is why we give beta blockers. That is why we give beta blockers to inhibit the response. To inhibit the response. Okay, but beta blockers we have discussed can associated with increased risk of hypotension. So has to be used with caution. Has to be used with caution. So understand now why we are giving beta blocker. Reduces risk of heart failure, because of which it offers survival benefit. हमने पढ़ा class 2 antiarrhythmic drug, survival benefit. Alternative to the beta blocker, we have got ivabradine. Alternative, we have got ivabradine, which is a direct SA node inhibitor. Which is a direct SA node inhibitor, which controls the heart rate without risk of hypotension. Which controls the heart rate without the risk of hypotension. Without the risk of hypotension. That is important to us. So after the heart disease, हम पढ़ते हैं ना, in myocardial infarction, in mitral regurgitation, you are prescribing beta blocker. Why are we prescribing beta blocker? To blunt the neurocompensation. We don't want it. Once the BP is normal, we don't want tachycardia. That is why we inhibit the neurocompensation. Other side, endocrine compensation. Nitric oxide release is good because reduces the afterload, preload, afterload. So to promote, we can give long-acting nitrates. I want you to look at your own family, any elderly person's prescription. Elderly person's prescription, you will see that they are on isotrate. They are getting monotrate. What is that? Long-acting nitrate. Prevents the heart failure, helps to prevent the heart failure. ANP BNP release is good. You want to promote ANP BNP because you want to induce natriuresis. But BNP half-life is very small. So we thought we can give recombinant BNP. So what we started? We gave nesiritide. So nesiritide was there. This is the IV recombinant BNP. This is the IV recombinant BNP we have got here. But इसका कलर चेंज कर दिया है ना. क्यों चेंज किया? बिकॉज ब्लू कलर. द ड्रग इज अप्रूव्ड बट क्लिनिकल ट्रायल डिड नॉट शो सक्सेस एंड हेंस नॉट यूज्ड इन क्लिनिकल प्रैक्टिस. फार्मेकोलॉजी ने अप्रूव कर दिया. फार्मेकोलॉजी ने अप्रूव कर दिया है ना. नेसिरिटाइड, सॉरी, I think I have messed it up. No, sorry. Anna, so correct hai na. So what I have done, we have got this. Sorry, I think I have, yeah. So not neprilysin. First we are always starting with nesiritide. Correct hai. We start with nesiritide. That is the recombinant BNP preparation. That is the recombinant BNP preparation. Yes, but not showing clinical trial. Not showing clinical trial. So हमने सोचा इसको जाने दो. We must try neprilysin inhibitor. है ना? Inhibit the neprilysin enzyme. So we have got omapatrilat. So we have got the omapatrilat. That is the IV neprilysin inhibitor. Neprilysin inhibitor, which prolongs the action of endogenous the BNP. Which there is going to be prolongation of endogenous BNP, but it did not show, but it did not show the clinical trial success. But what we have got now? Oral sacubitril. We have got oral sacubitril, which is the neprilysin inhibitor. Which is the neprilysin inhibitor, which is shown to prolong the action of endogenous BNP. Prolong the action of endogenous BNP. Endogenous BNP. Okay, to prolong the action of endogenous BNP. Okay, so neprilysin is going to metabolize the BNP. By inhibiting the neprilysin enzyme, I am going to prolong the action of endogenous BNP. That can be given for preventing heart failure. I can give ACE inhibitor ARB. ACE inhibitor ARB. Now we know ACE inhibitor ARB can prevent heart failure by preventing ventricular remodeling. Now we know the answer. So we can give ACE inhibitor ARB. We can prescribe spironolactone. But spironolactone, difficult side effect is painful gynecomastia. The side effect is painful gynecomastia. So in heart failure, preferred drug is the preferred drug. We have got the option of eplerenone. Eplerenone is the preferred drug in heart failure. These are aldosterone antagonists. These are aldosterone antagonist drugs. Aldosterone antagonist drugs. Genetic modulation, it is good in emergency, but long term it causes myocyte loss. So you want to prevent that myocyte loss. How to prevent myocyte loss? Let us see. By giving the supplements. By giving supplement. So what supplement is there? Omega-3 fatty acids. By giving the supplement omega-3 fatty acids, that is our fish oil, and B complex supplementation, micronutrient supplementation, especially thiamine reduces the rate of myocyte loss. Reduces the rate of myocyte loss. reduces the rate of myocyte loss. याद रखना. So genetic modulation long term में अच्छा नहीं है, long term में not good, because it will lead to loss of contractility, myocyte loss. So heart disease में you must give omega-3 fatty acid and micronutrient supplementation to prevent the myocyte loss. Cytokine can increase risk of arrhythmia. हमको नहीं चाहिए. You want to inhibit the cytokine. So we gave a trial of anti-TNF alpha agents. But anti-TNF alpha agents did not show success in clinical trial. But what is approved? We have written with gout. We have written with gout. We have got IL-6 antagonist, interleukin antagonist. We have got. Come on. Which is the agent we studied? Interleukin-1, approved for heart failure. I want you to remember gout, approved for heart failure. I want you to tell me. Which is the first biological approved for the management of heart failure? Okay, याद करिए. I have written it in when we discussed rheumatology. I want you to recall. Very good. Canakinumab. Very good. Canakinumab. We have got. It is the first biological. It is the first biological monoclonal antibody against interleukin-1 beta. Very good. Interleukin-1 beta, approved for prevention of heart failure. Approved for prevention of heart failure. Very good. Canakinumab. The first biological approved for the prevention of heart failure. So that is how you prevent heart failure. So remember, heart failure बीमारी नहीं है. Please याद रखिए सब लोग, है ना. Important point I am telling. Heart failure बीमारी नहीं है. Heart failure is the end point of cardiac disease. It is the end point of heart disease. So to prevent heart failure, we have got many choices. Along with the treatment of underlying cause, we have got many choices to prevent heart failure. But even if you get acute heart failure, you can control the symptoms. But unfortunately, once heart failure occurs, the cure is only heart transplant. So in majority of the cases, once heart failure occurs, the medical treatment, the medical therapy is usually palliative only. Palliative only. The only potential cure is to go for a transplant. Only potential cure is to go for a transplant, which is not yet freely available. And that is why the best treatment, 2 दिन में, over 2 days, we have understood lot about cardiology and the individual heart disease and their management. But end of the day, we have to remember, nothing can beat Ramdev Baba. Nothing can beat lifestyle modification. So once heart disease occurs, you can only wait for transplant to occur. So what is the best? Best is prevent the heart disease. Best is the prevention of heart disease. So how to prevent heart failure? To prevent heart failure, the best is to prevent heart disease. Heart disease ही नहीं है तो heart failure नहीं हो सकता, है ना. So the best thing to prevent heart failure is to prevent heart disease, and that is by lifestyle modification. By lifestyle modification. that is the ideal treatment to follow. मतलब कल से पढ़ो ना पढ़ो योगा शुरू करो, है ना. So even if you miss out on reading much, don't forget yoga. Gomutra is not part of any lifestyle modification. Don't stretch your imagination. People are stretching imagination. We don't want that. Yeah, we want to only focus on basic information. Yeah, so lifestyle modification. So this is our pathophysiology of heart failure and the various treatment options. So now you can understand. Heart failure को पहले बोलते थे neuroendocrine syndrome, we used to say. Neuroendocrine syndrome, we used to say. But now it is a complex clinical syndrome because there are multiple mechanisms involved in heart failure. Multiple mechanisms involved in heart failure. Okay, so you want to prevent them. These are all the preventive strategy for prevention of heart failure, right? So this is our end of theory class. So what we are going to do, we are going to start with the review of ECG and cardiology images. Loop diuretic is commonly not preferred because it is potent and can cause electrolyte imbalance. We usually don't use it long term, right? So let us go through ECG images and call it a day. चलिए, so एक बार हम देखते हैं कार्डियोलॉजी इमेजेस कहां से शुरू करें. यहां से शुरू करें. चलो, okay. So let us start with the cardiology images so that you can hopefully understand and revise. है ना, जो भी कुछ छूट गया है just message me. We'll try to put up the links on the Facebook. Okay. So not much छोटा छोटा syndrome के पीछे मत लगो, है ना. Focus on big picture. Small thing you can read. So first ECG. Come on, look at the first ECG. What does the first ECG tell you? First ECG you can see P wave is present. एक एक करके लिखता हूं, है ना. So first ECG shows you that P wave is present, है ना. यहां पर देखो P wave is present मतलब sinus rhythm. The P wave is present. Interpretation of ECG देखो, indicating that it is sinus rhythm. P wave is present indicating sinus rhythm. Next point देखते हैं. Each P wave is followed by QRS complex. Each P wave is followed by QRS complex and the PR interval is also constant and normal. Each P wave, that means AV nodal conduction is normal. AV nodal conduction is normal. तो प्रॉब्लम कहां पर है? If you calculate the rate, what you will see that you can see here the varying RR interval. The abnormality that you can see in the ECG, there is the varying RR interval. The varying RR interval. So this is A, B, C and D. Varying RR interval. So the only abnormality on the ECG is the varying RR interval. So this is the ECG of sinus arrhythmia. This is the ECG of sinus arrhythmia. Understand and write. This is the ECG of sinus arrhythmia. Sinus arrhythmia. Physiological change in the heart rate along with the respiration. There is also bradyarrhythmia. This is all given. Okay, this one may not be there. Otherwise, all others are given in the workbook also. Okay, come to the second one. यहाँ पर भी follow करते हैं second ECG. What we have done today, P wave is present. P wave is present. The P wave is present means it is sinus rhythm. P wave is present means it is sinus rhythm. Next, what you will see, every P wave is followed by the QRS complex. That means AV nodal conduction pathway is normal. But if you look closely, the PR interval is prolonged, constant hai. The PR interval is constant, but it is prolonged. PR interval is prolonged, increased PR interval is present, and that is why it is called as first degree AV block. This is our first degree AV block. Okay, first degree AV block. Sinus rhythm with prolonged PR interval. Okay, whether you have to write or not, that is your choice. These notes topics are already covered. If you want to write, you write. Just otherwise listen. You are looking at the image, listen, because you can always see in the recorded lecture. What we can see here, let us start with ECG. Always begin with the P wave. So P wave is present, P wave is present, P wave is present. But every P wave, is it followed by QRS complex? Let us see, this one is, but this one is not. So one of the P wave is not followed by the QRS complex. That means there is a missed beat is present. That means there is a missed beat is present. If missed beat is present, that means it is second degree AV block. Missed beat is present means it is second degree AV block. Second degree AV block. But which type of block we want to see? For that we see the PR interval is X. It becomes 2X. It becomes 3X with dropping of the beat. Resets to X, 2X, 3X and dropping of the beat. We have already studied this. So this is Mobitz type 1 Wenckebach's phenomena. This is the classical Wenckebach's phenomena. Mobitz type 1 second degree AV block. This is Wenckebach's phenomena. Mobitz type 1 second degree AV block, you can see, right? Next one, what we have got here, third degree AV block. Third degree AV block here. In third degree AV block, you can see there is no relation between the P and the QRS. AV dissociation. No relation between the P and the QRS. One P, यहाँ पर QRS is coming on before the P wave. यहाँ पर it is coming on top of the P wave. Here it is coming after the P wave. Here it is before the P wave. So no relation. This is called as AV dissociation. This is called as AV dissociation. Third degree heart block. It is the third degree heart block here, right? So that is our answer. Okay. Wide QRS hota hai because it is a ectopic pacemaker. It is a ectopic pacemaker, right? Let us go further. So coming to the first, tachyarrhythmia, PSVT. What do you see? Narrow QRS complex. So we are going to see narrow QRS complex. Tachycardia rate is more than 100 with regular RR interval. So you can see that the RR interval is regular, but it is rapid. It is paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia, we can say. What is the diagnosis? Come on, diagnose this ECG for me. Diagnose this ECG for me. Diagnose the ECG for me. What will we say? Narrow QRS. What can we see? Narrow QRS complex. But आप देखोगे लीड 2 में देखो, लॉन्ग लीड 2 में देखो, लॉन्ग लीड 2 क्या बता रहा है? irregular RR interval. Irregular RR interval बता रहा है. So narrow QRS means it is supraventricular, but there is going to be irregular RR interval. But what is there? ये देखो P wave present है. P wave present है. Arrow जहां जहां लगाया P wave present है. More than 3 different P wave morphology. This is an ECG of multifocal atrial tachycardia. Multifocal atrial tachycardia. Okay, 3 or more different P wave morphology. This is multifocal atrial tachycardia. Next one. What is this ECG show? There is again long lead 2 में देखो. Where will you look for arrhythmia? Long lead 2 में check करो for arrhythmias. Look for arrhythmias. Again, narrow QRS complex is there, which is having irregular RR, and there is absent P wave. Absent P wave. This is atrial fibrillation. This is our atrial fibrillation. Okay, so this is our atrial fibrillation. Very good, correct answer. Next one we have got VPC or VPB, ventricular premature complex. Okay, direct answer. ECG will not discuss here. Ventricular ECG premature complex or beat. Sorry. When you get VPC at regular intervals, when you get a VPC at regular intervals, so patient is getting VPC, every third beat is a VPC. Every third beat is a VPC. Then you call it as ventricular trigemin. Then we call it as ventricular trigemin. Every third beat is a VPC. We call it as ventricular trigemin. Very good. Ventricular trigemin. We can call this. Then the broad QRS complex is there. There is a broad QRS complex. Look in V1. There is a broad QRS complex. There is a broad QRS complex tachycardia more than 100 with regular RR interval. Regular RR interval. This is ventricular tachycardia. This is ventricular tachycardia. Ventricular tachycardia. Broad QRS tachycardia with regular RR interval. Ventricular tachycardia. What is this? So long V1 or V6 you see. Here you can see broad QRS complex with tachycardia, but the rate is irregular. There is a irregular RR, but there is presence of different pointed QRS complex. There is the presence of pointed QRS complex. This is our torsade de points. This is our torsade de points. Very good. Polymorphic ventricular tachycardia. Polymorphic ventricular tachycardia. That is torsade de points. We have got here the ventricular fibrillation. Heart rate is irregular, just random rhythm. You cannot identify extent of the QRS. You cannot identify extent of the QRS. There is just a fibrillatory baseline. This is called as ventricular fibrillation. Okay, which lead to look in. And usually for arrhythmias we prefer long lead 2. For arrhythmias we prefer long lead 2. For arrhythmias we prefer long lead 2. For ventricular arrhythmias, specifically for ventricular arrhythmias, you can also look at V1. You can look at V1 lead. You can also look at the V1 lead. Yes. So this is ventricular fibrillation. So first session today, we studied the topic of heart block, supraventricular and ventricular tachyarrhythmia. We studied. Next one, we studied valvular heart disease, mitral stenosis. There is commissural fibrosis. Mitral stenosis occurs due to commissural fibrosis of the valve leaflets. There is a commissural fibrosis of the valve leaflet. If the patient of mitral stenosis is severe, what procedure do you go for? You go for balloon mitral valvotomy. If the patient has severe mitral stenosis, heart failure or pregnancy, you will go for balloon mitral valvotomy. See how it is done. So you pass the catheter through the femoral into the right atrium. In the right atrium, you pierce the septum, enter the left atrium. Then you pass the catheter across the mitral valve and dilate the balloon. You pass the catheter across the mitral valve and dilate the balloon. So this is how balloon mitral valvotomy is performed. Balloon mitral valvotomy is performed. Coming to the topic cardiomyopathy. Tell me, suppose the first one is normal. Identify the rest for me. The first one is normal. Identify the rest for me. What is this? Dilated cardiomyopathy. What is this? Dilated cardiomyopathy. What is this? What is this one? Look at the septum. Asymmetrical septal hypertrophy. ASH. Asymmetrical septal hypertrophy. And this is our restrictive cardiomyopathy. This is our restrictive cardiomyopathy. Very good. So we have got normal heart, dilated cardiomyopathy, hypertrophic cardiomyopathy and restrictive cardiomyopathy. And the restrictive cardiomyopathy. Okay, this is what we have. The variant of restrictive cardiomyopathy is our ARVD, where the right ventricle is almost gone and the left ventricle is healthy. ARVD, right ventricle is almost gone and the right ventricle is totally fibrosed, left ventricle is healthy. So this is our arrhythmogenic right ventricular dysplasia. Arrhythmogenic right ventricular dysplasia comes with epsilon wave. Arrhythmogenic right ventricular dysplasia comes with epsilon wave, not Osborn wave. Osborn wave comes with hypothermia. This is epsilon wave due to the delayed RV contraction. We have got the ventriculography. This is normal coronary angiogram. This is a normal coronary angiogram. And the ventriculography reveals spade-like appearance. This is the spade-like appearance. The spade-like appearance of Yamaguchi's cardiomyopathy. Spade-like appearance of Yamaguchi's cardiomyopathy. It normal coronary angiogram with spade-like appearance on ventriculography. It is your Yamaguchi's cardiomyopathy. This is our Yamaguchi's cardiomyopathy. We must remember. The last one is your octopus on a Takatsubo. Once the octopus is gone inside, you will close the opening. So stress-induced cardiomyopathy 80% are women. The common feature, stunning, leads to heart failure, but they can also present as angina, which can mimic our myocardial infarction, So how does it look? During the diastole, the takatsubo, the ventricle appears like a open pouch. During the diastole, the ventricle appears like a open pouch. Ventricle appears like a open pouch. But when you do in the systole, what is happening? Apex does not contract. There is apical akinesia. Which leads to ballooning. Apical akinesia. Only lateral wall will contract. So in the systole, it gives the appearance of a octopus spot. Okay, apical akinesia leads to the ballooning, right? So this is what we have in our class today. So thank you so much, right? So all the best. I'm going to put up the post on the Facebook. So please post your doubts on the FB thread only. And we will follow it up, right? So I'm there to answer for you. Just don't stress, just read it step by step, and you will be able to complete your portion well in time. Okay, so just we want to be organized in how you learn, because there is lot of information that you all have to study, right? I understand that you have to study lot of information, so I want you to learn how to make concise notes. Okay, so you need to just make it clear what is essential and orient yourself to MCQ as well as practical application, right? So thank you so much. Good night, and we will see you soon in DVT. Okay, we will see you during the DVT. You can check on our videos. Chalo, all the best. Don't forget to see the clinical videos. Okay, if you are MBBS, still in your MBBS schedule, don't forget to log on and see the clinical videos. Tamil Kara Nichama Parango Namloda clinical videos path, you must learn for practical experience. Okay, so run away. Thank you so much. Good night.